diameter of a wire in a straight segment, the better will be the rail support and the torque, and it may allow vessel straightening, which may allow you to put sheaths in. The smaller the diameter, assuming it's the same material, gives us increased flexibility through the vessel and is less likely to induce kinks. Now, even though 014 sounds pretty close in size to 018, is it? Well, both the torqueability and the columnar shaft support of a wire are related to the fourth power of the radius of that wire. So that 018 wire in a straight segment has 2.73 times better torque and 2.73 times better columnar shaft support. It is substantially different, assuming it is made of the same material. This is comparing likes and likes. Now, we also have to consider the clinical situation. Tortuosity, you need more flexibility. Or if the lesion is just super critical, some of the bigger things may not be deliverable. Or if one is planning something like atherectomy, where you need small wire-based systems. Next, we need core tapers. So we start off with a wire being pretty thick in the back, but we make it flexible by creating grinds. And here you see taper 1, taper 2 on the bottom, grind 1, grind 2. And what we're doing here in the taper is we're taking a big wire and we're honing it down to a smaller size. What does that do? Well, you have great support when the wire is very big, but you have more flexibility as you grind the wire down. Now, we use these in different ways. If we have a broad, gradual, or a long taper, so the wire is very stiff in the back, but you have a really long area that's kind of soft that you've done a core grind down, then this allows us acute vessel access. It gives us better tracking down the vessel without wanting to prolapse. Therefore, the wire follows itself well around the bends. Abrupt or short tapers create support with a much shorter distance of wire in the vessel, but they have a tendency to prolapse when trying to go around curves. Now, you can see you would have advantages of each of these in certain circumstances. Now, we can look at this by looking at the charts that come with wires. And as you look at these, you must measure first, how far was this measured from the tip of the guide wire? And typically, this is done within a support catheter. And you can see support charts, and this will show you where the tapers are on these wires because it gives you an idea of the stiffness. It gets less stiff as you narrow this down. Next, and perhaps the most important thing as I look at wires is the tip design. As I said, I really want to get into super advanced tip designs in this later lecture, not today. But the predominant wires that we use in the peripheral space are quarter tip wires. Here you see the tip, it extends all the way out to the distal tip of the wire. This gives us better force of transmission. It gives us better steerability. It does give us tactile feedback because there is no cushion at the end. It's better for peripheral vessels and it tends to be more durable. In coronaries, we often use a wire that is not core to the tip and it has a shaping ribbon. And we use this because we often like to make exotic bends on these vessels. And typically when we're treating simply stenotic lesions, we don't have a lot of resistance. We're trying to feel our way through the vessel much more so than force our way through a vessel. These have easy tip shapeability. They're flexible and they're soft. They have the ability to prolapse if we need to, and they are indeed more delicate. Now, when people ask about penetration power, and they think this is some nebulous term, it is not. It is simply pressure. It's force per unit area. How do you increase that? You either increase the force or you decrease the cross-sectional area, just like you would do with a knife, like sharpening a knife. Why do you sharpen a knife? As the blade gets thinner, it's sharper because the same amount of force on the knife is going to then cut. Or if you make something pointy, it's going to penetrate. So penetration power is not difficult to understand. If I give you a very rigid wire, it's going to have more penetrance. If I sharpen the tip, it's going to have more penetrance. It's simply force per unit area. And this is typically measured in a wire, in a support catheter with a guide wire 1 to 2 centimeters back from the tip. Now, if I take that same support catheter and I bring it all the way out to the tip of that wire, I can dramatically increase tip penetrance. So when you have a tip penetrance, let's say of 12 grams, that is measured 1 or 2 centimeters back in a support catheter. If I simply take that support catheter and bring it up to the lesion, and I'm 1 millimeter away, all of a sudden tip penetrance is dramatically increased because you've given columnar support to that softer segment of the wire. Next, we have coils and covers. Now, these guide wire tip coils are very, very important. They affect support, steering, tracking, and visibility. And I cannot explain enough how important visibility is because you really want to see where you're going and you want to feel where you're going in many cases. These impact the dimensions of the wire and they clearly impact tactile feedback. These come in a wide variety. We can have outer coils throughout the entire tip, or we can have tip coils only. We can put sleeves over these. We can add hydrophilic polymers. We can do all sorts of things that affect these. And you must understand the characteristics of each and every wire that you use. I wrote for endovascular today in the past, a guideline basing on the basic tips of wires, and it was their most reprinted article that came out. I urge you to get it, to read those. I've not gone over all wires in that, but it gives you a rundown of most of the wires that we have. Now, many of you have heard of jacketed or sleeved wires. This is actually a jacket placed over the coils at the end of a wire. Now, what this does is it smooths the coils down and it diminishes friction. It diminishes friction. And if you make this jacket out of hydrophilic polymer, which attracts water, it's extraordinarily slippery. So if we look at decreasing resistance, hydrophilic polymer really decreases it. But if you have a jacket of hydrophilic polymer, since it covers up the coils, it makes it more slippery yet. These provide lubricity and give us smooth tracking through tortuosity. And these are not to be confused with just the coating, which does not hide the coils. Now, you can see we can mix and match these. We can have covers, we can have exposed coils. We can do this any way that we wish, trying to harness characteristics that we are looking for. And then finally, we have the coatings. The initial coatings used to diminish friction were hydrophobic coatings like Teflon. These repel water and they create a smooth wax-like surface. There's no actuation with water that's required, and these reduce friction and provide improved device trackability. But much lower coefficient of friction can be achieved with hydrophilic coatings. These have to be actuated. They have to attract water. They create a water-water interface, which gives the coefficient of friction of ice on wet, of an ice skate on wet ice. And we all know how low a coefficient of friction that is. This becomes very powerful in lowering resistance. But these are mucopolysaccharides, and they're sticky. So if you're trying to do exchange with these wires and you do not keep them wet, the catheter in your finger, which is wet, well, the wire in your finger, which is wet, will pull right out of the body. So you have to always be careful of keeping these wires very wet. So everything with wires is a trade-off. The more lubricious we make a wire, the more it will go through, the better it will cross total occlusions, but the less tactile feedback we will get. So we really want to use very low lubricity in stenotic lesions, very high lubricity in total occlusions and densely calcific lesions. Now, coils impact visibility. Platinum, palladium, tungsten, and stainless steel are all used. Now, how well we can see these is affected by two things: how thick is the material, in other words, the durometer of the material, and also the density of the metal being used. Platinum is the most radiopaque, assuming you're using the same amount, but if you double up the amounts of the other things, you may achieve similar functions, and stainless steel is the least visible. And the length of the radiopaque coil matters. Now, how we shape a wire also matters. We talked about penetrance, but anytime we put a bend on a wire, we lose some penetrance. The greater that bend, the more penetrance we lose because of vector forces. So if we want to penetrate a total occlusion, we want a straight or a small angle at the very tip of the catheter. This gives us greater tip penetrance. If we want to navigate tortuosity, we can add a secondary bend. This allows us to steer more effectively. And if we wish to cross subintimally, we can deliberately create a J. And this allows us, especially if we can control the shape of the J, which we can with some of the new wires, which are created to give us control length prolapsed wires, then we can cross subintimally. How do guide wires fail to cross? Well, the wire tip may prolapse at the cap. And if that happens, we can use a wire with a higher tip gram load. That's more likely to penetrate. Or we can use a sharp, short angle. Or we can take a support catheter and bring it all the way up to this lesion, and that will increase the penetrance of that first wire that you started with. Or the proximal segment crosses, but the tip and then the segment buckles after the tip is crossed. Well, once again, you could use a wire with a higher tip gram load, or use a hydrophilic coating, which will slide through better this lesion. Or you can advance a support catheter to the tip to help push the wire across. Or the tip enters the lesion, but the wire fails to follow. You can use a wire with a higher rail support, lower profile, a wire, an 014, an 018 instead of an 035. Go to a hydrophilic wire, which will slide through easily, or advance a support catheter to this point. Each and every one of those factors affect how your wire performs. Or the wire crosses, but the device fails to cross. Well, you can use a wire with a higher rail support or go to a lower profile system. It's really this simple as one works their way through these cases. Keys to success or wire escalation approach. Use your safest wires first and change as needed, but always have in your mind's eye, where's my problem going to lie? Which wire must I choose? Frequent wire exchanges if necessary. If you're working away at a very long total occlusion and you've worked for 20 minutes and you're getting nowhere, go to a different wire. Don't waste another 20 minutes. You're not getting where you want. Wire selection for penetrating the cap versus navigating the middle of the cap versus device delivery may be different. You must be patient. You must realize, where am I encountering a problem at each step? And then you address those. Shaping of the tip is crucial. And luckily now, some companies are starting to make preset curves for us at the factory, which are often more accurate than the curves that we can achieve. And use a support catheter. I view it equally important as the wire in treating. Also, access matters. Why? Access can affect push, torque, reach, and support. Integrate access when doing a femoral approach gives you a straight line versus contralateral, where you lose some torque and where you lose some push. It allows us to visualize things such as hibernating vessels and allows us to get closer to the site to be imaged. So often when we see infrapopliteal occlusions, if we stick a pedal vessel and inject retrograde, the occlusion is far shorter than we had envisioned angiographically. And this allows us to minimize contrast usage. And often it allows us to approach the softer cap or to avoid collateral vessels or a geometrically more approachable distal cap. So treating complex lesions can be challenging. Wires can fail in a lot of ways, and you have to understand those. And one of those ways is that they can injure distally. And if I see one thing that is very important thing to work with fellows is to make sure you know where that tip of the wire is at all times and that it is doing no harm. You must be familiar with a multitude of wires, particularly world-class new wires. This field has changed dramatically because of wires, and it's what's turned us into frequent failure into almost never failure. Understanding wire technical attributes will help you perform. Non-wire factors affect wire success. And on Friday, I'm going to have a session where we will talk about some of the newer advancements in wires, which I think you should familiarize yourself with. So with that, I'd like to introduce our next speakers for the next session. Can you guys come up here and we'll get started? So we got a little head start on this meeting. Any questions for me as people are coming up? Okay, Mac, you coming up? Mac's going to be heading this part, and I'm going to run out to the business session. I will be back with you this afternoon. And by the way, this afternoon at the end of this, we're going to have a Meet the Titans session, and many of the industry leaders, the presidents and heads of the major companies throughout the country, world thought leaders will be here. I urge all of you to do that. First, you're going to get a little free booze, and there's never anything wrong with that. But on top of that, it's going to be awful nice. You're going to meet some very interesting people who are really helping to change the world. Next, it's my pleasure to introduce Dr. Mac Ansari, great friend. And Mac, I'll have you head the rest of this session.
I think they have a workshop. So thank you very much, Dr. Walker. So Dr. Walker has been a mentor to generations of interventional cardiologists. And literally it's a turf battle that started in the United States when we talk about peripheral intervention. And it's a great contribution that he did in our field, really making it happen for all of us to be able to do these things. So right now, I think there's a rotation schedule. So you all have your groups listed with you. The rotation one is going to be the groups as listed over here. And I think this is going to go on from till now till 8:30 when we will resume our lecture series. So please look at your groups assigned, and these are the rotation booths over here. And what I really want you all to do is this, that some of the devices will be present in your lab and some of the devices will be not. The most important thing is wherever you guys go, these will be the devices available to you or a chance for you to get. So make yourself familiar with these devices. The whole concept of this workshop is a hands-on approach for you to put your hands on, lay your hands on, look at these devices, feel these devices and see how they function and ask as many questions as possible. The whole goal is for you to understand what's going on with these devices and how their approach in the body. All right, please go ahead to your rotations and we'll resume again at 8:30 for the next lecture. Thank you. This becomes such a bad weekend. I can't even explain to you words. It's such a huge loss. We have no idea. This is the guy who actually like for people like our son and these idiots that I'm stuck with.
How are you doing? Nice to see you. Hi, Stephen. Pleasure to meet you. Yeah.
How's everything?
Going well. Going well, yeah.
So for people, it's Dr. Walker's favorite, and actually one of the main life courses and the main angle of this department was extremely hard. So we actually came from Pennsylvania down to and literally started this scratch.
I did start first. It's true. For 4 straight.
It's a big.
Yeah. When you're gonna,
Yeah, I'm gonna
start the session? I kind of saw you guys in the first vision when I drove in yesterday. You guys were getting in the car. I didn't stop you because you were already in. You guys were going to dinner last night, huh? Yeah. Good. I went with Chief, yeah. Good. Yeah, she's Indian, right? Yeah. So I met her. All right, if I can have everybody's attention, if they can return to your seats so we can start the next session. Can I have my slides, please? So this is a really interesting course where didactics are going to be parallel matched with these intense workshops in the middle. And it's just important to utilize all your time over here that you can. And these breaks will also allow you to rejuvenate yourself. Because what used to happen when we were fellows, there were no breaks like this. We just used to have didactic sessions one after the other. And by the time we end towards the later part of the day, it was like extremely boring. So hope this would interest you guys. So the topic assigned to me was on peripheral arterial disease, patients for interventional, which patients you can go for interventional therapy, and the tools on toys and the program development. My disclosures. So we all know that PAD prevalence is worldwide, and it's 3 to 12%, 27 million individuals. That's those that we know have PAD. For the fellows, particularly the symptoms, the only thing I want you to guys to recall this, 50% of those are asymptomatic initially, and the symptoms of PAD can just be as simple as calf pain or buttock pain. So you want to remember that, and then it goes on to have this extreme form. So the scope of disease is enormous. And why it is important to understand that, because the risk factors are same as coronary artery disease, but the diagnosis is really simple. It starts with a basic ABI. And when I started at Texas Tech, I saw many fellows over there, when they would examine a patient in the clinic, they would ask questions regarding chest pain, but nobody would ask questions regarding leg pain. And a simple screening tool can lead you to the diagnosis, and then you go on to do the ultrasound and the angiography, which can tell you what's going on. Now, everybody talks about lifestyle modification and diet, But in my state of Texas, when the patient is present in the room, if I talk about lifestyle modification, which we still do, the patients tend to get upset because everybody in the state of Texas like their nice, elaborate steak and the steakhouses that they go to. Now, the recommendations for exercise is at least 30 minutes for 5 days, or at least 25 minutes for 3 days. So let me tell you, I treat PAD. I have 2 gym memberships. And the last 3 years, I have been there only once. So if it's something which is not possible for me to do, how would I ask that for my patient to do? Yet we still do talk about that, but we have to have a realistic approach, how realistic it is to do this. So we talked about the definition and prevalence, and yes, 6% of Americans over 40 years of age, and the high-risk population is diabetes, hypertension, CAD, and that's like almost all our patients. I told you the risk factors, it's very similar, but the clinical presentation from classic claudication to the nearly 50% asymptomatic people, that's the ones you want to remember to go into. So the role of exercise, yes, it has skeletal muscle metabolism, endothelial function, gait biomechanics, but how many of people will be really able to do that? That's the question, right? So when we talk about medical management of these diseases, you improve symptoms, your quality of life, you could do the same things that we do in coronary artery disease, and the adherence to guideline recommended medical therapy works. But compliance is a major issue in majority of our patients, and the disease just gets worse. The only medication, the few medications like cilostazol, ACE inhibitors, statins, and antiplatelet therapy, they do make a difference, but to a certain point, when disease is in its advanced stage, it's important to have these medications on. But yes, there comes a point that you got to intervene. So if you go to all these conferences to talk about just exercise therapy and medical management, it doesn't affect the patient to the level that the disease can be solved on its own. And that's where endovascular therapy becomes a part. But to treat PAD and CLI, it's not just an individual approach that you can just go on and treat the patient. It's a whole team approach to CLI. So when we talk about program development and when we talk about approaching a patient of PAD CLI, you have to remember it's not just the lab and the toolbox and the devices that you have to know and understand and the procedures that you have to do, but it's also the follow-up and the treatment strategy and the plan to have our entire village look into that. And this is the village, the wound care, the podiatrist, infectious disease, endocrinologist for the diabetes, the primary care, nutritional aspect. You work together with our vascular surgeons, and these are the entire components of our entire village, what we call. And yes, what are the equipment? You know, we used to start with basic wires to these specialized wires that Dr. Walker talked about. And these are the toolbox you want to have in your arena when you're treating these patients, the different kind of catheters, the different kind of closure devices, sheets, and different kinds of stents for different territories, whether it is the iliac or above the knee, or nowadays we're studying stents below the knee, covered versus non-covered, and devices which range from atherectomy devices, various kinds of atherectomy devices to thrombectomy devices for all those clot and calcification to handle that. And a proper lab would be a lab because most of these devices are important and every device has its place in different treatment modalities that we approach in our patient. We range from drug-coated balloons to different kinds of drug-coated balloons to different kinds of crossing catheters. We utilize different kinds of tip surveys to different kinds of balloons which utilize for dilatation, whether it is scoring balloons or whether it is drug-coated balloons or whether it is sculpting balloons. And how we utilize all this is just an example to give, because this is a patient who's 52-year-old female with Takayasu syndrome. She's high risk for surgery, so that's just out of the question. And if this patient presents with you with complete blockage, that there's no flow going down because of the severe Takayasu, what options do you have in this patient? So this is a patient with the surgeon wouldn't touch because high risk for anesthesia. And when we went in, that's only what you have, no flow, just a dissection plane. You utilize your devices, you cross through. After crossing through one side, you deploy a stent. After deploying the stent, you make your way to the other side and then completely block up the side. You see the beaded appearance of Takayasu, and you were able to stent that. And this 55-year-old patient that was supposed to go to hospice was treated, a mother of 4, and was discharged home. So case after case, there are multiple such examples. And this is the final result on this patient who was supposed to go to hospice because of the lack of flow. So these are the specialized techniques that were utilized in this case. Similarly,
You have to be well equipped with utilizing any territory that you can go in for, whether it is pedal approach or radial approach. Nowadays, there's also radial interventions that we are doing. And there are many cases we successfully do. Now look at this other case. What is missing over here is half of the aorta. So when we talk about endovascular approach, patient is high risk for surgery. The surgeon's not going to touch the patient. So what options does this patient has? So similarly, we went in from above and below and created the new carina. Case after case, this is a patient who had surgery in the past and now is going for over here with complete blockage on both the sides. And we went in and we fixed one side and then went on to the other and treat the patient. Case after case, if you read, what if about the focal stenosis and calcified stenosis in the SFA? What small focal stenosis hindering flow to put a graft in the patient? You know, all the data that we have, or we talk about different kinds of trials being done, do they take into consideration what are the effects of the graft placement and later how much they would be varied? We talked about one in a CLI Global Society meeting about those. We're doing atherectomy, making way from the calcium, and then go on to have the flow restored. And this is your final result. So case after case, if you could see how are you going to approach this patient that has complete peripheral vascular blockage? You talk about from the axillary artery to the radial artery to the popliteal artery and to the tibia, one after the other. And we opened from the popliteal way up to the axillary artery and restored flow in the patient. On the right picture, it shows how we even went down to open the tibia, what I call complete body aspect. So what I'm trying to say that when people talk about aspects of the disease, there are many patients that you will come across. They are not only just patients for endovascular intervention, but depend on that because there is no other option as well for those patients. So your program not only requires you to have interventional therapies available, but a complete village approach. And that's when we talk about program development. This is what we were able to do in Texas Tech University Health Sciences Center, come up with a center of excellence with a goal to collaborate between multidisciplinary physicians to come across one table, 30 different physicians from 15 specialties to come across, make a PAD center. And our motto was save a limb and save a life, because yes, CLI is a deadly disease. Patients with CLI die. It is important to utilize that. And these are the components of our Center of Excellence. So what you have to focus on when you go out and work, it's not just you treating a patient. You're treating an entire disease, and you have to come up with a program approach, a village approach to this disease. So you have to understand not only the patients that need intervention, but what your tools are available. And the things that I want to leave the fellow is few very important things, because remember, when you are working, you are being watched. So failure to plan is you're planning to fail. So you have to visit the lab, meet the people over there. These are the different people that will be responsible of running things with you. You have to understand that. But what are your staff? What is your best nurse? What are your best tech? What is your radiation tech? What's your holding area? What's your post care? How are the people trained in this area? So these are the people that you want to remember. And then you have to build your own team, your regular team, your high-risk team, and your team for different kind of devices. I also have my best tech for different things, which I scrub in with them. And then your own network, your support network, your boss, your strong guy, you pair up with individuals who you can collaborate with and who can help you cover and run your show. And then the referral pattern that you have to very important remember, those outreach meetings, the wound care, the podiatrists, the diabetic people, your surgeons, your internal medicine, and your hospitalist physicians. So the entire program development not only goes on for the interventional aspect of it, but also the training, outreach, and education, educating your team, educating your physicians, not only just patients, but your physicians as well. And then you come up with different programs, and you come up with the different characters of this program. For example, your rescue initiative. If you get in trouble, what are the devices? What are the backup? What is the documentation for those? And how are you going to manage through complications? So these are very important aspects that during fellowship, you do not learn. And then you're thrown into this world where you're supposed to learn as you swim in the ocean. But these are very important things to make algorithms in your mind to carry on, to navigate to these things. So it's very important you understand what are the toys that you are used to, that you have hands-on to, and are available in the labs that you go. So your focus should always be the right thing. You should be aware of what's going on, but the right thing, the right device, and the documentation. And one thing which will always lead you to win is your teamwork. You built a program, you built a referral network, you built relationships, and then you go on with that with your support network. And in the end, remember, with entire patient care manifesto that we follow, there is something called personal care. So you have to be aware of the issues that can come across and the plan that you take care of those issues. If any questions, please let me know. Thank you. So with that said, I'm going to invite our next speaker. Our next speaker is going to talk about femoral artery access techniques, antegrade, retrograde, contralateral, and direct stent puncture, Dr. Justin Price. And Price is going to be our incoming fellow after a year at Texas Tech University Health Sciences Center for Interventional Cardiology. Please welcome Justin Price.
Thank you, everyone, and welcome to one of the best conferences you'll ever be to. And please come in the years to come, because this is the nation's best right here. So I'm practicing out of East Texas. I don't have any disclosures here. We're going to talk about femoral access. So you have to be comfortable with femoral access. There's a big push with radial access between cardiologists. That's great. You have to be an expert in femoral access, and sometimes it's not so easy, as you saw from the prior presentation. So the frequency of femoral access or peripheral intervention is going up, large bore access, and the setup is going to be key for this. And we're going to talk about a lot of this. So you cannot deliver therapy if you can't get there. So in part A is going to be the crossover approach. Many of this people are most commonly from this. You go from one side to go up and over. B is an ipsilateral approach or an antegrade approach. Part C is when you go retrograde, which is very commonly. Brachial approach is going to be discussed in another talk. So this is ideally what you're set up here. This is a micropuncture. You use your landmarks here of the femoral head. You got your superior border of the lateral circumflex artery, and then you have the bifurcation of the profunda and the SFA. This is done through a microcatheter without a wire in it. This is how I was trained. Some people don't like this from the risk that you could either A, lose wire access, or B, you could dissect whenever you inject too hard. So there's a way around this. So you can use your needle, get your wire in there. You can go ahead and place your microsheath, and then you can just put this hemostatic valve here through the back of it. You maintain wire access, and through the side port, you can do your injection. All right, just make sure that you have good pressure waves whenever you're doing that. So that's an idea. If you're ever having trouble in there, or if you're worried about having that, that's a little extra technique, just, tips and tricks of the trade as you're going along. As you're doing a peripheral angiogram, start at the top. Do the aortoiliac. Don't skip segments, and perform angiogram of the disease segments in multiple planes. Ideally, you want to do both sides. You may need to do an intervention on the other side in the future. Try to avoid a panning shot where you take a shot from the hips and shoot all the way down to your feet. It makes me dizzy. All right. Try to do individualized segment shots of everything. Always include the foot. You have no idea how many leaders in this world do not shoot the foot. You have to shoot the foot first before you do anything else. All right. If you have to have that prior to your intervention, and then you have to do it post. You need to know that you still have flow in the foot before you're done. Catheters to do this, whatever you like. An IM catheter, multi-purpose, OmniFlush, whatever dealer of choice. We're going to talk about some special considerations here because, again, it's not always so easy. You've heard this 1,000 times. Don't push against resistance. You either lost vascular access, you're in a side branch, you're in a tortuous vessel, you're in a dissection plane, the vessel could be occluded. Don't push against this and cause a complication. We're in Southern Louisiana. Not everybody's going to be skinny. You can't always use your bony landmarks the best you can, but get the setup is key. Tape up the pannus. All right. Your typical micropuncture is going to be about 7 centimeters long. That may not be enough if you have enough adipose tissue in the angulation. Use a long micro if you need it. All right. We also have stiff micropuncture sheath that you can get through enough adipose tissue. There's also the Sheba needle. It's 15 centimeters. It's a biopsy needle, but it will get you where you need to go. So these are just extra tools. Keep that in mind for whenever you're dealing with tortuous vessels or adipose tissue. You never want to see a bent wire. This is a never go. You don't want to create a Z-track where you're in multiple tissue planes. You're pushing against tissue there and you're bending your wire. Then you're going to lose wire access. You don't want this. Use stiffer wires. Again, the setup is key. Talked about these already, the pannus, depth of the artery. Use your ultrasound. Find out how deep you need to go. If your needle is already hubbed and you're only supposed to go X amount of far with the ultrasound, then you've done it wrong. Back out, change your angle. Use your ultrasound to know how far the artery depth is. Maintain your needle angle. Again, avoid the Z-tracks. You don't bend wires. Use stiffer 035 wires if you need. And you can use serial dilations to get you where you need to go. If you want to go to a 6 French, start at a 4, dilate up to a 5, and then to a 6. Okay, tortuous vessels, a lot of these, you're going to see it all the time. Again, if you hit resistance, switch over. Dr. Walker talked to you a lot about wires already. Switch over to a hydrophilic wire. Sometimes you can navigate somewhere else that you need to go. Use a long sheath after you've crossed that tortuous region so you don't have to continue to recross it. Also, sometimes it will straighten out the vessel when you do that. All right, if you're having difficulties going up with a wire, you could be subintimal. Stop, take an angio, take a look and see where is your wire. Again, tortuous aortas, you can use a stiffer wire. Sometimes that straightens out the vessel so you're able to deliver your therapy. I'm going to talk about two techniques that can help you here as well. One is called balloon-assisted tracking or BAT, and there's what we call a mother and child technique. On the left side here in the BAT technique, figure A shows you what we call the razor effect whenever your catheter digs into the wall. Okay, this can cause dissections, you can embolize calcium plaque. So you want to get that catheter off of the sidewall. One of the ways you do that is you put up a balloon, doesn't matter the size, low pressure, and effectively you're just getting the tip of the catheter off of that wall and you're able to create a rail system over your wire then so you're not digging and scraping along the way. And that's called balloon-assisted tracking. Mother and child is very similar, in which case you have a 6 French guide system, you have a wire down, you put a 4 French guiding catheter inside of it that's longer. So in other words, you basically have a telescoping effect, or what we call mother and child. So the 4 French catheter leads, 6 goes after it, you get where you need to go, you pull out your 4 French, and now you're ready to go. So 2 trips to get you through tortuous and kind of diseased areas. Integrate access, again, you're just flipping under the 180 things. You still use the same landmarks, just instead of sticking retrograde, you're sticking antegrade. This can be difficult. Sometimes the wire goes into the profunda artery. It's okay, take it, put your sheath down, then slowly pull it back, put a second wire down into the SFA. You can direct this either under fluoro or under ultrasound. Get your wire into the SFA, then you pull the profunda wire out, sheath it, and now you have an antegrade access. You can also do a retrograde to antegrade flip, in which case you purposely get retrograde access. Put in an SOS catheter or an OmniFlush. So you have your sheath in, you have your catheter, you retract the entire system out to where the tip of the catheter is barely in the artery. You wire down into the SFA. Then you advance the catheter over it, and then you flip the axis of your sheath into an antegrade position, and now you have antegrade access. So another trick here, if you're having difficulties trying to get into this, particularly with the obese population, can be difficult to do this. Don't forget about braided sheaths. They're flexible, they're kink resistant, they're radiopaque, so they're very helpful in certain cases, can help with the retrograde to antegrade conversion. And also don't forget about these if you're an interventionalist putting in impellers. This can also help as a distal perfusion catheter. It won't kink, so that's nice to have. We're going to talk about direct stink puncture quickly. This is if you have a proximal cap that's very difficult to cross. This is kind of more of a bailout type strategy. This is showing kind of a pre and post left SFA lesion with multiple layers of stent. We're going to walk through this slowly with one of my colleagues' videos here. This is in a right SFA lesion, multiple layers of stent. So this is going to be an LAO projection. You're trying to line this up under fluoro where you put your needle right into the middle. We have a center puncture of this. All right. Under fluoro. Now your next shot in multiple projections. Remember, whenever you have a lesion, you want it in multiple different planes. Now you flip it over to an LAO projection so that your needle had gone through and through, and all you're going to do is slowly pull it back into the lumen. So now that you know in 2 planes that you're in the lumen. From there, you're able to wire up in a retrograde fashion, and now you've obtained access through a direct stent puncture. From there, you're able to externalize your wire from your retrograde access there, and you can deliver your therapies. So goals for the fellows course: learn all you can. It's overwhelming. The great part of this is you get to come multiple times, years to come. Get to know the industry and the devices, the medications, the reps, everyone here. Wherever you're going in the future, let them know, because they will look out for you and call their colleagues and be ready there for you. The other part is the network. That's part of this conference. You need to get to know at least 3 new people. You need to at least walk out of here with 1 staff number, a fellow number, at least 3 people, because in the PAD world, everything's a small world, and they'll help you out in your career and the way to go. So that's one other goal for you. All right, enjoy the course.
Thank you, Justin. Yeah, that's a really nice advice. You know, we used to say this, that if you go to every conference, one of the aims should be to at least know 3 new people. One should be an attending, one should be another fellow, and one should be a rep. So this way you could stay in touch with them. Our next speaker I'm going to invite is now Douglas Rhyme. He's going to talk about radial access, brachial access, and pedal access.
Good morning, everybody. As you said, my name is Doug Ream. I'm one of Dr. Walker's endovascular fellows and interventional cardiologist. with CIS. This is my one disclosure. So why do we use these alternative access points? Dr. Price just gave you a good lecture on CFA. So you guys probably deal with this quite a bit already, but area of infection, whether it's yeast infection, cellulitis, you can specifically see these in unkept morbidly obese patients with a large pannus. That in itself kind of lends difficulty with access and hemostasis. And then on the other end of the spectrum, you have very thin patients, which add another component of morbidity in terms of bleeding. And then anytime patients had a prior growing complication, so whether it was a left heart cath, peripheral procedure, anything they may have had, you want to kind of figure out, why that area had issues after, and really think about using it again. It's also for patient comfort in terms of patients being unable to lie flat. Pedal access is going to be a very good thing for these patients. You can put a little extra, pillow or something under that may prohibit the other access sites. Obviously, if you're doing planned bilateral peripheral interventions, you're unable to go just standard CFA, up and over retrograde access. And then iliac tortuosity is a big one too. Justin gave some good techniques and tips to deal with that. But as you can see on this reconstructed CT on your right, with every bend and turn you have in those iliacs, you're going to take away some pushability and torqueability of your equipment, even if you are able to navigate that area. So anytime you're pushing that, you also risk dissection or even worse, perforation in this area. And then these are some other contraindications, common iliac stents that extend up in the aorta, which you can see in this picture. Even if they are right at the ostium, sometimes you're still able to navigate that with some of those techniques that Dr. Price mentioned, but you really want to be careful when you're doing so, because the last thing you want to do is invaginate or malform the ostium of those stents and cause yourself a whole nother procedure or a whole nother headache, when you finish treating your targeted area. And then lastly, patients with aortofem bypass and prior EVARs are also contraindicated. So in terms of procedure planning, this is one of the biggest things you should be thinking about, going out on your own or when you're starting these procedures. In terms of non-invasive testing, an arterial duplex is, you usually have that at least to kind of assess. And you're not only looking at the areas of stenosis and where you want to treat, but you also want to look at your vessel sizing to see what access sites may be possible. CTAs offer you, a good layout of everything and helping you target those areas. And then they also help you really assess that iliac anatomy to see if retrograde access is a possibility, or do you have to go, tibiopedal, popliteal, radial, whatever it may be. And then from there, you determine where you're going to go, whether it's retrograde, antegrade, or radial, pedal, a combination of radial and pedal, or brachial. If you're not comfortable with ultrasound at this point, you really should start using that as much as physically possible. This is a nice normal vessel, and you want to look for that vessel pulsation, the vessel compressibility in case you have issues with your closure device. The sizing is a big thing, and then closure technique. And get used to looking at these in the long axis as well. This is something I didn't do too much as an interventional fellow, but working with our team this year, our ultrasound team and our nurses and techs, it's really helped me kind of develop my skills in terms of access and safely, advancing wires. This is kind of contrasting images. Again, that nice normal vessel on the left with compressibility, nice pulsation. And then on the right, you pretty much see over 180-degree arc of dense calcium there. And, the reason you want to scan up and down this vessel, especially when you see something like this, because it could be the difference of a couple millimeters, which, make your great procedure a great procedure, or, a great procedure that has a good result, a bad procedure at the end. So this is obviously, CFA, profunda anatomy, but this applies to all vascular beds, including radial pedal. Again, you want to be looking at these in the short axis, the long axis, to kind of see what you're dealing with. So you start by identifying your vessel, in this case, the cross section of the SFA profunda. You scan back to look at the CFA, and then you image in long axis as well. So this is an EVIS wire advancement. As you can see, that wire wants to take the profunda, and then just with a little manipulation and with your needle or your wire, you're able to safely target that or advance that down the desired vessel. So when do you spare the CFA and access the radial? So most diagnostic peripheral angiograms can be done from this. Most mesenteric, celiac, and renal interventions can be done from the radial. Some 6 to 7 French sheath compatible aortoiliacs can also be done from the radial. Common femoral and profunda proximal can be done from the radial. Anything that's 5 to 7 French sheath compatible in the prox SFA can. And then, almost all balloon angioplasty in the SFA pop and some tibial lesions can as well. So I got this, Dr. Fadi Saab had this in the lecture when I was a fellow a couple of years ago in your position. And I think it's good to know in terms of your procedure planning, knowing your sheath length. And you can see these are the distances. This patient they had in their lab was about 5'9", and they mapped these out. And as you can see, 120 centimeters or 140 centimeters. And this is going to help you pick in your sheath size, your balloon shaft lengths, anything that you may be using, atherectomy devices to see how far, you may or may not be able to reach. Just to note, there's about a 10 centimeter difference going left radial over right radial when accessing these sites. So you're going to get a little further reach when going left radial. So radial and brachial access, for those of you that aren't too familiar with it, current technology is also always catching up in terms of wires, atherectomy devices, support catheters, and more technologies being really developed every day. I'm sure there's going to be a lot more talks. This is a lot of this stuff is a talk in itself, but there's going to be a lot more talks on this throughout the week. And then, like the radial access, obviously achieving brachial access, you're going to get about 15 to 20 centimeters further than you would from the radial. So some of the challenges, obviously, brachial access, one of the biggest knocks on it, it could be difficult to achieve hemostasis. You can have radial artery occlusion, so, pretty standard, but using your radial cocktails, every case. Tortuous aortoanominate subclavian anatomy. So type 3 arches are pretty much a contraindication to doing brachial or radial access. And then patient height. Obviously, the taller the patient, the less reachability you're going to get with devices. So in terms of tibiopedal access, this is something you should always be thinking about as well. It's a safe technique. It gives you an option to interrogate a convex cap, which prevents subintimal crossing. And you can use these for, simple non-CTO interventions as well. Again, you really got to be facile with extravascular ultrasound with this and have the optimal equipment to do so. This is a good example. Again, this is from Dr. Saab's lecture, but I just thought it was a great image. So you're pulling back, you can see that radiopaque needle releasing that posterior wall right now. And then that wire's safely advanced up the tibiopedal vessel. One of the things that how I've gotten a lot better with this is our superficial vein interventions that we do. So whether it's with foam sclerotherapy, RF, getting access in these can help, and get comfortable accessing and short access is usually how I like to start, and then going to a long access. Or if you're comfortable just going from a long access, that can be very, very beneficial in accessing some of these vessels. This is another example. There's a support catheter down there in the distal PT. And then you can see this wire is able to be manipulated to get into that catheter and get to the desired position. Again, with practice and imaging, get down. If you have the opportunity to have your ultrasound techs in the room, that's fantastic. If you don't, try and get down to down to radiology or ultrasound and work with them as much as possible to try to get comfortable and at least seeing these images, which will help a lot with your access. And you can even do it in diseased or even occluded tibial vessels. So you're obviously, if it's occluded, you may not get, the bleed back that you desire when you stick with your needle. But you can see you have a good image here, the radiopaque needle, and then this wire is advanced slowly and safely under ultrasound guidance. This also limits dye and radiation during your procedure, the more you're able to get comfortable with and the more you're able to do this. But there's, kind of no such thing as free lunch. So you just don't want to go sticking around down there. You want to be comfortable with your ultrasound images. You can have dissections, perforations, hematomas. These can lead to compartment syndrome, which can, add a whole level of morbidity and mortality to a patient. Pseudoaneurysms and AV fistula, and then as well as embolization. I'll stop there. For anyone interested, just a quick plug. If anyone's interested in advancing their peripheral training and doing working with Dr. Walker, I'm more than happy to answer any questions, whether it's this year, next year, in the future. More than happy to answer any questions. It's been an incredible year. And there's my email if you think of anything down the line.
Thank you, Douglas. Thank you. So one very important thing that he mentioned, that you could do a great case, but anything goes wrong with the groin axis or any axis, that's what the patient is going to remember. Patient is not going to remember that $1 million rescue that you did. They're going to remember the bruise and the problem that happened with the groin. And the number one issue that cardiologists that are sued, according to the surveys I got, or the 65% individuals who switch job in the first 2 years, is actually access-related complications. So remember, access is extremely important. Your whole case depends on the planning of the access and the closure, because it just helps for the patient to understand what you did, because that's the thing they're going to see. So with that, we're going to move forward to the next set of rotation, the workshop rotation 3 and 4. So please, everybody, just look at their badges and groups and then move on to your rotation schedule, and we'll reconvene at 9:40 for the next didactic session. Thank you. All right, everybody, the rotations are done and we're going to start our next session. So just for the sake of staying on time, I'm going to go ahead. I'm going to invite my next speaker. Dr. Arun Gopal is going to talk about optimizing angiography in peripheral arterial disease and when to use IVUS. Dr. Gopal.
Let's get started now. Oh, okay. All right. So I'm going to be talking about optimizing angiography through the use of IVUS. And we're going to be focusing primarily on arterial IVUS because there's going to be a separate talk dedicated to IVUS in central venous disease. But just as an introduction, my name is Arun Gopal. I'm one of the PVD fellows here at the Cardiovascular Institute of the South. And I have no relevant disclosures for this talk. So as we all know, angiography is limited. You know, when we perform angiography, we're really performing luminography, and we're not getting too much information outside of that. So it tends to severely underestimate the extent of disease in patients with PAD, even in vessels that look like they're normal. And so that's why IVUS can be such a helpful adjunctive tool, because it provides additional information regarding not only the plaque structure and morphology, but also vessel sizing, among other things, which we'll talk about. And the principle of IVUS imaging is it's based on the oscillatory movement of a piezoelectric crystal, which is the transducer, and it produces sound waves when it's electrically excited. And those sound waves traverse through different tissue based on its acoustic property and then reflects back to the transducer to produce an image. And there are two major types of IVUS catheters. There's this mechanical single element rotating device, and then there's a solid state or phased array device. And the mechanical rotating device, it uses a single piezoelectric transducer with a mechanical rotating element that rotates about 1,800 times a minute. In order to produce that 360-degree image. The phased array device is a little bit more complex, because it involves multiple transducers that are stationary, but they're sequentially activated in order to produce that same image. And there are kind of pros and cons with the two subsets. With the mechanical IVUS, because you have the drive shaft that causes the rotation, the setup can be a little bit more cumbersome, because the connection is a little more sophisticated. But one of the advantages is, you may have a little bit improved axial resolution, especially in the far field as compared with phased array. It is a little bit larger in size as compared with the solid state IVUS with a short monorail, which can cause buckling. So, that may cause some difficulty when crossing tight lesions. You don't see a ring down artifact, but because the guide wire travels alongside of the transducer, you can see a guide wire artifact. With the solid state device, because it utilizes electronic control of each of the transducer elements, it's just a catheter that comes in a kit and you just plug it in, it's plug and play. The commercially available ones are, 20 hertz. So they tend to result in a little bit poorer axial resolution, but they do allow for increased penetration. So, with regards to imaging larger vessels like veins, it can be very helpful. There is, of course, a ring down artifact, but that's pretty easily masked by the push of a button. And then, of course, you don't see a guide wire artifact, because it goes through the shaft. It is a little bit smaller in size with a longer monorail, so it may have a slightly better crossing profile. And just to kind of reiterate, IVUS is not the same as, histology. Again, this is what you're seeing is the intensity of these reflected sound waves produced by the transducer and received back based on the acoustic property of the tissue, but it can correlate with the histological specimen. As you can see here in this image, The innermost layer is the intima, and you can see these kind of mixed echoes within the intima, probably indicative of some fibrofatty plaque. And then you see this black ring, a hypoechoic ring, which represents the muscular media. And then outside of that, you start to see these hyperechoic signals, which are indicative of the adventitia, or the outermost layer of the vessel. And just to go over some pathology, I think it was a little bit cut out, but essentially this slide just goes over calcified plaque. We can kind of broadly characterize plaque into both calcified or non-calcified lesions. And calcium is characterized by these hyperechoic signals with posterior shadowing, as you can see here. And you can further substratify that into superficial or deep calcification. With superficial calcification, as you can see on the left-hand side, this is calcium that impinges on the lumen, and it's typically intimal. You can also call it endoluminal or intimal calcium. And this can be, circumferential or involve only part of the vessel wall. And this is kind of in contrast to deeper calcification, which tends to be medial. And the best example is this one on the right. You can see that hypoechoic ring that you saw on the previous slide, it's been replaced by this hyperechoic plaque with the posterior shadowing, but it's not really impinging on the lumen. And it's important to know where your calcification is occurring, because that can help determine, what kind of modality you want to use for plaque modification. Then we go into the non-calcified plaque. You've got your fatty plaque, which is predominantly echolucent, so you'll see it fairly dark. It's important to identify because it tends to be fairly compliant and much more prone to shift, especially when you're treating bifurcation lesions. Then you've got fibrofatty plaque, which tends to be kind of mixed echoes. You see some echolucent, but some echodense echoes in this type of plaque. And then fibrous plaque tends to be a little bit more organized. So it's more of an echogenic gray that you can see here in the middle. And IVUS is really important with vessel sizing. As we talked about earlier, angiography tends to underestimate the size of a vessel because, we're performing luminography. And ideally, you want to size the vessel based on the diameter of the media, that muscular wall. So you can see here on the left, by angiogram, the vessel looks like it could be a 6.4 millimeter vessel, but by IVUS, you can clearly see that it's closer to an 8 millimeter vessel. So that's really important when deciding, different therapies. And it can also be pretty important with regards to looking at, where vessel origins come off, or, especially with bifurcations, kind of making sure that your stents landed right at the origin. It's not impinging on, where a vessel's bifurcating off. So you can see that at the 3 to 5 o'clock position. You can see that vessel coming off there on the IVUS image. This is just an example of intimal calcium. Again, you can see that it's encroaching on the lumen, and you can see that classic hyperechoic signal with the posterior shadowing. And it's kind of varying from circumferential to only involving part of the vessel wall. And this is an example of medial calcium. You can see the hyperechoic blood, kind of free flowing in the lumen. It's not impinging on the lumen, but, you see the replacement of that muscular, medial layer. And then this is just a still image of an example of a mixed plaque. You see a calcified cap here, but you also see some mixed echoes underneath it, and some, echolucent, fatty portion underneath that as well, which is a lot of the disease that we see. It can also be a really important problem-solving tool in complex, revascularization, especially when crossing large segments of chronically occluded vessels. You want to know where you've gone subintimal, so you can use color flow Doppler, and you can see here by this example that the IVUS is clearly underneath an intimal flap, and you can see the vessel. You can see the Doppler through the true lumen, and you can see where you've crossed back into the true lumen. Can also be used as a problem-solving tool with regards to stents. You can see the stented segment. Woven nitinol stents really appear as this hyperechoic signal. And if you start to see mixed echoes underneath, it's indicative of smooth muscle proliferation or neointimal hyperplasia, which is the segment highlighted in purple here. Something we see predominantly with bare metal stents, not so much with drug therapies. And this is just an example of that. This was a pullback through, what's likely a woven nitinol bare metal stent. And you can see all those mixed level echoes, on the IVUS image, indicative of significant in-stent restenosis. And you can correlate that with the fluoroscopic image. And you can contrast that to a drug-eluting stent. You can see that, the lumen is pretty intact and you don't see any of those mixed echoes within the lumen itself. And that's just highlights the power of drug elution. And this is just side by side. It's also important to, see if there are anything within the lumen. You see a cross-sectional CT image on the left of what looks like a thrombus, and on IVUS, this is a still image. It's not a moving image, but you'll see this free-floating mixed echo dense, lesion, and that'll help determine whether or not you want to use thrombectomy or possibly stent to the side. So it can be very helpful with that. And of course, IVUS guided reentry. It's a pretty powerful tool in these complex revascularization cases. The Philips has a Pioneer device where the IVUS is built into the reentry, and this is just an example of that. And here, you've got a wire above with the balloon expanded into one subintimal space, and you got a wire below. And we're using the Philips device. You can visualize exactly where the needle is going to go, and you can puncture the balloon and connect the wires together. And then, use further therapies after that. And this is just a short quiz. Just have a few seconds. So what's the dominant type of plaque here? You can clearly see, the posterior shadowing and the hyperechoic signals. This is clearly, predominantly calcific plaque. And you can kind of correlate that on the fluoroscopy. And where's the location of this calcific plaque? This is pretty much the same image. And you can see that it's encroaching on the lumen. So this is clearly endoluminal or intimal calcium. And which one of these images most likely represents a stent graft? You can clearly see in A that you see these mixed level echoes within the stent itself, which is probably indicative of a bare metal stent versus the stent graft here with the PTFE coating. It's less likely to have that, neo-intimal hyperplasia. And then what's the location of this plaque? You can clearly see that there's replacement of that muscular hypodense, medial ring. So this is clearly medial calcium. And that's the gist of it. Thank you.
Thank you. So these days, it's becoming more and more clear with the recent studies that IVUS is essential for not only just sizing, but in optimum therapy. I'm going to call my next speaker. He's with Dr. Pradeep Nair. He's going to talk about using external duplex to cross lesions and treat patients.
Thank you, Mac. Welcome to all the fellows. It's a great privilege to have you all here with us today for 24th Annual NCVH Conference. You just had a talk on intravascular ultrasound, a modality that is used every day in my lab, our lab. But lately, not lately, in the last several years, we've been utilizing external duplex ultrasound to assist us in crossing lesions. This is not something that I developed, but something that I watched afar from Fadi Saab and Jihad Mustafa. They've been using extravascular ultrasound for quite some time. And, I was watching from afar and thinking we should do this too. And lo and behold, it's been a godsend for us in many of these, treating many of these patients. Here are my disclosures. So when you look at extravascular ultrasound, we can see, if you can see it, you can treat it. So in the limbs, the arms or the legs, you can obviously see the vasculature with ultrasound. So these are prime targets for using ultrasound. The visceral organs, the aorta, iliacs, you can see it, but probably not ideal for crossing. It's a little bit challenging for visualization, especially in patients who are obese. And, I would love to be able to see with ultrasound externally in the coronary arteries, across a coronary CTO or in the brain, but unfortunately, that's not going to happen. So what are the pros for endovascular ultrasound, extravascular ultrasound, I should say? So the obvious, there's no radiation involved. The legs are easily accessible. It assists us in crossing chronic total occlusions. We can evaluate cap morphologies, and this comes into play and I'll show you some slides where it comes into play. We can assess vessel size. We can assess plaque morphology. We can look at how our balloons and stents are being deployed, make sure that they're opposing the vessel wall and sized appropriately. And additionally, we can use Doppler to assess our real-time success of a revascularization procedure. But all in all, I think extravascular ultrasound makes procedures safer. So the cons, of course, are you need experience. And this is both the imager and the operator. You cannot do both. You're either going to be using the wire and the catheter and crossing, and you need somebody who is skilled to be able to operate the ultrasound equipment. And the ultrasound machines can sometimes be bulky, but this is something that in time, we're getting smaller and smaller machines so that they can easily fit during and not be cumbersome during your interventional procedures. Imaging can be suboptimal when you have calcium, which can cause acoustic shadowing. Edema and wounds can cause significant barriers for ultrasound penetrance. And one of the issues that I've found is that while we can identify subintimal crossing with extravascular ultrasound, it's a little bit harder than I say with intravascular ultrasound, as Aaron had showed you earlier. And the sonographers need to be dedicated in doing this. I would say that if you have ability in your laboratory to train somebody in ultrasound to use, have them with you on every case so that you can utilize them to their fullest, and they get better the more they do. And it does take a little bit longer at first, but it does get better over time. And so angiography itself is an abstract art. It really, I mentioned the pitfalls, radiation, you have to use iodinated contrast, but the stenosis severity is really dependent upon the obliquity with which you're viewing this three-dimensional object on a two-dimensional screen. And it does not identify plaque morphology. So my children are out of school and they were quite bored. And I said, hey, let's do a little video for the fellows. I had them put a blindfold on, put some objects in our room and said, run as fast as you can. And you can see that crossing a CTO is like crossing a vessel with angiography alone. It's like crossing a vessel with a blindfold on. And so the first step with enhancing safety with EVIS is starting with access. If you're doing radial artery access, you want to ensure the size of your radial artery is adequate to accommodate your sheath. If you're doing femoral access or brachial access, you want to ensure anterior wall punctures, because if you're going through and through the vessel and you use a closure device, you close the anterior wall, but you're bleeding through the posterior wall. So we want to avoid issues. These are cases of mine where you have pseudoaneurysms that can form from groin access or perforations. Perforations can be deadly if you're not addressing them right away. And so I mentioned to you cap morphologies, and Fadi has published on, and his group published on cap morphologies, which I look at now more intently. You look at the concavity of a plaque cap, and it helps you address whether or not you can cross via an antegrade or retrograde fashion. And there's 4 types, and what you can see is if it's concave, you can typically cross your wire through, convex, where the wire tends to go subintimal. And along the way of vascular plaques, we have boulders and a lot of roadblocks in our CTOs. So let's look at C-tops by EVIS. So it's really hard to see, but if your ultrasonographer can angle the probe, you can see plaques. And in this case, we identified a C-top classification type 1. And so we felt we can cross antegrade. This was a patient who had both a common femoral artery occlusion and an SFA occlusion. Obviously, with a common femoral artery occlusion, we do not want to go subintimal if we can avoid it. We want to try to protect our profunda. And then after that, we have to deal with the SFA. So that C-top 1 was of this common femoral. So we felt very confident that we can cross from an antegrade fashion. And so this is what we did. You see our wire and catheter crossing with EVIS support, our visualization, and we're able to cross that short CTO relatively easily. Now, the other aspects of this is you can real-time assess vessel size. This is a vessel that is 6.3 millimeters. That'll help you identify what balloon size you want to pre-dilate with, what drug-coated balloon, if that's what you want to utilize, you can use to have vessel wall apposition. And when we then went on to cross the SFA, you can see our wires easily able to navigate using EVIS Assist to cross the CTO. And so finally, you're able to get a good result utilizing extravascular ultrasound. And in this case, we did have to place a stent because we used adjunctive intravascular ultrasound, which did show a short area of subintimal crossing. So if you can't see it, EVIS can absolutely help. So you see here a common femoral artery, SFA profunda junction. If you don't see a nub on angiogram, put a probe on the leg. You can easily see where your nub is. And all you have to do is get a crossing catheter, enter that nub, and then you're able to complete your procedure. You see here, if it's occluded, if the vessels are occluded, EVIS can help. This is a case that I was working on with my colleague on. He had a case where the SFA was occluded and it reconstituted in the posterior tibial. And so what we did was we accessed the posterior tibial and we're able to cross a wire through the tibial artery into the TP trunk and able to revascularize this patient. Tibial artery EVIS is more challenging, it has a steeper learning curve that you need to address, but I'm going to tell you that in time it gets easier. This is a case, so I wanted to have a case that I just did last week where I could show you the full complement of what we do. This is an SFA occlusion in a patient with critical limb ischemia. The SFA is occluded. Nothing too crazy. I mean, this is something you can do with angiography alone, but if you want to get this procedure done with the least amount of radiation, iodinated contrast, and in my opinion, the safest way possible, EVIS can help. So first starts with access, as I mentioned to you, watch for vessel tenting, get an anterior wall puncture. From there, you can find your SFA profunda, which is on the bottom juncture. You easily cross your wire through, and you can pass your wire through the occlusive area of the vessel. Now, if you want to see the genesis of a knuckle wire, this image shows it to you. You see how the wire can buckle and creates a loop. And now you decide, do you want to keep the loop or do you want to straighten your wire out? EVIS can help you assist with that. It can keep you in the true lumen of a vessel. You can look at your C-top classification, your plaque morphology, concave. So this went subintimal. Now, in this case, rather than sticking retrograde pedal access, which would have helped us to connect the dots, we decided to keep the subintimal access, keep a knuckle wire, and re-enter the SFA. As you can see, the pop right there. There's a pop where we entered the true lumen of the SFA. From there, we measured the size of the vessel. This was a 5mm vessel. It was mixed plaque morphology, soft plaque. It can help you identify what atherectomy tool you want to use. In this case, I chose laser atherectomy given its mixed plaque morphology. Here's a turbo power laser, excimer laser, 308 nanometer at low fluence and frequency. And on the right, you can see a higher fluence and frequency. Real time, you can see the spinning of your laser catheter performing atherectomy. And in this case, you can assist with PTA. We can accurately place your balloon at the SFA profunda junction and to treat occlusive disease. And then you can also see your stent deployed. This is a Supera stent I was deploying with EVIS guidance, showing excellent wall apposition, real-time Doppler evaluation pre and post shows successful revascularization, and then you get a good result. And so finally, I will say that the last thing it can help you with is closure. This is a case where we use a Vascade device. You can see it abutting the anterior wall of the common femoral artery, and you can ensure that you have hemostasis. So in summary, EVIS is a great asset in revascularization procedures from access to closure. It's a great complement to intravascular ultrasound. And yes, it does take some time and resources, but I will assuredly tell you that it is well worth the effort. Thank you.
Thank you, Pradeep. So also helps with radiation, less radiation in the lab for the operator and the staff. So it was a great talk. I'm going to invite my next speaker, Dr. Whiteman, who's going to talk about promise of CO2 in vascular interventions.
Thank you very much. Okay, I want to thank Craig and the meeting organizers for allowing me to talk about CO2. A couple of years ago, this talk was kind of given in honorarium of the guy that was kind of known as the CO2 guy, Jim Caridi, who was professor at the University of Florida, where I trained, and also at Tulane. So I'm going to talk a little bit about the promise of CO2. And rather than the title of where it's not useful, perhaps where it's used best or where it works best. My disclosure is nothing particularly relevant to this talk. So Dick Hawkins was my fellowship director initially, and he was really one of the pioneers in using CO2 as a contrast agent within the arterial system. And then Jim Caridi, who again kind of took over as the CO2 guy. If you ever met Jim, there's simply nobody like him, and never will be anybody like him. But interesting guy, and kind of carried the torch for Dick. So let's talk a little bit about what makes CO2 useful in the arterial system and some of its unique properties. It's a very highly soluble gas, and more so than oxygen or nitrogen. This is some early experiments that we did at the University of Florida in a canine model. And if you look at the presence of CO2 here, hopefully that projects well. You can see that the contrast is layering in a non-dependent position, and over the course of 45 seconds, it completely disappears. So very soluble in the bloodstream. It's also very low viscosity, and because it's a gas, it's very compressible. So you can see in a comparison of 2 injections here of the celiac axis, you're getting some retrograde flow through the pancreatic vessels here, and you can see a little bit of a filling defect. Whereas with CO2 in the same injection, in the same artery, you can easily see that gastroduodenal artery filling in an antegrade fashion. So because of its low viscosity, it gets to places where contrast may not get. And we've actually found that in certain settings of GI bleed, for example, or extravasation in an arterial rupture, that you can identify the source of bleeding much more easy with CO2. Here's another example of retrograde injection in aortoiliac occlusive disease. This is done through a 3 French catheter. So you can see in the setting of aortoiliac occlusion, retrograde injection through the catheter in the left external iliac artery, you can get all the way back up into the aorta, into the collaterals and into the contralateral limb. And CO2 acts by displacing blood rather than being dissolved in blood like with contrast. So you're actually displacing the blood because of the buoyancy of CO2. So that's how it actually works. So definitely some unique properties of CO2 relative to iodinated contrast. So how do we deliver CO2? Well, back in the old days in 1984, these devices looked rather primitive, and over the course of time, a couple things have developed, from automated injectors, which are really no longer in use, at least in the United States, but there is a unit in Europe, to what was called the plastic bag system in the early 2000s. Nowadays, we have kind of a combination. This is the most efficient way to deliver CO2. And I do hear some people talk about their own kind of homemade CO2 system. And I would advise to take caution with your own homemade system, because contamination can be pretty devastating, not only in terms of patient pain, but also with complications. So this is the kind of the latest version, which is a good combination of syringe delivery and automated CO2 cartridge that is a very simplified system. So where is it useful? Let me just show a couple cases here. This is a 73-year-old gentleman with buttock and thigh claudication with short distance ambulation. You can see his ABIs here, pre and post exercise. Chronic renal insufficiency with a serum creatinine of 2.3. And you can see the CO2 angiogram here showing evidence of occlusive disease, not only or stenotic disease in the right common iliac and right external iliac artery, but a complete occlusion of the left common iliac and left external iliac artery. So using standard techniques with guide wire recanalization, we were able to kind of reconnect the dots, so to speak, deliver covered stents bilaterally, self-expanding stent in the right external iliac artery, and then covered stents all the way down through the left external. And you can see the good flow here on the final cine angiogram. This is the comparator exam with contrast, and no significant change in the patient's GFR or renal status, and the patient remained asymptomatic out to 3 years. So certainly good in the claudication population. There are some limitations, however, with CO2, especially in the aortoiliac system. You need more volume to be able to effectively displace the blood when you're dealing with bigger vessels. But we have, even though there are limitations, we have ways to mitigate that. So because there are larger vessels that require more volume, there's also some, in the iliac segment, these vessels are tortuous. They're a little bit more posterior. So there's some implications there. These patients, when you inject in the abdomen, they can get transient abdominal pain, especially if their inferior mesenteric artery is patent. So how do we mitigate that? Well, if you allow more time between the injections, allow for that solubility to kick in, then that usually mitigates that. Also be careful with explosive delivery. Again, this is a compressible gas. So if you really blast that syringe, they're going to feel that. So be careful with that. In the abdomen and pelvis, obviously we're dealing with bowel. So because there's normal bowel motion, that can produce what's called misregistration artifact, and that can obscure the area of interest. So how do we mitigate that? Well, you can consider giving glucagon if you think this is going to be a long potential intervention with multiple repeat runs. So that'll help kind of mitigate some of that bowel motion. And then sometimes it allows, it can be challenging to see your distal reentry target, but we see that with contrast too. So some of the things we can do there was just supplement with contrast. So again, a lot of times these cases that we do with CO2, that's the primary contrast agent. Doesn't mean that we don't necessarily use some contrast in the appropriate scenario. What about in patients with critical limb ischemia? Is there a role in critical limb ischemia? Absolutely. This is a 90-year-old patient of mine with Rutherford IV ischemia and an ulcer on her right toe. Tiny little thing, tiny little old lady, serum creatinine 2.0, GFR of 30. Incomplete evaluation by pressures, but her toe pressures were diminished. And this is just kind of the standard evaluation of her runoff, which shows no real significant femoral popliteal disease or SFA disease. This is the cine run here on the far left frame, and then the stacked frame using software that you can use to optimize the CO2 imaging. You can see that there's a little bit of static flow in the tibial vessels down here, but also a high-grade stenosis. This is the correlative angiogram with contrast, just to get a better idea about what's happening below the knee. And you can see the patient's not only has a below popliteal stenosis, but also short segment occlusion of some tibial vessels below the knee. This is maybe projecting real well. It's a little bit of a light image, but you can see that the runoff is primary runoff is through the anterior tibial, through the dorsalis pedis. We do some intervention in the popliteal artery. We also do it in the anterior tibial artery, and we get what looks like a little bit of a dissection here. And that's one limitation of smaller vessels with CO2 below the knee, is it's sometimes hard to depict dissections. But then we get good runoff into the foot here on the final run using CO2, and a good result in the anterior tibial artery. And then here's a final patient again with critical limb ischemia, small wound on the great toe with chronic kidney disease. Here again, here's evaluation of the runoff. This is quite helpful in limiting your contrast. If you can look at the inflow abnormalities using CO2 and minimizing your contrast. And you can see we're dealing with anterior tibial artery occlusive disease. You can see kind of a static column here of the CO2. In this patient, we actually, you can see the flow here primarily through the posterior tibial artery, and it's actually filling retrograde in through some connections through the posterior and anterior circulation. And so we get across the occlusion. In this particular patient, we ended up having to use a stent because that lesion in the anterior tibial artery was very resistant. So put a short drug-eluting stent. You can see the final result here. And then perhaps most importantly, when you see the final run, did some posterior tibial intervention there as well. You can now see that that there's, instead of primarily filling the posterior tibial and then filling retrogradely through the anterior tibial artery, now we have actually kind of simultaneous filling in both the anterior and posterior portions of the lower leg. So limitations in CLI. In the interest of time here, I'll probably cut off the last two slides, but these are important limitations to know. If you have suboptimal inflow in patients, particularly with critical limb ischemia, treat the inflow first. Again, we're looking for ways to mitigate the limitations here. Treat the inflow first, and you can even elevate the leg. Again, CO2 is a gas, so it goes to non-dependent portions. If you elevate the leg, that can sometimes help. I mentioned before that you can sometimes underestimate the dissection post-intervention, particularly in the smaller vessels. And because these patients sometimes move around a lot, they're susceptible to, the images are susceptible to patient motion artifacts. So some things that you can consider here, complementing with intravascular ultrasound or extravascular ultrasound, as the previous speaker mentioned. And then you can consider securing the foot, maybe deeper anesthesia, Liberal use of vasodilators sometimes helps with better visualization of the small vessels below the knee, and then super selective angiogram. Get the catheter down as far as you can before you do your injections. Some technical tips. Again, avoid the explosive delivery because it can hurt patients. Film at a fast frame rate. Get as selective as you can, and again, use the vasodilators. We also use it in the venous side here, but I'm a little bit over time here, so I'll just summarize. CO2 is very useful in many scenarios, so it's not really where it doesn't work, it's just where it can work best. Patients with acute kidney injury, patients with maybe severe contrast allergy, particularly suited for straight vessels like the femoral popliteal segment. You can get outstanding imaging with SFA. It's much less mobile area in general, particularly in patients with critical limb ischemia, and you can use less volume with less subsequent pain. But all these limitations that we have with CO2 can usually be mitigated with fairly simple techniques. Thank you very much.
Thank you. So in the interest of time, we'll go ahead with our next speaker, Dr. Yates. He's going to talk about overview of atherectomy device.
Well, thank you again to Dr. Walker, the course directors here at NCVH, for having me back. It's always a pleasure to be in New Orleans. We're going to give a very 30,000-foot view overview of atherectomy devices and how they might help you in a variety of different situations for plaque modification. These are my disclosures. A lot has changed in general in the peripheral space, obviously in the last couple of decades, but certainly since Laura Shaw was treated by Dr. Dotter in 1963 with the advent of angioplasty. We've seen certainly the ability to increase our minimally invasive treatments of these patients with severe peripheral vascular disease, but we still have a variety of limitations where atherectomy may help to decrease. And this is partially because plaque is really not a one-size-fit-all entity. Lesions are often complex and heterogeneous. They can be of variable length, particularly as we get below the knee. And sizes diameter-wise can pose a challenge to getting adequate apposition of stents and balloons. And then, lesions, again, may represent a variety of different components, including thrombus, intimal hyperplasia, et cetera. And so why do we do this? Why do we modify plaque, particularly with calcium? Well, we've seen a variety of data sets come out since the advent of drug-eluting therapies have certainly shown that calcium seems to be the enemy of good drug penetration. And intimal and medial calcium, as we saw in the IVUS talk, very adeptly put, really does result in a higher degree of complications. So things that we can do to debulk that plaque may theoretically help to decrease those post-procedural complications. Again, just referencing the well-known Finelli data set looking at the decreased efficacy of drug penetration with greater degrees of peripheral calcium. So broad brushstrokes, there are a variety of different tools on the market, and I'm not going to be able to really go through these in exhaustive detail. It's not meant to be exhaustive, but I generally think of these two types of atherectomy categories broken down simply as more of debulking versus modifying atherectomy systems. You can see there's a broad list here. We'll go through these individually. So starting with the directional atherectomy system, Medtronic, the Hawk-1, these come in 6 and 7 French varieties and are meant to be sort of a plaque cutting tool, which can be directed to specific areas while trying to avoid other areas. Just generally speaking, distal embolic protection is recommended. The definitive AR trial looked at the use of this particular device in the setting of DART or antistenotic therapy using their DCB versus DCB alone, and they did find that it was safe and efficacious, and actually found that overall lower flow limiting dissection rates, PLS sending restenosis were seen in the atherectomy plus DCB groups. How have I used it and how do I apply it in my practice? These are generally applied in no stent zones, typically in the setting of a common femoral or popliteal stenosis, can be combined with DCB to improve drug penetration. It may help to decrease dissections, but be aware that too much cutting can potentially result in a higher degree of hyperplasia. This is just a couple of cases demonstrating long segment SFA occlusion on screen left in a patient with claudication, and then a patient with ischemic rest pain with a high popliteal occlusion, both treated with directional atherectomy and drug-eluting balloon angioplasty. So the rotational atherectomy system from Boston Scientific, known as the Jetstream, combines atherectomy and thrombectomy in a 7 French system. They come in 2.1 to 3 millimeter or 2.4 to 3.4 millimeter sizes for the SFA, and smaller to 1.6 to 1.85 for the below knee circulation. Generally speaking, distal embolic protection is probably beneficial as you learn to use the device. As you get more adept at using the device and the aspiration capacity, this may be able to be used less often. The design of the catheter has a wings down and a wings up configuration, which allows you to tailor the size of the atherectomy debulking that you're doing, which could be certainly helped along by both intravascular or extravascular ultrasound, so that you know the true luminal size as well as the plaque bulk that you can help to focus on. The Jet Railroad Registry looked at 241 patients. A large proportion were diabetic and over 258 lesions, and found that there were quite reasonable TLR rates at 12 months, as well as 12-month patency. They found the distal embolization rates were exceedingly low, only 1.4% of events, and actually less than a quarter of patients were treated while using a distal embolic protection device. They found that in general, a lot of the patients had severe calcium, which is more of a real-world data set, so it is useful in our real-world patients. How have I used it? Again, I generally, in the setting of trying to have very controlled luminal gain and debulking, this is a very useful device. It's particularly in the blades up configuration after you've gone with the blades down. It's very good at debulking calcium, but if it's a largely calcified vessel, distal embolic protection may be beneficial to prevent distal embolization. No stent zones and femoral popliteal disease are the typical locations where we use this. A couple of similar cases, distal SFA lesions, screen left, and a rest pain patient, screen right, and a patient with an ischemic wound. This allowed this device was able to cross intraluminally, treat with DCB only, and not have to place any stents because of the excellent debulking, both in the setting of severely calcified lesions. Orbital atherectomy is another category, and probably the best known device in this category is the CSI Diamondback. Comes from 4 to 6 French sizes, and really sort of revolutionized the way that tibial disease was treated, particularly severely calcified tibial lesions. The device used in a sort of an off-hitched 40 micron grit, rotates in an orbital fashion, and basically helps to debulk the firmer, grittier calcium while leaving some of the softer plaque relatively untouched. And generally speaking, distal embolic protection is not necessary, although there are differing opinions. The Liberty 360 trial looked at the use of orbital atherectomy and angioplasty in all-comer patients from Rutherford 2 all the way to Rutherford 6, and found very high rates at 12 months of freedom from major adverse events. They found that also was found to be safe in patients with difficult to treat calcium. Across the quality of life measures, they found that there were significant improvements across all categories when using orbital atherectomy. This is a case of a distal SFA and proximal, as you can see, extensive tibial disease. Screen left, a patient with ischemic ulceration of the foot, treated with orbital atherectomy, and excellent technical result crossing through the perineal with then good posterior perforator flow into the posterior circulation. Another similar example, a patient treated through the pedal-plantar loop. Both AT and PTs were adeptly recanalized with regeneration of the pedal-plantar loop for excellent forefoot flow for this patient with forefoot gangrene. One of the things to keep in mind with this particular device is we want to try to be careful in certain areas, particularly where there is soft plaque and less calcified plaque, the device can get stuck. And so as we get smaller into tinier vessels, particularly the pedal-plantar loop, take care as we cross into the deep plantar artery, unless it's absolutely necessary to treat that area with a modifying technology such as this. And one of the other orbital atherectomy systems on the market was recently studied. The CardioFlow system has a similar design with more burrs rotated around in orbital fashion around the shaft, allowing for even a greater debulking in theory, although the FAST-2 trial is currently being evaluated from its data set. So going over into another type of modification with laser atherectomy, the Philips or Spec Genetics system is well known, well published, and has been on the market for a long time with absolutely excellent results. And there are 4 to 7 French device systems. 308 nanometers is the frequency of the laser. Generally speaking, this does well in most situations, with the exception of a high degree of calcium. Generally, distal embolic protection is not necessary. a variety of different proposed mechanisms for the way that the plaque can be ablated, which I won't go into in gross detail. The Excite ISR trial is probably one of the first real true randomized prospective trials that showed a benefit of using atherectomy in the setting of intimal hyperplasia with in-stent stenosis, and really got laser atherectomy sort of in the public eye in peripheral disease for treatment of these problems. Here's a case of an SFA occlusion treated with atherectomy and then post-atherectomy, an excellent result with a proximal DES for a small dissection in that area. The other laser on the market is the Arion angiodynamics laser, which uses a 355 nanometer wavelength for its ablation, similar size matrix. And again, generally distal and bog protection is not necessary. A couple of interesting developments currently with this particular device. We're looking and currently finishing up the below knee trial, looking at the use of laser atherectomy in the setting of both soft and calcified lesions. And one of the additional areas of interest is the micro CT study, where they've looked at cadaver tibials with severe calcium, and are actually demonstrating pre and post angioplasty significant fracturing of the calcium with similar results to lithoplasty. So this is an area of active investigation where you might be able to see an atherectomy system actually debulk and modify plaque effectively. A similar case, multivessel tibial disease, the system crosses very easily down into the most distal branches, allows for reconstruction of a 3-vessel runoff and pedal plantar loop. So in the interest of time, I'll try to go through these last couple of systems pretty quickly. The Phoenix atherectomy system is a front cutting atherectomy system, which works by a cut and extraction, similar 5 to 7 French designs. They have sort of tracking and deflecting devices allow you to direct the tool into the area of interest. The deflecting is the larger device, and generally speaking, the distal and bog protection is not necessary. Again, it uses a front cutting, so immediately treating the disease once it comes into contact, different than some of the other systems out there, and pulls the plaque into the rotating shaft to help remove it without causing distal embolization. I'm going to go forward here in the interest of time. One of the other devices, a similar aspiration and cutting device currently being used, is the BD Rotorax, which does work particularly well in soft plaque, but also in thrombus. So it has been used for both indications of atherectomy and thrombectomy, and has a wide array of different sizes. So it can be used from 6 to 10 French devices. Thank you very much.
Thank you. Our next speaker is going to be Hanan Ahmed, who's going to talk about self-expanding stent technology, impact on choosing a device.
Good morning. Thanks, Dr. Walker. Thanks, Dr. Ansari, for inviting me again. It's always a pleasure. And I think it was mentioned earlier, this is probably one of the most exciting large fellows conference that you guys will find in PAD all year round. So definitely promote it and make your colleagues come next year. So I'm going to take next 10 minutes to talk about, we talked about kind of literally the toolbox of peripheral arterial intervention. Dr. Walker talked about wires, balloons, atherectomy, and I'm going to add a little bit about stents. Before I delve any further, when you deal with PAD or peripheral arterial disease, I think this has been mentioned, kind of think of it as 3 arterial beds. The aortoiliac disease, different rules apply. We treat it differently. Femoropopliteal disease, we have different tools available, and then infrapopliteal tools. What's also good throughout this meeting for the last 10 years that I've been here, you will see how new technology comes by, how new things are evolving, and how we have gotten so much better now treating these patients. We used to be very limited in what we could offer these patients. The restenosis rates were high, the recurrence rates were high, but now we're getting much better. SFA continues to be a very challenging field. I'm an interventional cardiologist, so I've seen the advances in coronary interventions, and the restenosis rates are very minimal. However, we continue to have challenges in treating PTA and SFA disease. So these are some of the tools that are available. Dr. Yates talked about the atherectomy devices in detail. Very nice talk. But why is SFA challenging? These are some of the challenges you face in the SFA. It's a very dynamic, tortuous vessel. And if your patients are mobile and walking around, there's constantly forces that are put on the artery. There's radial compression, there's flexion, extension, especially at the adductor canal. And all these torsion and traction put a lot of stress and strain on the stents when we use them in the SFA area. This is a model, again, when you bend the knee, the kind of forces that you're applying on the SFA, especially in the distal SFA area. So that's what makes a challenging stent to perform well in this scenario. Ideally, the stent should be flexible so it can conform to the vessel, should have a good crossing profile, a good radial strength to stay open, should be able to watch it under radiographic properties deployment. So all of these things are very hard to find in an ideal stent. So how did the self-expanding stent technology evolve? It came off almost as a serendipity. The alloy, the nickel titanium alloy, or nitinol as we call it, was kind of found in a space ordnance lab where they found that the metal actually had this property of hysteresis or shape memory. So it comes compressed in the shaft, so it's compressed. And when it actually is deployed, a lot of you who have done this before will know this, it kind of takes the shape of the vessel and it expands, self-expanding, hence the term. It basically, nitinol has the shape memory, whatever shape it was formed at in the lab, it will take that size and shape and it will try to conform that to the vessel. It may not have the best radial strength, but it still has enough. And most of these self-expanding stents, as you know, we will follow with post-dilation with an appropriately sized balloon. These stents go through extensive bench testing. Here, as you can see, they are put through radial compression, crush resistance, and with all of this testing, the technology actually has gotten better, and you can see the quality and improvement in the stent data. How are they made? There's many different ways or techniques, different styles, as you may say. You can get a huge nitinol tube and then cut holes in it through a laser. There are slotted holes, there are cut holes and mesh. You can get covered nitinol stents with an PTFE graft. This is very commonly used in the aortoiliac system. And there's heparin bonded PTFE grafts that we use in the SFAs as well. Gore-Tex is the kind of technique or term which was started again in the clothing industry, but was found to be very useful to cover our stent grafts with. This is the design of a heparin bonded Gore-Tex stent graft for SFA endoprosthesis. The Viabond stent also has some good data. And then there's a woven style of nitinol stents where you have 6 strands of nitinol that are woven together, again, to improve the flexibility and the duration of these stents. Different examples. Now, we also have drug-eluting technology on these self-expanding stents. What the drug we use is paclitaxel, and there is a primer or a polymer that's coated onto the nitinol, and the paclitaxel drug is actually bonded to the primer, and it slowly elutes over time. So now we have data on paclitaxel eluting stents for SFA as well. How do I use stents? As Tim showed his cases where he uses this, I technically have different ways of treating femoral popliteal disease. You can debulk with an atherectomy device, you can deliver drug, you can do a, what they say, no stent left behind technique, or there are times when you really need a stent to solve the problem. Here is a very resistant calcified lesion, as you can see. We debulked it, we even did a shock wave, ballooned it, but there was still very resistant residual restenosis, and we ended up doing a stent and got good results. Similarly, a total popliteal occlusion with very poor distal runoff, again, heavily calcified lesion. We debulked it, ballooned it, still a lot of recoil and resistance, and the stent actually gave us a good lumen. Stents are very good to treat complications like this. I think, Pradeep, you showed a case. This is, again, a case from our lab. High stick, and you have a perforation, come up and over and use one of those covered stent grafts, as we talked about, to seal this perforation. This was a post-TAVR case where perclose was used, and immediately when we tightened the perclose sutures, distal limb ischemia was noted, went up and over, crossed the lesion. Due to the perclose sutures, the balloon angioplasty results, you can see there's still some hazy restenotic areas. We ended up stenting it and got good results. I'll let this play. Stents are a good visual marker. If you want to re-access an artery, you just aim for the stent as shown here to re-access the area to get open the occluded area. But stents have some potential problems too. In the interest of time, I'm going to go through quickly. Stent fracture and restenosis is probably the most common problem you will see. Here's a focal example of a stent fracture leading to restenosis. This was treated with a DCV. And then this is a more diffuse example of multiple areas of stent fracture leading to multiple multi-segmented restenosis. And then on the right here, a total occlusion of a restenotic lesion in a stent. So it can be focal, diffuse, or a total occlusion. Stent restenosis is pretty common. It unfortunately happens with stent fractures that initiates it. There's many treatment options for stent restenosis. Most often we'll try to not put a stent inside a stent, or as in say double layer it. We'll try to cross it, debulk it, and then balloon angioplasty. These are all the different options available. What are the trends for the future to look for? Definitely the stent technology is going to improve. It's going to get better. We will be probably having custom design stents that you can make in the lab, designed for your patients. We're working on bifurcation stents that can fit easily into bifurcation lesions. There's a lot of technology that has gone up and down with biodegradable and bioresorbable stents. There's talk about polymer-free. Gene or RNA eluting stents are coming out in the market, growth factor stimulating stents, and then stents with sensors. So this is an example of how a material and size of the strut can affect stent function. The bulkier stents, the bigger stents cause a lot of turbulence, a lot of inflammation, a lot of restenosis. So making the stent strut sizes smaller, more laminar flow leads to less restenosis rates. There are stents that are going to be designed and have sensors. In other words, they will warn you or alert you if restenosis rate or inflammation is picking up, and you can intervene sooner than later. The good news is, as I said, with meetings like this, with awareness like this, PAD is treated much better. This is the trend in the last 20 years of how peripheral arterial interventions have increased. And this has led to actually a decrease in the amputation rates, which we thought was impossible at one point. And it's predicted to grow in more future. PAD growth and interventions for PADs are predicted to grow at an exponential rate in the next 10 to 20 years, with a CAGR of about 8 to 9%. This is the peripheral intervention market, especially the stent market is going to increase markedly over the years, as shown here along with other devices. And the shape memory alloy market is expanding. As you can see, its utility is in many other fields in addition to stent technology. I want to put a plug in. We have our fellows conference in August in San Antonio, and feel free to ask me about it. And guys, again, thank you very much. Pleasure being here.
So moving on to our next talk is going to be on current paradigms to treat instant restenosis by Erica Fedon. Thank you.
Yeah. Hey, good morning, everyone. Hope y'all have already learned a lot. As Dr. Ahmad just talked about, stents are only becoming more prevalent, especially with the newer technologies. PAD awareness and diagnosis is only becoming more prevalent. And so knowing how to treat instant restenosis is paramount for any peripheral interventionist. I have no disclosures. So again, greater than 200 million people globally living with PAD, less than 2% are treated surgically or endovascularly, but hopefully that is only increasing with increasing awareness. Worldwide, about 400,000 FemPop stents are implanted every year. And in the US, half of those are come from us. So stent volume, again, is only growing with increasing technologies and increasing awareness. And there's about 115,000 US cases of in-stent restenosis each year. So again, nitinol stents are being used more commonly in the treatment of PAD, multiple reports have shown improved patency, better symptomatic relief as compared to just plain old balloon angioplasty. Obviously, if you have a flow limiting dissection, stenting that is crucial. Again, instant restenosis is just becoming more common. And then interventional therapy has historically been associated with high restenosis rates and complications. And that's when we're talking just about plain old angioplasty. So kind of to structure this lecture, I did a case to walk you through why we treat it how we do. So this is an 81-year-old male that we did during my fellowship with Dr. Walker. He had an extensive history of PAD, prior limb salvage. He presented to our clinic with Rutherford 4 symptoms of the left leg, and his arterial duplex ultrasound at bedside showed a greater than 75% instant restenosis of the proximal left SFA. So we took him to the lab. Here's his left SFA. Again, full metal jacket in that SFA, obviously has instant restenosis. Looks simple enough, right? Pretty straightforward. Well, you know, in order to treat instant restenosis and why we treat it how we do, we must understand the mechanism. That's the most important part. So what is instant restenosis? So it's a neo-intimal hyperplasia, about 15% of it's cellular, and then the rest is extracellular matrix with a very high water content, which is important because restenosis, again, it's usually secondary to intimal ingrowth in a fully expanded stent. And reocclusion usually has superimposed thrombus, which is important to remember, and I'll go over why. Several investigators have noticed that if you have a stent fracture, thrombosis can be even more prevalent. Historically, treatment of long diffuse disease and occlusion showed very poor patency, with one study by Dr. Walker showing that less than 20% were patent at 3 months with a high embolization rate during the intervention. So there's been suboptimal results with plain old balloon angioplasty, PTA dilation of the intimal hyperplasia. It initially compresses the aqueous extracellular matrix. However, rehydration of that matrix quickly ensues. Then again, you can have thrombotic material that embolizes and becomes thrombogenic in and of itself. And then obviously you can have elastic recoil. So this is just a study reiterating what I just said, where they performed IVUS of an instant restenosis, then they did just plain old balloon angioplasty, and then they re-IVUS. And their conclusions was that the IVUS suggested compression and decompression as the main mechanism for early lumen loss after dilation of instant restenotic lesions. So leading to bare metal stenting. Again, we've had suboptimal results with that. Again, we tend to not want to double layer stents. There's an increased risk of embolization. There's no barrier to the intimal ingrowth. It certainly won't seal a pseudoaneurysm. And then the lumen can be compromised by the thickness of the stent strut. So that being said, if you do have a fractured stent, you need to mechanically stabilize that with a covered stent or another nitinol stent. So here's the Tosaka class, which can kind of predict how quickly you may have instant restenosis in a patient. So you have a short focal lesion and a diffuse lesion, both those at 2 years, about 50-50 chance whether that will instant restenose. But the Tosaka 3s, the total occlusions, a lot of them are going to restenose by 2 years. So when you treat instant restenosis in the FemPop segment, there's multiple things to consider. And again, this is all about procedural planning. So consider the length of the lesion, the location. Is it within the stent or is it on the edge of the stent? Is it a stenosis or is it a Tosaka 3? Is it an occlusion? What's the acuity? Is it old thrombus or new thrombus? Because that's going to change how you treat it. Is the stent fully expanded or compressed? This is where, you know, your intravascular imaging comes in, which is equally as important. What's the type of stent? Is it covered? Is it bare metal? Because those stenose at different places. Is the stent fractured? What is the runoff status? Because again, we always worry about distal embolization, the location of the artery, and obviously the vessel diameter. So there are 3 FDA-approved therapies for ISR at this time: laser atherectomy, covered stent with a Gore Viabond, and a drug-coated balloon. So Doctors Walker and Dipple did the Excite ISR trial, which has been alluded to in previous lectures. So that was with the 308 nanometer excimer laser atherectomy system. Here's the baseline characteristics. So one group was laser plus balloon, and this was not a drug-coated balloon, just a regular one, and then PTA alone. You can see here in the green that the laser plus PTA, those patients were more calcified. They had one vessel runoff or less, and then the types of stent fractures. And this is a study that had the longest lesions, with 20% of the lesions being over 30 centimeters or 300 millimeters. So what this showed is that laser atherectomy with just ballooning was superior to ballooning alone when it came to residual stenosis, procedural success, need for bailout stenting was less with laser plus balloon, and then dissection was less with laser plus balloon. So freedom from MACE was better with laser plus balloon, and then freedom from TLR was as well. This is just something to show that the longer the lesion, the better laser plus balloon did. So again, the EXCITE conclusions was that laser plus PTA is superior to PTA alone for FemPop ISR. It was the first FDA-approved randomized control study demonstrating the benefits of laser atherectomy in the lower extremities. And the 308 nanometer laser is the only atherectomy treatment FDA indicated for FemPop ISR. So this is just showing FemPop ISR just after laser, not even ballooning, which is pretty incredible what laser can do. DCB experience. So now we're moving on to the DCBs. Here's some trials that have covered those, but basically they said, okay, now let's do DCB plus laser versus DCB alone. Both cohorts had 24 patients, all diabetic, CLI, and total occlusions. The treated stent length and lesion length was greater than 20 centimeters, 100% crossing success. Complications, there were 3 distal embolizations, 2 of those being with DCB alone, 1 with DCB plus laser, 0 perfs and 0 dissections. So at 12 months, it was clear laser plus DCB is superior to DCB alone when it came to patency, freedom from TLR, achieving limb salvage, and then freedom from amputation. So going back to our case, again, gentlemen, Rutherford, 4 symptoms, instant restenosis of a FemPop segment on the left side. To make things more complicated, not only did he have anaphylaxis to contrast, so we did his case completely with CO2 angiography and IVUS, he only had 1 vessel runoff. He had an occluded AT, he had an occluded perineal in his entire top to TP trunk to PT was stented. So what we worry about here is distal embolization, because if we distally embolize, we trash that foot pretty quickly. So again, we IVUSed, and I don't know if you can tell from this picture, but right here is a nice big old thrombus just sitting there. So what did we do about it? In addition to giving heparin, obviously, as well as antiplatelet agents, we also used 2B3A inhibitors. So we gave him 2 boluses and a drip of 2B3A inhibitors. Why did we do this? So we've all seen this from day 1 of medical school, basically, the coagulation cascade. Well, 2B3A inhibitors affect the very last part of the coagulation cascade, which is platelet aggregation. That's where the 2B3A receptor comes in. We have 3, most commonly integralin and aggrastat are used here in the US. I tend to prefer aggrastat because it's pH balanced, so it burns less than integralin does. Just know that integralin and aggrastat are both cleared renally, so just remember that. But despite the strong pathophysiologic rationale, clinical experience with these in peripheral interventions is still limited. The goal of antithrombotic therapy with percutaneous intervention is always to prevent formation of the platelet-rich thrombi and then block the stabilization into fibrin deposits. Currently, antithrombotic therapy for these interventions includes antiplatelet agents, aspirin, Plavix, and then an antithrombin agent, whether it be bivalve or heparin. So again, why do we do this? Well, aspirin works on the thromboxane A2, clopidogrel on ADP, heparin and bivalve on thrombin in some way, antithrombin versus a direct thrombin inhibitor. Well, all these 4 work on platelet activation, but none of them block that final common pathway of aggregation. So namely that 2B3A receptor. So even if you have all these things on board, you can still have thrombus leading to ischemic events. So by targeting that final common pathway with these 2B3A inhibitors, irrespective of the platelet agonists on board and the state of platelet activation, you can have the most potent form of inhibition of thrombus formation. And then even at ultra high concentrations, you can actually have disaggregation of the platelet-rich thrombi. So the potential for these inhibitors in PAD is currently very underscored by the fact that a PAD patient may have abnormal platelet reactivity to begin with and therefore diminished clinical response to aspirin. Multiple studies have demonstrated that adjunctive therapy with 2B3A inhibitors in patients undergoing intervention for PAD is safe. There's a low rate of bleeding, complications, and thrombocytopenia. So what did we do? We, again, we gave a bolus of aggrastat. We started a drip of aggrastat. We did 2 passes of laser atherectomy, one at low energy, one at high. And then we did DCB. Got great results, didn't trash the foot, preserved that one vessel runoff. So just in conclusion, PTA alone has failed. DCB is effective, especially for lesions less than 100 millimeters. But more data is needed for those CTOs. Both laser and Viabon are effective for long lesions and FDA approved. And remember the 2B3A inhibitors. Remember that coagulation cascade because you may need it on board because a lot of these incidents are going to have thrombus related to it. All right. Thanks, guys. Enjoy the rest of your day.
Thank you. We now come to the workshop rotation 5 and rotation 6, a little change in time. These rotations are going to be just 10 minutes each so that we can come up on the time and resume back at 11:16 a.m. So please go ahead with your rotation 5 and rotation 6. Thank you.
Check 1, 2.
Now I heard it. Okay, okay, it's been heard. We're good. Once you did that, okay.
Hello? Oh, okay, all right. Can everybody get back? We are done with our 5th and 6th rotation workshop, and we'll be moving on to the next session. Sake of time, we will do the questions after the talk. I'm going to invite my next speaker, Dr. Amit Amin, who's going to talk about need to know. Amit Amin.
See if I'm no good. All righty, let me get this show on the road. All right, thanks to everybody being here. We'll get started. Thanks to Dr. Walker for getting me started and get me to into this field even more than I wanted to be. Hang on, let's go. All right, there's my disclosures, nothing major to go. All right, so PID outcomes, populations over 50 years old. You have this initial clinical presentation, but for this talk, we're going to concentrate in this area right here. Alive with 2 limbs at 50%, amputation at 25, and other CV mortality at 25% too. So it's pretty staggering numbers here, and hence the reason you're all here, just because of that reason. So PID outcomes, survival-wise, normal subjects, over 12 years is actually pretty good. But then you get to the severe symptomatic PAD, and it's a pretty precipitous drop-off all the way down to 25%, which are staggering numbers. So overall diagnostic modalities, hang on, let me go back. Can you go back a couple of slides? Let's see. Okay, yeah. All right, so modality-wise, we all know the resting ankle brachial index and toe brachial index, perfusion testing, useful for hyperbaric. They got the fluorescent stuff now, and then the CT perfusion maps, which are excellent to finding areas of poor perfusion. Handheld Doppler is a vital key element in your clinical practice. Should be able to recognize monophasic to triphasic flow, which should be in all your practices. Then the exercise ABIs, segmental pressures, you got pulse volume recordings, arterial duplex to actually find out where these lesions are. And then you've got more diagnostic imaging using CTA, MRAs. And then, of course, last but not least is invasive angiography. TBIs here, you divide the toe pressure by the highest brachial pressure. And you continue on, and anything less than 0.7 usually considered diagnostic for lower extremity PAD. Treatment, this is the main thing that we should all be concentrating on. Those who are not into the medicine part should be working coincide with either cardiologist or internal medicine physician to get the smoking cessation, the hypertension, the diabetes, the lipid control, which is key to prevention. So progression is guaranteed with ongoing abuse with smoking cessation. That's probably one of the toughest things that I battle in clinic is to get them to stop smoking. Sometimes you have to put a little curtail on and say, hey, look, if you're not going to stop smoking, there's not much I can do for you. So hypertension control is very important, of course, ACE inhibitors if possible. Remember, beta blockers are not contraindicated. And then lipid control is also key new guidelines for CAD, say less than 70, and I kind of implement that with the PAD also. And then, of course, the PSK9 inhibitors are working wonderfully these days. Glycemic control in diabetes, of course, A1C over 6.9 shows associated increase of amputation. So working with your endocrinologist or your medicine physician's exercise program, if they can do it, sometimes a double-edged sword because many people just can't walk with their wounds. Antiplatelet therapy is pretty straightforward. Aspirin and Plavix is a mainstay. Cilostazol is a key ingredient to this whole program, with maximizing your dose up to 100 milligrams starting from 50. Now, remember, cilostazol is not indicated for patients with EF less than 40%, so just be mindful of that. Roxaverin or Xarelto at 2.5 BID with aspirin reduced amputation risk from the Voyager. So, and then you've got the endovascular open revascularization. This is the Pletal cilostazol. Showing an exercise tolerance walking distance to be improving using the maximum tolerated dose compared to a placebo or pentoxifylline. So endovascular versus surgical. The bypass wise, as you can tell all the way down the list, I'm not going to go through this. You can read the numbers, but you can look at FemTib bypass, and then a Fem bypass mortality 6% with these surgeries. But expected patency 70% and even less if you go even distally. So with the tools that we have right now, we can eliminate most of this. So this is big, and then I think is one of the key concepts you should take away from this presentation is angiosome concept, and it's the one straight line flow to that area which is of concern. Because studies have actually shown that improved wound healing, you got decrease in major amputation, and then free survival rates. And you've got to look at the angiosomes for the anterior tibial and dorsalis pedis distribution, the posterior tibial, and then, of course, looking at the calcaneum branch of the peroneal artery, which is sometimes the main perfusion of the Achilles area. So you may think it's the posterior tibial, but you've got to keep in mind that that posterior branch or the peroneal artery to supply that area. So be very mindful of that. You do get a lot of different kind of dominant vessels, whether the AT, PT, or the peroneal is dominant. So just be mindful of following it down and make sure you've got adequate coverage in the zone where your ulcer is. Consider alternative access. Dr. Saad and colleagues came up with this great criteria CTOP, which will save you a lot of time with access, either going subintimal, getting your case done quickly. So find it, recognize it. You can try from above and below for most above for most of this, below and for this. This is nidus for going subintimal, so it's going to be maybe a long day. Or if you see this, you keep on going subintimal, just pedal access and move on. Access sites, safer radial, which is a newer technique. You've got external and then manual compression. You've got the transpedal and the proximal tib. Mostly balloon occlusion for this, but you can have external compression using intravascular ultrasound using that. So intermediate wise, you've got contra, antegrade, and then direct SFA puncher, which you can't use a covered stent or balloon angioplasty. And then higher risk areas include axillary, popliteal, and then brachial. So infrapopliteal access is a mainstay if you're going to do CLI work. You may need multiple access, whether it's both, even if it's a ghost vessel. And this is where your ultrasound skills will come into handy here, just to find a ghost vessel where you don't even have a flow into it. Of course, using EVIS equivalent needle and as small access as possible. Typically use a 2.9 Cook sheath to get access. You can put a 0.018 Navicross and an 18 wire through there if you just want to keep small and go all the way through, externalize, and then flip your wire around, and there you go. And then I routinely put a spasmodic cocktail down there, just the nature of the small vessels, and they are prone to spasm down there. This is multiple access, is courtesy of Dr. Matthews. Only in Florida you see this. I'm just kidding, but it's everywhere. And as you can tell, this is the anterior tibial distribution. As you can tell, the anterior tibial is occluded here. Looks like a dominant peroneal and maybe a smaller PT coming in. And so he's got bilateral access in probably most likely either a vessel which is ghosted or which you saw on ultrasound of both the PT and the dorsalis pedis. So the toolbox, there's a lot of tools out there. And as you can see with the booths around here, it gets intimidating to remember which one's going to be which and which one do you want to use. And so it's one of my favorite shows when I was growing up. It's nothing better than a case feeling accomplishment of a successful case, but using the right tools for the right case is exactly what you need to be doing, because you can use the wrong tool and have a very long day or a very bad day and a bad outcome. So imaging is key. When you start off with quality DSA images, make sure they're collimated, save you on radiation. Oblique the images when you need to, get your pedal, get your lateral shot and your AP cranials. So like I said, don't get intimidated because there's a lot of tools out there. You just have to figure out what it is. I remember sitting out there before I started fellowship with Dr. Walker, and there was so much tools out there. I just didn't know which ones to use. After a while, you get used to it. You'll figure out which one's best and go from there. So this is my selection of crossing catheters and crossing wires, mostly the Sahi brands. And I just got that from Dr. Walker mostly. And they work extremely well for me, from support catheters, different sizes, and crossing CTOs, whether it be Sion Black for my pedal loops, the Gladius series for the Mongo, the PV, which is one of my go-tos now. And then this is a bad day if you have to get to the heavy tip loads and you saw those 20 in the halberds. Intravascular ultrasound is all my cases, 100% of my cases do intravascular ultrasound. It tells you everything you need to know about the vessel itself. And I think you've had 2 talks earlier with intravascular ultrasound. The biggest part for me is one, size, of course, but the guidance for atherectomy devices. Toolbox, multiple tools like you've seen over here, so I'm not going to go into details. Stents, including drug-eluting stents from Boston and Cook. Stents come in multiple sizes. You have the dissection repair from Philips, and then you have the covered stents from Atrium, BD, and Gore. So toolbox, DCB scaffolds, and you can do the proximal part. Drug-coated balloons, unfortunately, the deeper stuff from the BTK area either are not approved or suspended. And then the solution before BTK, the Limus one, it should be, I think, completing in September of this year. Drug-eluting stents, down here still working. The Saval and Life BTK are complete and still working. And then you got the Toba 2 with this small dissection repair, which shown promising results. Plaque modification with focal force sculpt. They got chocolate now, and they've got a chocolate with a DCB coming in there too. They got a serrated cutting balloons, which are also for plaque modification. And then you've got the Shockwave, and then you've got the Spur, all with respective great, good looking data, and still more data to come, especially with the new studies. And then finally in the DVA, this is new. I think Dr. Nair's been doing this for us, and it's just a changing over flow and using the venous system to provide perfusion. So I'm going to make this quick, do a case real quick. So with wounds, R6, smoker, this is typical Louisiana right here. You can't see much. My colleague, Dr. Loda, actually did the right side. He accessed a profunda, came in, did a cart, reverse cart, ballooned it, and he's got flow on this side. And he, of course, left the other side for me. Came from radial and actually crossed. As you can tell, the knuckle is kind of big, and you're wondering, once you get the feel that it doesn't push, don't push. That means it was subintimal, and I can tell right here subintimal. So what I did was I could see the ghost vessel here, use intravascular ultrasound, accessed it, put a French in here. As you can tell, the wire comes in, my knuckle remains small, came all the way through, pushed through. You can see it's nice and small, and it pops right through the cap, and I'm good to go. Balloon angioplasty, great flow now, as you can tell, shooting from below. And this is how I sealed it, direct balloon occlusion from below, wire across from above, occluded it, and here's the images. Patient's wounds did heal up, runoff looked good. The CTO we fixed next time because he started getting very aggravated on the table. As you can tell, the flow from the other side looks better, which my colleague did fix before. And here's just the runoff of the other side, knowing that SFA is looking good. So in summary, angiosome with one line flow concept is critical to positive outcomes. They'll be intimidated by the tools available. Find the right tools for the job. Multiple access points are often required with CLI patients, and doing intervention is recorded, but preventive medicine is key. Thank you all. Appreciate it.
Thank you. So our next speaker is Dr. Anish Thomas. He's going to talk about endovascular approach to CTOs, crossing methods and devices.
Thanks. So I'd like to thank the Dr. Walken as well as the course directors for this. Crossing CTOs in the next 10 minutes. You can spend a whole day talking about it. I think Kumar is going to talk more about pedal and stuff. So I thought I'll focus on aeroiliac occlusions. Nothing relevant from my disclosures. Anytime you want to do something, always have an indication for it. It's pretty simple in the aortoiliac space. If you have critical ischemia, it's always indicated to open your iliac vessels if they significantly stenosis in the aorta or the iliacs. Patients with claudication, for the most part, if You failed conservative management, like Amit talked about, you're indicated. For patients with critical stenosis, even if you have not, because of the tendency to develop CLI, it probably may be appropriately indicated in some of these. More often than not, especially in this day and age, for needing mechanical circulatory support for TAVR, even if they are not having any symptoms, but you need to get to the heart, it is indicated. So one thing is, if you can't cross, you can't treat. So for the next few minutes, we're going to talk about how do you cross. Access remains absolutely critical, and it's key to your success. You'll often need multiple points of access for aortoiliac occlusions, most commonly femoral. However, more recently, using a lot more radial, especially with the R2P generation of tools that we've got. I'm not a big fan of brachial because I think brachial artery complications are a heck of a lot more than radial, and very rarely will you need pedal access to cross an aortoiliac occlusion. Ultrasound guided access. Learn how to do it. You're not going to be able to feel your femoral pulses. Ultrasound guided access is key. It'll tell you where your soft spot in that femoral axis is. It'll tell you what your radial size is and so on. Access using roadmap, we've done it for years. Always know how to do it. Angiography is key. Most of the times you might have a CTA, sometimes you will not. And so in this case, take multiple views. Know what your cap looks like, especially your proximal cap. Is it beaked? Is it a flush occlusion? Where are the collaterals? Know what's feeding your distal reconstitution point. Lesion morphology is key because it can get you into trouble, especially if you have a thrombotic occlusion. Study your distal cap. What does it look like? Essentially, you're trying to get to see what your CTOP classification is. I talked about it briefly. Essentially, this is extremely simple. Read this paper by Fadi Saab and his colleagues. Essentially, for a CTOP 1, an antegrade approach should get you through most of the time. Similarly, for a CTOP 4, a retrograde approach is going to get you. For 2 and 3, chances are you're going to need both an antegrade and a retrograde approach. For crossing these, you need adequate guide wire, adequate sheath support. If you're coming for aortoiliac, most of the time now, I tend to use radial access as well. It gives me a support from above, can take your images from above while you get access in your femoral arteries if you need it. There was always a dictum when I trained 15 years ago, it's always easy to cross aortoiliac occlusions from above. That's not always the case. And so look at the CTOP classification. I tend to use a lot of 018 wires. I used to use only 035 wires for the aortoiliac space, tend to use a lot of 018 now at this point in time, especially if you want to try and stay true lumen. If you see a microchannel, an 014 or 018 wire will get you just across. You may need re-entry devices. Learn how to use them. I happen to have all 3 on my shelf. The Pioneer-based device is an IVUS-based device to re-enter. The Outback is similar to the Pioneer, except that there's no IVUS based on it. The Go Back is a little different. Unlike the Pioneer and the Outback, where the needle comes out from the side, the Go Back, it comes from the tip. So you may want to use different devices depending on what your occlusion looks like. So we're going to go through a few cases in the next few minutes. This case was a little old. This was a patient with an external iliac occlusion. I came from up and over. In today's day, I probably would have done this from transradial through and through. So if you're going to get a sheath up and over, you're probably going to need to get a wire into your hypogastric artery. So make sure you don't damage that, because that's your source of collateral to form your common femoral in this case. Once you get your sheath up and over, look at that cap. Take multiple views, you'll see the cap. That's a beak cap. This is a CTOP 1. It's pretty easy to cross from above, which we were able to do. Very easily you get a stent in the external iliac artery. What about a case like this? Once again, if you look at it, it's a densely calcified left common iliac artery occlusion. This looks more like a CTOP 2. So you're probably going to need antegrade and retrograde. We tried to come from above. You can see there's a radial sheath above there, and we've tried to come from above. Not surprisingly, you're subintimal and it's very, very calcified. So here you're going to get retrograde access, right? You're subintimal, you can clearly see that. It's densely calcified, retrograde access, and see where you go. Not surprisingly, you're subintimal back right at the aortoiliac junction. So at this point in time, you can try different things. For the coronary interventionalist, you'll know what COT and reverse COT is. Essentially, you're blowing a balloon in the subintimal space and trying to get either your antegrade wire or retrograde wire to track. This case, we weren't able to do so. So use an Outback. So this is what we did. We used an Outback in this case. You could use a Pioneer, you could use a Go Back, but quite easily able to track that wire through. And that's what it's going to look like. The nice thing is try and see if you can outback into that beak. If you try and outback higher up into the aorta, you're trying to end up with kissing stents, which you didn't have to do in a case like this. Something that's going to be a little more challenging now in your aortoiliac space. This is a cap approximately that's very ambiguous. It's very calcified, not really sure if there's a beak or not, because you can see that, not really sure. Once again, this looks almost like a C-top 3. This is what you're going to go. So you're going to go retrograde once again. You don't know where you are. In this case, before I use a reentry device, I probably will use a wire like an Astardo 20 or an Astardo 40 to try and see if I can get straight into the aorta. Weren't able to do so. In this case, imaging guided access is probably retrograde, imaging guided reentry is probably going to solve it best. So especially at this place where your bailout options are limited, so you used a Pioneer in this case to get through. You're going to end up with a result like that. Case like this, history taking is extremely important. So this is a case a few years ago. This is a patient who had a cardiac cath 1 week ago, now has symptoms of acute limb ischemia. Take pictures, this is what you're going to see. Looks like an occlusion, but this is a thrombotic occlusion. Be very careful about thrombotic occlusions. It's probably going to get you into trouble the most. It's very easy to cross, but sometimes you're not going to be able to get through. This is an older case. We used a combination of a penumbra with a filter device, and we're able to take care of the common femoral thrombus. However, that got stuck. That's a mixture of plaque and dissection and thrombus down there in the external iliac. That's quite easily able to be taken care of with the balloon expandable covered stent and get a good result with thrombus that looks like that. You're then going to take on more challenging cases for crossing chronic total occlusions. These are task D cases. This is something like a task D. This is an infrarenal aortic occlusion, probably a few millimeters below the renals. Look where the reconstitution point is. On the right, it's at the common femoral, but you can also see it's probably that external iliac over there is just underfilled. It's patent, use that. On the right, you're not able to see the common femoral on angio. It's probably going to be somewhere there. You can see a hint of it to some extent, but you often wonder what's filling that. For the most part on the CT, I didn't have it shown over here, but this was filling from the collateral pathway of Winslow, where it's your left internal mammary artery that fills the inferior epigastric on this. So know that, because you don't want to damage the inferior epigastric while you're trying to get access retrograde. I often get asked, how do you get retrograde access in the common femoral artery when you have such a short stump? Well, when you use micropuncture, use your microwire and direct it into the lateral circumflex branch, because now you can get a pinnacle precision sheath to get that easily in there. Before you take on task D lesions in your first year of fellowship, talk to your vascular surgeon, because they may want to do an aortofemoral bypass. You can always hash out what the clinical risk profile is for this patient. But for this, pretty easily to cross on the right. On the left, you can get lucky for something like this. This was a reverse cart. Basically, you angioplasty the subintimal space on the left, the wire just tends to fall into something like that. But know how to externalize a wire. There are multiple ways you can learn how to do it, and you'll get a case like this and a result like this. So, in conclusion, when you're crossing, anticipate complications. Perforations, very common. Know what your bailout is. So you have to have bailout equipment on your shelf, not just covered stents. You probably need to have coils as well. So talk to your IR colleagues. They're best at using coils. Recognize thrombotic occlusions. Use distal embolic protection if you need to. And if you need to use embolic protection. More than anything, in summary, study the angiograms, study your CT scan, have a plan B, have a plan C. Because when you're trying to cross these occlusions, develop a cadence, you'll have that. Don't get stuck doing the same thing over and over again. Know what toolbox you have in your lab. Not everybody has access to all the tools. More importantly, when you're starting off as fellows, know your limitations. Because while you think you're almost there, some of you all are in an advanced fellowship, most of your learning is still to come. Take care. Thank you.
Thank you. Our next speaker is going to talk about CLI. He's none other than the amazing His Majesty, Dr. Sri Kumar Magister.
Yeah, thanks so much. I'm here for the diversity section. It's an honor to be in front of Mac here because I don't know if you know this, but he's the youngest professor ever been granted professorship. He's won every award in Texas that nobody cares about. But thank you so much. We're here to talk about pedal loop and DV. I don't know why the slide's coming in a lighter color, but let's go with that. Can we? Okay. So the goal is talk about pedal loop, which everyone likes to use. It's a sexy term, and DVA, but the question is when and how do we use it, and what are some of the nuances of it? It's hard to cover this in 10 minutes, but I'll try. This is my disclosures. So pedal loop and beyond. So what are we trying to achieve with this? We like to get the great pictures for Instagram and TikTok and Twitter, because if you didn't show it, share it there, it didn't happen. But our goal is to get these pedal loops to get great revascularization to the forefoot, and we'll talk about at the end of the day when that's for. The key for all this, and Anish mentioned some of this in every case, is planning. And I swear to God, the things that go wrong are because of poor planning and poor approaches. Prep everything. You know, for years, it took me a while to tell the tech in the middle of a case, can you prep the foot? I used to get these eye rolls and like kind of just angry teenage responses. Now 100% of cases is prepped, even if we're doing a pick line. I don't care. Just have it prepped. No one argues. It's ready. Patients should know all the outcomes and what's going to happen. And you got to be honest with them that all this fancy stuff that we do below the knee and the foot, it's not going to stay open forever. Be realistic about it, but you're trying to get to a goal here. Your goal are these patients with wounds that are going to take their leg off, or sometimes rest pain that are affecting their life. But be honest about that stuff. We don't have magical cures. I don't know where all you guys are from, but in Chicago, the Midwest, we have this Midwest pannus. This affects most of our cases, and it used to be a nightmare. This is when Mac and Anish will go radial, but I'm a more of a femoralist. And there's a pannus retraction system, which takes this big pannus and it puts it up to their neck. They may have trouble breathing, but that's okay. I can get through my case safe. And that's all that matters to me is make sure your access points are safe, that your closure will be safe. Closure devices, I have fellow seal where I walk away like Superman and the fellow holds pressure for 45 minutes. But if you have to hold it with a big pannus, it's gonna be very difficult. So you got to know what you're doing. There's a slew of catheters, wires, supports, sheets, and you have to kind of have an understanding of all these. You have a lot of companies here, and every single device is, made from the hands of God, but just understand that you should have many different varieties of each and learn the nuances. What really matters in the end is try to find the shortest distance to your lesion, in the pedal especially. Use the longest support sheet to that lesion. Have at least 3 of each support catheter and 3 of each wire at the minimum. If you can have those, then you should have the ability to cross or fix most things that you run into. I have 3 different 014 wires for different reasons: cost, workhorse, CTO, whatever. So have that kind of nuance, learn about them and why, because a lot of technology and research gone into each one of these things. You need to have space. These are 2 of my residents doing a safari case. That red arrow shows where I'm usually hiding with coffee in the control room, but you got to have a lot of space. Everything should be prepped. You should have a lot of comfort zone as to what's going on, your imaging. All these things matter when you're doing pedal. When you're doing the tibial-pedal anatomy and the foot anatomy, there's a lot of great papers. Monzi and our friends in Italy have put out some great papers. Understand the normal anatomy. And what's important in these things that a lot of people still don't do is you have to have multiple views of everything, especially in the foot. When you have a forefoot wound, you have to know is it dorsal or plantar, and you should do imaging in both views, because if you don't do 2 views, you really don't know what you're looking at. So it's really important that you look at multiple views of everything, right? Understand even more the anatomy of variance, because when you have multiple occlusions in your tibial pedals, you have no idea what's going to what. And if there's a variant anatomy, if you didn't have 2-3 views, you don't know what you're chasing. Sometimes you think, I've seen trainees, even partners, look at what they thought was an AT, turned out to be a genicular. So make sure you understand variance too. Shoot the other leg if you have to compare. That helps you. People have talked about angiosomes. Understand what your goal is in the tibial pedal, where it's a forefoot wound. Is it a toe wound? Is it a plantar wound? Is it going to be a TMA? What are you trying to revasc here? We do wound care primarily, so that helps understand wounds. And I think if you're going to do CLI, you should understand the basics. You don't have to do all the debridements like we do, but understand what different wounds look like so you know what you're treating. The mixed ones are the hardest because you have venous and arterial, sometimes lymphatic too. So are you trying to get direct flow to the foot through the pedal loop, or are you trying to get indirect because you don't have a direct target? So our friends Fadi Jihad have a wonderful publication that shows you where are your access points for tibial and pedal. These are very important. You have to think about this before you go into a case. Just like I'm sure cardiothoracic surgeons think about their case before they go in, you should do the same thing. Everything should be prepped. You should know what anatomy and landmarks you're doing. So if I have a great toe wound, now this is kind of a watershed at the tip of the hallux, I would like to have an AT, and sorry for the crude drawings. This is how I send pictures to my referrers and friends, but I have no AT going into DP. But if you can revasc that all the way into the DP and also pedal angioplasty all the way into the first metatarsal, then I can feel confident on the table. I've done my best. This should heal with close follow-up. And that's with the loop. But why is a tibiopedal and all this so hard? Calcium is the scourge of what we have to deal with. It gets painful. We don't have a lot of tools and techniques to deal with tibiopedal calcium. It's a pain. Right now, we usually use balloons, with different kinds of balloons. There's some atherectomy. You got to be careful with that. And there's not many scaffolds you can use down there. Think about how superficial these arteries are, right? There's no self-expanding stents that are 1 millimeter. Waiting for our cardiology friends to make that for us, but we're not there yet. But if you look at this calcific burden, I don't know if you can see on the x-ray in the middle, it's very tight. You can see a tram track almost. And what happens inevitably on the right side is you go subintimal. And just like all the other things you've probably seen, you have to find ways to come from above and below. Here on the left image, you're going from above, below, can't find the same plane. You do the reverse cart techniques. You got to find a way to create a channel, a flap. And then you may be able to get down the vessel and get to the foot. You have to balloon as far as you need to get direct flow. It's not enough just to connect to the DP. Do that AP view and find out, do you have direct blood flow to that wound? If not, you have not succeeded yet. You have these horrible calcium disease that has multiple levels of disease, popliteal, tibial, and pedal. You can see on the right, I'm just happy the wire is going anywhere and it seems to be within the area of the vessel. I'm pretty sure I'm not extravascular. IVUS can help with that. But then you might pop in and be like, this is great. But then you may have multiple disease levels still here. You have it in the DP and beyond. So what do you do here? Above and beyond, it's not going through the lumen. You have to find different ways. I tried ballooning, that didn't work. So what else do you do? There's an age-old technique called push harder. So that's a technique that we use. The far left, this is that Anish had brought this up, the go back or be back catheter. It's a really small one. I use that, and if you look at this, this is just literally ramming that thing because can't find any other way to break a channel. You can try stabbing at it with the needle from the outside. That's called a Pierce technique to break that calcium. I've done that. Just be careful. Sometimes you might get a geyser of blood once you reopen flow, so just be ready for that. Everybody should be aware. But sometimes with that needle, you just kind of shove it in there as long as you're careful. You can always hold pressure if there's bleeding. And when I say you can, a fellow resident can. And then you cross from above, get all the way across, and you can see pulling this all the way through. This is that device we're talking about, the B-back. It's a smaller outback type thing for me. It helps in these situations. And then you might get restoration of flow, and that's not enough. You have to go all the way through the loop to the area of the wound that you're dealing with. Yes, there's a small little bleed that's just from the access site. Somebody will take care of that after the case. But sometimes you're in a situation where only your wire passes. What do you do now? Because this is in that tibiopedal segment, you don't have a lot of options. You'll get an 014 wire. You're so happy you crossed, but now what? Sometimes you can do a little bit of orbital atherectomy or laser small just to kind of create a channel and then proceed. You got to be careful. You have to know that your luminal. Use ultrasound on the outside, IVUS if you feel comfortable. You might not pass the IVUS. And then you can continue on. This patient right here has a DP that's occluded, and it's very calcified on that negative X-ray. If you can see that on those two images right there, it's really hard to pass anything. The wire crosses, but that support catheter, I went shopping in the cardiology lab, all their catheters, Corsairs, none of those passed. So then use a little orbital atherectomy just to cover that area. Be careful. When you hear that crunch and stop, don't push anymore. Bad things can happen. You have to be comfortable with what's going to happen with these cases, but then you might be able to restore flow afterwards. Similar here, here's the pedal loop coming all the way around on a patient that had first and second toe wounds. Your goal is, how do you cross that pedal loop? And I'll tell you, if you're going to do pedal work, consider anesthesia if you have access to it. Having that foot still is very critical. If you look at the images here, having a roadmap with negative DSA, that really helps you watch your wire if that foot can hold still. If a patient has restless legs, you're going to be in a little bit of trouble. It's going to be hard to navigate. But having that roadmap showed me I was going the wrong way in that second image. But then I was able to find the right way because I still have that roadmap. Come all the way around. And antegrade access on these cases are great because then your balloon lengths will be enough to go up and over around the loop rather than coming from the other groin. So you can do that, but shorter the distance, shorter the devices, right? Do the loop and you balloon and you get wonderful results. And also, when you send the images, darken the hell out of them so it looks good for Instagram and all the others. Like, you got to really make it look robust, like a Sharpie. That's what I do. Follow a patient did well. The loop is important. There are studies showing that patients did better with limb salvage with restoration of the loop. The loop is important if your primary flow does not have enough forefoot perfusion. So then you need the loop to recruit more vessels, right? It's a flow phenomenon. I mean, you might have to stick any vessel in the storm. This patient has horrible calcific disease in the pedal planters. This is direct sticking in the lateral calcaneal area of the plantar. Then you find a way to come across, snare it. You might have to repeat, do this, try to find another way down. And you stick anywhere, literally. If you have calcium, that can be a great thing as long as their foot holds still. A lot of them are neuropathic, they may not feel anything anyway. So you could sometimes just stick away, just don't stick through and through. That's not ideal. And then you kind of come across and you're able to balloon it, and you might get some flow that may be enough, may not be enough. Can you do atherectomy? Yes. People use all different types of devices. Be careful. Things can happen. These are luckily some of my friends who are more cavalier in some of this. I do some, but not a lot. But there's different types you can use along it as long as you're careful. And I say careful because you can embolize. So this one, I luckily was able to restore flow after losing the plantar by aspiration because I showered some emboli. Some of them you're not so lucky where devices pop out of the vessel and now you got to call your friends to bail you out. So just be careful with these things. You can do it with a grain of salt. Sometimes you might find things you weren't expecting. This is a post-TMA patient, has a natural DVA, not one that someone tried to. They created an accidental fistula. It's iatrogenic. So it's stealing all the blood from the TMA site. So come across from the venous side, actually coil it, which a lot of us do coiling, and you might find in tibiopedal, you might have to do unique things. And after coiling that venous flow, now you get good antegrade flow. So you never know what you're going to deal with. And what do you do when there's no options? It's going to finish up here. We do the DVA. And how does that work? Basically, you have nowhere for the arteries to go. We bypass it into a vein. And that's how we do it. This is basically a schematic. This has been done decades ago, but now we're trying to find ways to do it off the shelf. We've all been doing it for years now with conventional systems. There is a trial system. And the goal of this is really just to prevent major amputation and rest pain, and mostly for wound patients. There's a lot of caveats to it. We're forcing arterialized blood into a vein to the tissues. It takes a few weeks for that to work. This is a desert foot. You should feel comfortable knowing when it is and when it isn't, when you have that small arterial pattern. This is the device, the limb flow system, the only one in actual trials for a system that does this. They're on their phase 3, which we're part of, and that's going to be a global study. But there's two ways to do it. There's a proximal one where you go at the proximal tibial to the proximal vein and you line it with stents. And there's a distal one where you just connect them to at the artery vein at the ankle. This is what it looks like when you have no good flow in the foot here. You can see this foot wound, desert foot. This is now crossing from the artery to the vein with a reentry device at the proximal tibial level. That third picture is in the venous system. Sometimes a little atherectomy in the artery, then you balloon across the valves to break it open. This is a covered stent to force the blood down the veins. And that's what it looks like now. Now you have an artery to a vein conduit. This is on the table, but it takes 4 to 6 weeks to really see if this is going to work or not. So you need stability in that wound for it to work. So you might be able to get to this kind of situation, but you need a multidisciplinary team to do this. It's not just do it and done. Then we moved on to avoiding stents by doing distal DVA, where we make the connection by the ankle. This is where you kind of stab at the ankle level. And this is what it looks like. When I do it, I have 2 snares, one in the vein, one in the artery, and we're basically sticking a needle through both of them, pulling a wire through both, and just ballooning. That's what it looks like on the right. So this is distal DVA, how we're off the shelf doing this another way to avoid covered stents. That helps with cost, it helps with infections. But again, patient choice is the best. And we stick the vein below the foot to help us deal with some of those valves. A lot more we don't know. You don't do it when it's grossly infected. You don't do it when the wound is not stable. So you have to either have a good team or you have to understand wounds. You want to wait a few weeks. You have to tell the patient family, listen, we don't know what's going to happen. This may overload your heart. You know, we have to be aware of all these things that we don't know. And we're still doing studies to understand this, but we've all seen about a 65% limb salvage rate. Those are patients that are supposed to get 100% amputation. So to me, that's still a win as long as you're honest and you're open about how this stuff works as we learn. And they have to be able to tolerate anticoagulation or antiplatelet therapy. Expect that you don't know everything. We'll figure out how it goes. You need really good follow-up. They should have your phone. The data looks pretty promising from the studies so far on it, and we'll see how the PROMISE 3 goes. And this is just one I want to end with. This is when I did a DVA, and this is a terrible heel wound, obviously, in a 40-year-old diabetic. That's what the angiogram looked like on the right. So I did the DVA, but really there was no real outflow to go. So I was a little skeptical this was going to work. I put a coil into one of the outflows, like maybe this will help. 7 or 8 weeks later, the ultrasound showed the DVA is gone. It's shut down. So I'm not going to go after it. I did an angio though, because he was healing. And that's all the new blood flow that he got in that 7-8 weeks on the far right. So look from start to finish. There is something that's happening. We still don't understand all of it. What we do understand is that we have an option for people. And that's what he looks like right now. He's going to heal. So I'll say the approach to tibiopedal, all this work has gotten bigger and bigger. We're doing more. We still don't know how to fix all these things. Planning is important. imaging is everything, and have some backup and support when you take these on. That's it.
Thank you. So our last speaker for this session, before the lunch and keeping you away from lunch, is Dr. Richard Kovac, intravascular lithotripsy and role in treating calcified lesions.
Hey, good morning, everyone, and great to see such a wonderful fellow turnout. So my task is to discuss one of the newest modalities we have for dealing with calcified lesions, specifically for this talk in the periphery, but a technique that's been applied now to multiple vascular beds, including the aorta, coronary vessels, and even carotids. These are my disclosures. I'm sure I don't have to tell anybody here that calcium is not our friend. It's something that can be really the bane of your existence during any type of interventional case that prolongs the case, leads to complications. As much as we think we can see calcium easily on angiography, often angiography actually underestimates the severity of calcification in vessels. These are going to be some of your most technically challenging lesions to treat. Incomplete balloon expansion, incomplete stent expansion, smaller residual diameters, higher restenosis rates. Sometimes, especially in chronic total occlusions with dense calcium, you may not even be able, even if getting a wire across, you may not be able to get another device through it. Calcified lesions are associated with a much higher incidence of dissections, leading out to bailout stenting. We all know that more stents in the periphery, the more likelihood of restenosis. And again, once stents are deployed, typically they're in heavily calcified lesions, they're going to be underdeployed, underexpanded, and not what you would consider an optimal result. This is just a quick example of how angiography underestimates the degree of calcium, even when we don't see it. The standard angiogram on the left and on the right, a CTA, which shows the calcium at the tightest point of stenosis. So generally speaking, and typically lower success rates with calcified lesions. 74% of flow-limiting dissections occur with calcium. And with balloon angioplasty alone below the knee, limb salvage drops to 56% at 1 year. And with stent fracture, 28% of the time is associated with intense calcification in the area of stent deployment. And obviously, as we mentioned, stent malapposition, incomplete stent expansion. So which patients are most likely going to have calcified lesions? These days, it seems like just about everybody that has peripheral vascular disease has heavily calcified lesions, but typically advanced age, diabetics, and patients with end-stage renal disease. Other predictors of calcium, having not even done an angiogram yet, are patients with elevated ankle brachial indexes. These vessels are non-compressible because of the calcium. Critical limb ischemia. Calcium, as you saw in the previous presentation, you can actually see the calcium on a 4-foot X-ray, and a history of tobacco abuse, particularly in the inflow vessels, iliac vessels, and common femoral and SFA. You're going to see this dense, bulky calcification in those patients. So I think it's important to point out that the key of dealing with calcium is, although we use atherectomy in many instances to debulk vessels, the key in dealing with calcium is to change vessel compliance, make it easier to dilate at a lower pressure so you get less barotrauma, and to allow for better balloon expansion at a lower pressure, as well as better stent expansion and complete expansion at a much lower pressure, and ending up with a larger residual lumen at the end of the procedure. Devices like rotational atherectomy and orbital atherectomy typically deal with more intimal calcium, as does cutting balloons and focus force balloons. Laser doesn't necessarily work well on calcium, but sometimes we can use laser with contrast injection instead of saline injection, so-called granuloplasty. The problem with this technique is that it can cause severe dissection because it's kind of an uncontrolled explosion that occurs with putting laser energy through contrast, as opposed to lithotripsy, which is the focus of this discussion, which is a more controlled way of delivering high atmospheric pressure to the calcium to crack it. Now, lithotripsy has been around for a long time. Any of you who may have been unfortunate enough to have a kidney stone may have experienced this. Basically, we're using sonic pressure waves to fracture the calcium into little bits. And that same technique now has been adapted to catheters, basically microlithotripsy emitters along a balloon, which fire in a sequence to fracture the calcium. The important point being here that the high pressure wave and the bubble that forms is contained within the balloon. So there's an extremely unlikely event of dissection or uncontrolled fracture or damage to the vessel. Basically, the concept is deliver the catheter across the lesion, generate the sonic waves. There's a generator associated with the catheter, crack the calcium, change the vessel compliance, and then safely expand the vessel at a much lower atmospheric pressure. On the bottom two panels, you can see a model of the calcium before and after with the linear fractures. Now, this delivers effective pressure up to 50 atmospheres. I think most of us agree, if you put 50 atmospheres into through a plain balloon catheter, you would certainly risk significant damage, dissection, or disruption of the vessel. The balloon itself, though, is only being inflated to 4 to 6 atmospheres. So to the normal tissue itself, appropriately sized, you're delivering minimal barotrauma to the vessel itself. And again, like any differential cutter, it doesn't affect normal tissue, but it does affect calcium. Little video here showing on the right, showing the expansion of the bubble. Now, this is an uncontrolled bubble in a test model, demonstrating the bubble that's created in sonic pressure wave. And let this run. You probably can hear the pulses being delivered. This is a calcium model on the left, demonstrating how that fractures these little pieces around the balloon. While on the right, holding it in your hand, you basically feel nothing because it does not disturb normal tissue. So there's a reasonably large body of evidence now with the device, basically the Disrupt series of studies. As I mentioned earlier, we're now using this. It's really been a game changer for calcium. We're using it above the knee, below the knee, iliac vessels, especially for things like TAVR. We've used it extensively in coronary calcification now. And it's also been used in carotid, heavily calcified carotid lesions. A number of studies, as I mentioned in the Disrupt series of studies. For the sake of time, we're going to look primarily at the Disrupt 3, a randomized controlled trial, and the Disrupt observational study. This is a randomized study looking at IV lithotripsy versus balloon angioplasty alone, followed by drug-coated balloon angioplasty plus or minus stenting. Primary endpoint was procedural success, meaning a residual stenosis less than 30% without flow-limiting dissection prior to DCB or stenting, meaning with the device itself. Secondary endpoints as listed rather, and powered secondary endpoint was primary patency at 12 months. Key inclusion and exclusion criteria, I'm not going to belabor going through each of these one by one. Baseline lesion characteristics are very similar in both groups, although there are more smokers in the PTA group than in the IV lithotripsy group. Baseline lesion characteristics, important to point out that these were somewhat real-world lesions, long lesions, at least 10% greater than 150 millimeters. All of them were heavily calcified, or I should say the vast majority were heavily calcified. Excuse me. Post-treatment, the diameter stenosis was significantly less in the IVL group versus balloon angioplasty group, and this was statistically significant. If you look at complications, specifically dissections, which we frequently see in these heavily calcified lesions, particularly type C and type D dissections were significantly much less in the IVL group as compared to the balloon angioplasty group. Procedural success, again, defined as that less than 30% residual stenosis without limiting dissection prior to DCB or stenting. Both site-reported and angiographic core lab reported much better in the IVL group as opposed to the PTA group. The Disrupt PAD observational study looking at real-world patients, 90% with moderate to severe calcification, at least a third, almost a third rather, chronic total occlusions, and again, very long lesions. And if you look at every subset, looking at vessel beds, challenging lesions, or complex patients, multiple medical comorbidities, the reduction in vessel size with IVL alone, again, remember, these are only 4 to 6 atmosphere inflations used with this device. A significant improvement in luminal diameter with the IVL alone, improved further either by adjunctive balloon angioplasty, drug-coated balloon angioplasty, or stenting. Observational study outcomes were very similar to the randomized controlled study. Typical case example here. Again, note extensive dense calcification of the pre-treatment slide on the left. IVL, again, low pressure balloon inflations. I should point out it's important to deflate and aspirate the balloon again between inflations, because when you do create that vapor bubble within the balloon, the bubbles accumulate, and it's important to aspirate that out again so that you're giving solid fluid to transmit the pressure wave through. Again, point out the third panels I think is most impressive. Heavily calcified lesion, 6 atmosphere rather, inflation, and already an impressive luminal gain with lithotripsy alone at low balloon inflation pressure, and then the final result. So in conclusion, lithotripsy, or IVL, really represents a great new tool for us to use in peripheral vascular intervention, whether it's above the knee, below the knee, or in the iliac vessels. In these studies, it was superior to PTA for acute procedural success and demonstrated very atraumatic treatment. Reduction in percent diameter prior to DCP or stent placement was superb. Again, low inflation pressures, even in follow-up with the DCBs. Again, reducing the risk of barotrauma or further dissection. Low incidence of dissections, and again, calcified lesions are highly prone to dissecting. And again, randomized control outcomes are similar to PAD3 and the observational registry. Thanks.
Thank you. So I think this would be down the lunch symposium. So please help yourself for lunch. And I think the symposium is going to be also in the same room. Thank you.
Standing up here, I was standing like this. I couldn't see it. I would put it more that way for the short. Oh, you can't. Yeah, I can see it. So I was standing back. And here, I didn't realize it was there. That's fine. I can make. Yeah, we can make that work. Yeah, so for the future. Step to the side. I think that's why people want to go.
All right, want to give you a couple more minutes. I know the line's big. Take your time. I get it. Food's food. But we're going to get started in just a little bit. So a couple more minutes, see if that line gets down a little bit more, and then we'll get started.
Oh, no, we're good now. Good afternoon, everyone. I hope everybody's enjoying their lunch, and everybody else will stream in as they get their lunch. I'd like to, first of all, start off by thanking everyone, all of the fellows, for attending NCVH this year. NCVH for me has been an educational experience, to say the least. Just as a show of hands, I just want to get an idea of the fellows that we have in the room. How many of the fellows are vascular surgery? Okay. Interventional radiology? Okay. And interventional cardiology? Okay. So I am also an interventional cardiologist. During my training, the background that I was able to get in endovascular intervention was really limited. I was focused on my specialty of cardiology, but yet I had a very strong interest in acquiring the skill set for performing endovascular intervention. Acquiring that skill set requires some dedication, and you also need a good mentor who can help you achieve those goals. So almost a decade ago, I came for a fellowship with Dr. Craig Walker, really with the only skill set in hand of a passion to learn, wire skills in the coronaries. And, that's essentially it. When I came down to the southern part of Louisiana for an endovascular fellowship, it really expanded my horizons to a great deal, to the point where you get a great foundation of skills and it grows over the course of time. And so what I will tell you is that there's different levels of endovascular intervention, whatever discipline you are. Seek out mentors, seek out fellowships if you can to gain this expertise, or if you have partners in your practice to help you achieve a certain level of expertise. We have a fellowship at the Cardiovascular Institute of the South. We are leaders in training our future fellows and leaders. And so there's going to be ways and avenues for you to learn in the future. So with that being said, I want to again thank you all for being here. I also want to thank BARD for hosting this lunch symposium for us today. BARD's been a specific, tremendous partner, I should say, for both Dr. Amin, myself, and many endovascular interventionalists around the globe. They've brought us many devices that have helped save limbs. They bring new technology to the field that really is disruptive in how we can treat patients and how we can most effectively heal our patients with peripheral vascular disease. So we're going to start by talking about some of these devices. And I'm going to start off by talking about a new device that's on the market. It's called the Highlander. So, we're going to keep this relatively informal. And I'm going to ask Dr. Amin, when we deal with infrapopliteal disease, what kind of barriers do you encounter when you treat these vessels?
Honestly, the biggest part I would say is the severely calcified vessels down infrapop, having the difficulty to trying to implement a good balloon expansion in those general areas because the vessel size is so small. Just to find that good quality balloon to actually help us inflate these vessels. That's one of the biggest challenges I think we have.
Yeah, infrapopliteal disease, when you're dealing with peripheral arterial disease, is an entirely different animal than, say, above the knee disease. We're dealing with smaller luminal sizes. We're dealing with highly calcific lesions, many road mines along the way. And when you get a balloon and you're trying to inflate or treat these lesions, oftentimes with the traditional balloons that we have available to us, these traditional nylon balloons, we see a lot of dog boning within these balloons. So what is dog boning? Well, if you have a semi-compliant balloon and you haven't properly maybe pre-treated the vessel, what happens is you're getting inflation in areas outside of the stenotic lesion. So that is the dog bone effect. But if you can utilize a balloon with higher pressure that has more evenly distributed pressure, such as the Highlander, what we're able to do is more effectively crack these lesions and treat them most effectively for a full dilation and more effective treatment. So the Highlander is a new balloon that is available to us that is fiber-based. It is on a 14 thousandths platform, which is specifically very valuable when we are treating infrapopliteal disease. It's compatible with a 4 French sheath. So now we're talking about lesions where, Dr. Amin and I, not uncommonly, will need to do pedal access for treatment. This is a balloon that can cross from a 4 French sheath. It is easy to traverse to the lesions. I've had a chance to use it on several occasions. But what's most striking is its ability to precisely treat the area of interest, fully effectively treat it with high pressure up to 30 atmospheres. So 30 atmospheres. You look at the traditional balloons, they may go up to 12 atmospheres. Some of them may go up to 10 atmospheres. 30 atmospheres is sometimes what's required in hostile tibial vessels. These balloons come in 2 to 4 millimeter diameters and upwards in length to 150 millimeters. So we have a good profile of balloon sizes and lengths to treat a wide variety of infrapopliteal disease. Now, what I will say is that when you do utilize this balloon, I think you have to understand the physics of angioplasty and utilize that to your advantage. So when I say physics of angioplasty, and I'm not sure this is something that I learned at NCVH, you want to go slow with your balloon inflations, right? Slow inflations are going to be important, and stay up longer with your inflations, upwards of 2 minutes. Why? Because that helps reduce elastic recoil. But if you go to lower pressures, you may be able, with this balloon, you can call it fiberplasty, or whatever you want, but this is a balloon inflation that can effectively dilate this vessel, and you may not even need to go to 30 atmospheres if you utilize some of the physical principles that I mentioned. If you think of silly putty, and you're stretching that silly putty very quickly, you rip it apart. That's how we inflate balloons in coronary arteries, because the end result is going to be a stent. But that also causes disruption and tearing and just in the vasculature itself. So what you want to do is slowly grow that balloon. Is just like stretching silly putty very slowly. It'll stretch and stretch and stretch, without causing the injury. So that is the Highlander balloon. And now we're going to move on to a device, an atherectomy tool, thrombectomy tool, you name it, a device that has really revolutionized the way I treat many patients with differing lesional subsets. So let's talk about plaque. So when you look at plaque, in specifically critical limb ischemia, a study by Narula looked at 239 limbs that were amputated. And what's interesting is that we really are understating the amount of thrombus within these vessels. You look at the stenotic vessels, there were over 70%, 165, and 73%, almost 3/4 of them had included acute and chronic thrombus. Less than 2% of these were due to restenosis, and 25% of these included significant atherosclerosis without thrombosis. So 3/4 had thrombus, 1/4 no thrombus. And you look at it, atherosclerotic disease is present, it's ubiquitous, but it is not the genesis of lesional disease. Thrombus is a big player. And this is related to plaque rupture, which we all learn in medical school as a process where atheromatous plaques rupture, you get platelet aggregation, platelets beget platelets, you get platelet cross-linking, fibrin deposition, and ultimately you get thrombosis. So looking further at Dr. Zeller's work in 2013, when we think of a vessel as having severe calcification, we may be actually overstating the amount of calcification. Sure, that vessel is calcified, but there is a lot of thrombus within. We are understating how much thrombus there is quite significantly. And this is from actual debris that is collected in the vessel during treatment. There is a significant proportion of thrombus that is retrieved. So what I'm trying to say to you in the grand major point that I want to bring across is that disease within vessels always typically encompass some degree of thrombosis. And so Rotarex is aimed at treating these varied disease processes. It's indicated currently for treating native bypass grafts, artificial bypass grafts, stent grafts, in-stent restenosis, atherectomy, and thrombectomy. So you have a dual indication of atherectomy and thrombectomy, and I utilize it for both. So looking at the device itself, this is it has a rotating atraumatic catheter head with a blunt facet. So what happens is it's able to modify this plaque as it's spinning and detaches this plaque of various plaque morphologies. And there is a rotating cylinder that causes a vortex around it. And these side windows able to further break down and macerate this plaque and then remove it simultaneously. This via a rotating internal helix that you can see on the right that continuously is rotating, creating a negative pressure at the tip and aspirating away the debris. So one of the questions that we can discuss, and I'm going to show you some case examples, is do you need a filter device for something like this? And I'm going to answer, I've never used a filter device because the aspiration power is so phenomenal. There are two specific devices available. There's a 6 French device and an 8 French device. You know, one size does not fit all in this scenario. So what you want to look at is what minimal diameter is acceptable for which device. Focus less on the maximal diameter. So for the 6 French device, you want to ensure that your vasculature is at least 3 millimeters. So if you have a 3 millimeter vessel, you know, you've heard a lot of talks today about intravascular ultrasound. I highly recommend using it if you're going into a smaller vessel. But if it's 3 millimeters, you can feel safe and comfortable that utilizing a 6 French device. For the 8 French device, for larger, bulkier clots, a 5 millimeter vessel is required. These are both over 18 thousandths wires. It's called the Rotarex wire. It's actually one of my favorite wires to use for all atherectomy tools because the tip doesn't get banged up like some of the other ones. So it has multi-modality utilization. The 6 French device comes in 135 centimeters or 110 centimeters in length. The 8 French, though, comes in 110 centimeter because typically what we're dealing with is more proximal disease with the 8 French device. The rotational speed with the 6 French device is 60,000 RPMs as compared to the 8 French, which is 40,000 RPMs. And you're able to aspirate 45 milliliters per minute with 6 French and 75 milliliters per minute with the 8 French. And the external diameter at the catheter is 2 millimeters on 6 and 2.7 with the 8. So let's go through some cases. These are real world case examples where I utilize Rotarex.
Dr. Nate,
Yes.
before you get started, I guess we all know when to use it, but when do you not use the Rotarex? I think that's a good segue to say, hey, look, don't use this in this particular case. That way we can avoid complications and trouble.
That's a great question. The number one area where you will not utilize Rotarex is if you are subintimal. Let me repeat that. If you are significantly subintimal, I would not recommend using Rotarex. Now, there are cases, you know, where you may be subintimal for a very short segment and you get back into a true lumen for the remaining segment. I would treat it beyond that segment, right? So again, intravascular ultrasound is my guide. I showed you extravascular ultrasound today. I'm telling imaging is going to be important for all of this. Now, the other areas where you may consider using alternative devices, we mentioned calcium. Now, we understate thrombus, but calcium is a problem. Now, you know very well when we're crossing lesions, when we're encountering just really rough, rigid plaques where we're trying to, you know, we start from the finesse phase and graduate to the aggressive jackhammer phase. You know, in cases like that, there may be other tools you may want to consider. But if you're dealing with mixed morphology plaque, you know, coming basically from the fibrotic all the way towards the thrombotic. And my favorite sweet spot is in the softer thrombotic plaque for myself personally, but I've used it in the mixed morphology plaque with success because why? There is thrombus within mixed morphology plaque as well. And I think you're getting a lot of benefit from that. And the no reflow phenomenon is not an issue that I've ever had to face with the Rotarex.
Yeah, I think we've both had SFAs, stented SFAs, which have significant thrombus within it, especially if you look with IVUS. So I would assume this Rotarex is a perfect case for a good in-stent restenosis, whether being fresh, kind of subacute.
Yes, I'll just tell you, without jumping into these cases, because some of that's going to talk about that. But I will just say right now, if you're thinking about using a thrombolytic catheter to declot a leg, think Rotarex first. Why not Rotarex? I have saved myself the headache of putting in a lytic catheter on countless times now. If anybody in this room has had experience with thrombolytic catheters, you know that there is a ticking time bomb. It's like playing Russian roulette. Somebody's going to pop in the brain. You're going to get a bleed. It's going to happen to you if it hasn't happened to you already. So I always answer the question when I have an acute limb, can I potentially use Rotarex? And it's bailed me out from countless number of cases where I had to. You still have to use thrombolytics at times, but this is something that's bailed me out significantly. So I'll get into these cases. This is the first case. This is a 67-year-old male with severe ischemic rest pain, Rutherford 4. The patient was recommended for amputation, but underwent endovascular limb salvage in the past with stenting, turned down for bypass. Symptoms progressed over 4 months, became severe after a month. ABI was 0.2, no flow, noted on duplex. So you can see this guy was going to lose his limb. So he has stents from essentially stem to stern, occluded from the top, occluded from the bottom. This is the nightmare, right? You see this and, what are you going to do for something like this? So you got to cross it. You don't know what's out there, right? You have to cross it and get distal, and you have to do a injection, which I don't think we show here. But what we do after we cross, we do intravascular ultrasound to be able to see what are we dealing with, right? What plaque?
The key tip also is when your wire goes very easily, it just knuckles and pushes, it's soft and there's some definitely thrombus in there. So that's a key tip to know if your wire just sails down with your crossing catheter, you definitely need some aspiration in it to remove this thrombus.
That's a great point. So look at IVUS too. You see what you're dealing with when you drop the IVUS catheter down. First of all, what I did was I looked at the proximal tibial artery, make sure that the size, I'm thinking Rotarex, by the way. Initially when I saw this, if I can cross intraluminally, that was my first thought. Make sure you're 3 millimeters for a 6 French device. And then you start to pull back in the stent. You see all that snowy disease within the stent. That's very collagenous, what you see in ISR, a little bit firmer, harder collagenous plaque. And then you have the true in-stent thrombotic restenosis, where it's almost black within, but you see the thrombotic disease. So this is a case that is in the sweet spot for Rotarex. So Rotarex can seamlessly cross. You drop the Rotarex wire down and you go slow. Slow passes are very important. I sometimes utilize flush tubing, like just to keep some fluid flowing through the system, through the sheath. But I make 2 passes on average, and then I take a picture and reevaluate at that point in time. You can see this person, we had to cross through a stent to get through the other side. So there's 2 stents around the knee.
How many passes do you typically make on something this long?
This is definitely, like I said, 2 passes to begin with, and then I'll just take a puff and see what we got. And I may have to do another 2, but it's usually 2 passes seems to be the sweet spot. And you just do 2 passes of Rotarex, and if this plays, we'll see it. If not, let's see. There we go. So you see it. This is just after 2 passes of Rotarex. No balloon, just Rotarex alone. So you then follow it up with whatever treatment you desire. And you can see here that we then achieve flow restoration back to the foot. Sorry, I just jumped through that. So Rotarex bailed us out from that case. In the past, how would you treat that? Like, lice and prey?
Yeah, pretty much.
Okay.
That sounds about right. Yeah.
Yeah. So here's case 2. This is a 47-year-old presented outside facility with a cold left foot, diminished pulses, and he's young. He had a left great toe ulceration. Over the course of 2 to 3 months, he was having some pain in the leg. At an outside facility, they tried to treat him with lysis, ECOS lysis. He had a fem-pop bypass that was attempted, but they couldn't find an adequate suitable tibial vessel. He had a postoperative course complicated by compartment syndrome, fasciotomies. It was a disaster. This is actually, I have to credit this case as Dr. Walker's and his fellows. So they shared this with me, but I thought it was a great case to show. So this is another case of de novo disease, basically from the SFA. There is essentially no flow, if this will play, down to the foot except for collateralization. And you really don't see much lighting up in the foot. So this is another scenario, but this is now de novo disease. And so in this case, they were able to cross. They confirmed their position in the vessel distally. That's an important point, teaching point. And then you confirm that your vessel size is at least 3 millimeters. They did that with IVUS. And then you can use Rotarex. And then following that, they were able to restore flow to the foot, as you can see here. They did have to place this is actually right after the Rotarex pass. So we have flow. It's not perfect, but we cleaned up a lot of the thrombotic disease. But you can see flow going down to the foot. So post-treatment, what you see here is after stenting, the patient was able to achieve limb salvage. And so this is another case where Rotarex was able to bail us out. This is a last case. This is a case that I did not that long ago. He's 62. He had a prior EVAR by my partner. He had a stent within an iliac. So the EVAR graft was somewhat constrained in the iliac. But he was doing good until he had a dental procedure and they held his Eliquis for 2 weeks. At that point, his left limb occluded down to the common femoral artery. So, what do you do for this? Do you call the surgeon, do a Fogarty embolectomy? Do you, what else could you do? You could drop a lytic catheter in and lyse him for a day or so. But you see where he reconstitutes. So in this case, I immediately said, let's try Rotarex. Now, this is an EVAR limb, right? Automatically, I'm thinking 8 French, right? I want to go bigger. So that's the first thing I do. 8 French now, where am I going to get my access? That's the next question. I have to do a direct SFA stick. Not ideal, right? This is a guy I need to treat. So I went ahead and got direct SFA, ultrasound guided access. Again, ultrasound is important. Able to cross, it was very soft. You can see another closure device that was placed there in the past. 8 French device, Rotarex crossed very seamlessly through the entire graft, had no problems, made 2 passes again. This is immediately post Rotarex pass. So we were able to clean that up quite significantly and restore some flow. And in this case, you have to see that after we were able to restore flow, this patient, this is what we got out of the EVAR limb. That's what 8 French device was able to grab out of that EVAR limb. So now the next thing you have to do is decide how are you going to close this. You have an 8 French sheath in the femoral artery. So in this case, I did get pedal access and I did balloon tamponade because I didn't want a pseudoaneurysm. I didn't want any complications, and we were able to achieve hemostasis. So in summary, before I pass it over to Dr. Amin, we have tools in the toolbox to treat a whole host of different disease processes. Remember that infrapopliteal disease is a specific condition with a lot of challenging, complex plaque morphologies, high pressure balloon inflations, fiber-based. Highlander has an effective means of treating this hostile disease. And if you see anything with thrombus, anything with mixed plaque morphology, you can also start thinking about utilizing Rotarex. And with that, I'm going to pass it over to Dr. Amin, my partner, who's going to switch over and shift gears from the arterial side into the venous side.
All right. Thank you very much, Dr. Nair. Yeah, speaking of, I guess, kind of going on the same kind of flow with Dr. Nair, I was also a fellow of Dr. Walker. I came a couple of years after Dr. Nair. My interventional training happened here in New Orleans at LSU. and started with the peripheral, kind of just love for it. I remember sitting in here with you guys and went in the back and there just watching, and I was like, wow, what is going on? What is all this? What is venous disease? What is this, all this arterial stuff and all these tools that everybody, and we got to, and my curiosity just spiked. Initially, I'm from the East Coast, so my goals were initially to move back to the East Coast, and then you have a talk with my wife and decided, hey, look, is this something? She was like, well, I'll promise you this. Once you get started as attending, you're not going to go back. So get it done now and move on. And she was right, of course, as all women are. And so did the fellowship with Walker, and I don't regret it. It's probably the year of my life. I've learned so much, and here I am on the podium, sitting with my friend and colleague, Dr. Nair, and just relishing in the moment, just how much you learn from a year working with Dr. Walker. And if you truly are passionate about peripheral disease, as most of the attendings that you'll see back in here, Dr. Nair, I see Dr. Beasley in the back, you'll truly understand why we do what we do. And going through a fellowship such as that will really move you on to the next level and to be one of that top 1% or 2% in this country that really do complex stuff. So that's just my side note. So I'm going to move over. This is one of my passions, and venous disease has been an extremely big thing for me over the last 5 years since I got out of fellowship and training with Dr. Walker. And so majority of my practice now, I say, is venous, with probably, I'd say 60, 70% is venous, and the rest of it's CLI, and then I have a small coronary stuff. But I just want to thank Bard for, giving me the opportunity to do this today. I'd like to thank my reps over there. I see Andy, I see Brian, I see John over there, I see Ernie, and then DJ's over there somewhere. So thanks to all. Round of applause from inside. Without them, we can't really do anything. They're our eyes and ears. He'll help us kind of move on. So without them, so I'd urge you to really form a good relationship with your local reps to get you moving. And as a little plug, they do offer a training course on both what we're going to go over. And of course, this guy right here does head it. So come find me later. I'll be happy to talk to you about it if your interest is there. Because Dr. Walker was talking in the business of medicine about this, how venous disease is so prevalent that you really should implement some of this in your practice. So let me get moving on here. All right, so Venovo, the venous overview stent is an excellent stent. Self-expanding nitinol is purposely built for the iliofemoral veins, and it has that really unique tapered ends at the which flare out, which help reduce the stent migration. Now, historically, I'm sure you've heard other stents did migrate. That was more lack of sizing issues. And I think the operator did not use intravascular ultrasound at that point. And I think you heard me earlier say that I use intravascular ultrasound in both arteria and venous, and it's mandatory if you're going to start this to use IVUS and become comfortable for it. Otherwise, don't do it because you're going to do your patient a really big disservice when you have to cut their chest open and dig out the stent from a right atrium. Okay, and you're not going to do that. Your friendly cardiothoracic surgeon is going to do that, but then you've got to see him in post-op and say, hey, what happened? So use it, and it's very, very, very important. Okay, so the delivery system, excellent, easy delivery systems, a triaxial delivery. You can see the device. Here's the lock right here, and it's the slow release wheel and the fast release wheel. Honestly, never used the fast one because this stent is all about precision, and so precise deliverability is key. So using the slow wheel for release and letting it go out in the body itself is the only thing I use, and it's depending on operator. And then you've got the tantalum markers for visibility, so you can really see where they're actually placed, especially on fluoro. And then it's indicated for severe treatment of symptomatic iliofemoral venous outflow obstruction, whether it be PTS related or a NIVL. So vernacular clinical trial, they did this with 170 subjects, and they did this kind of worldwide at 21 sites. It's a prospective randomized, non-randomized, multi-center single-arm study looking at the treatment of iliofemoral occlusive disease. It's core lab adjudicated, and it's used to assess the safety and effectiveness of the actual stent itself for the treatment of symptomatic iliofemoral disease. And so overall patency rates, pretty remarkable, especially for the NIVL, since it's the low inflammatory rate, using for mostly May Thurner kind of fibrotic areas. It's a 93%, that's 36 months, which is actually very respectable. However, PTS, just the nature of the disease process itself and the inflammatory process after a large DVT, it's down to 70% at 36, but still, I've been using this stent for about 5 years now. And honestly, I'm gonna knock on wood, hopefully this is wood. But I haven't had any in-stent restenosis, any occlusions, and that's the reliability that I can provide for you for the last 5 years of doing this. And it's the reason that's my go-to stent to use. And the freedom of TLR at 36 months is 88%, which is also excellent too. So the accuracy wise, there's 100% placement accuracy. Now, historically in the past, we used to build the IVC or the stents into the IVC to create a double barrel. Now, if I need to, I reconfigure and build my own bifurcation using the actual flared ends of the stent and hooking them together on the ostium or the confluence of both the right and left to create my own bifurcation. So 36 months, 0 stent fractures, and then 0 migrations because of those flared ends, which you really can't beat. All right, so here's one of my cases, little motion here, so sorry about that. But it's a 24-year-old male. This is actually one of my first patients, maybe my first year or second year, coming out of fellowship with Dr. Walker. 24-year-old guy comes in, he worked in McDonald's, really nice guy. And he was so embarrassed to come in because his legs were he was like, Doc, my legs are horrible. I can't go to the beach. I can't wear shorts. And I was like, okay, fine. So, got him undressed. And then I looked at his legs, and then, unfortunately, I don't have any pictures, and I apologize. And he had legs. I don't know if you know who Barry Sanders is or Emmett Smith and seen the guys with the big thighs. He had one all the way down to his ankles, if that makes sense. And it was just full of varicose veins, the discoloration, the stasis changes. He was up to C4A, 4B at least. And he was just so embarrassed. And he said, nobody's ever done anything for me. Can you help me? And, the pressure's on and the timer's ticking. So he's got severe edema, can't stand at work. He's working at McDonald's as a cashier. He can barely stand for a couple of maybe 20, 30 minutes. He has to go sit down, put his legs up. And he's getting to the point where McDonald's is about to let him go. And so never seen, and the family doctor seen a dermatologist before, give him some lotions, here's some steroids kind of stuff and moving on, but nothing. So here I bring him to a venogram and I take a look. As you can tell bilaterally, he's got severe stenosis at the level of the external iliac vein on the left right here. And then maybe some pancake or flattening, as you can tell right here on the ostium of the left. The right side is also compressed. On this side too, as you can see, a severe stenosis on that side too. All right, here's IVUS. And like I told you, IVUS is the proof in the pudding. And so we're coming down with a pullback. Here's from the IVC coming down. Let's see. And we're going to keep on pulling back. As you can tell, and here comes the stenosis right here, and it's right on the catheter itself. You can see some white hyper bright areas. There's some scarring in that area. The arteries positioned at the top and go from there. And so, as you can tell, the severe stenosis right there. Looks like this is the left side. Oh, moving on to the left side. Hang on, let me see. Yeah. So the left side was about the same. So this is, like I said, one of my first cases, and we built it back up there just for the nature of the disease. So this guy came in a couple of weeks later for post-op, and he was so happy. He says, Doc, I've lost about 20 pounds of weight. And I was like, 20 pounds? He's like, yeah, I had to buy new pants. And I was like, this is 2 weeks. And he was like, yeah. He was like, I've lost so much fluid. I've been going to the bathroom so much. I have no idea what's going on. My legs feel better. I sleep better. I don't have restless leg. I don't have cramping. He was just ecstatic.
Can I interrupt?
Yeah.
So this is a really interesting case, young guy. What do you think is the underlying disease process that he had? Because that's bilateral. It looked fibrotic. I mean, that's an interesting venogram.
I personally think it's not as common in males, but I think this is a May-Thurner variant with the compression in those areas. He's got some fibrotic areas in the external, which may be another part of the May-Thurner coming down. But there's so many different types of May-Thurner that I've seen where there's compression in the left common iliac vein and then extending down into the right external iliac vein, with some of it extending into the other side. So I think this is what it was. There's no history of DVTs. I don't think this is post-thrombotic. Just the nature of what it looked like. I think this is more of a classic
Yeah.
Maytherner, but like I said, you don't see this in guys. It's
Yeah.
the
It's-
3-to-1
it's
ratio. for them.
unusual. I have one more question, though.
Yeah.
This is for, all of our fellows. Sizing the stent. So do you look at cross-sectional area? Do you look at the diameter and average it? I mean, how do you do it?
That's actually a really good question. And this is the way you avoid migration. And so IVUS is going to tell you exactly where you need to be. It's very difficult to look at an area or an area of the vessel when it's heavily fibrosed. So you can't get a good reference area. So what do you use? Or in general, where do you start? So if you've got areas where are good, you use those areas as your reference and you compare it. So if you're in an external, for example, find a good reference area in the external. Dr. Raju had commented that each individual area should have a minimal luminal area, 200 for the common, 150 and 125 respectively, going down from the external into the common femoral. You can use that as a rough estimate. 16 millimeter stents are a rough size, but this is a male, a young male, a large young male. He's relatively tall. So typically you don't want to put a 14 and so that should be in the back of your mind saying, hey, I'm not going to put a 14 in a grown man. Maybe in an elderly female, man, you get away with that, but you should be looking for 16 and above, and that way you'll get it locked in. So using the corresponding size as a good reference point, that's good way to do it. And it's typically, so for example, this guy, I think he was at 18. So I measured, as far as I remember on IVUS, was about a 17. If I just reviewed it, you won't get a perfect circle, but you'll get the maximum diameter of one angle, which will be a 16, 17, 18 in that range. At that point, for this stent particularly, I'll just put a 1-to-1. I know the stent's not going to take off. The flared edges are just remarkable, exactly what they need to be, and they'll just park themselves and be good. The only thing that you will need to do, especially if the common is 18 and then the external is a 16, you'll have to size appropriately. Otherwise, they're going to feel that severe pain with the stent stretch, because it's nitinol, it's going to grow over in the next week. And they feel the pain, and females have described it as a constant contraction. If you've had children, you don't want that for a week, I promise you. And guys, think of it as a kidney stone for a week. So the stent, sizing is very, very imperative. One, for migration, two, just for, pain wise. That's mostly my algorithm, looking at IVUS, finding a comparative lesion, looking at the other side if it's normal, using that as a rough landmark too. So there's a lot of different areas which you can use. But sometimes, like I said, one size doesn't fit all for sure. And biggest thing is don't undersize. That's your recipe to disaster. So like I said, he came back, felt great. We had some other ablation stuff to do using the vein close device. So we did some some GSVs. And then a superficial small saphenous, and we did that, and he was doing wonderful. I see him every year now. He's doing excellent. He's lost a amount of weight. He's given up his pant sizes. He's down to whatever. He's got married recently. He's so happy he bought a car, and I see him yearly just as a follow-up. So this can happen. This is what you're going to see coming out. It's just a matter of getting your name out there, getting to know your representatives, and get yourself marketed for this kind of stuff. So let me move on. Okay, perfect. So we're going to talk about the ablations, a good segue, doing RF ablations. And so we've got the vein closed catheter. So the only RF device with dual heating elements to treat long and short reflux in vein segments. You can do 10 centimeter burns or a 2.5, depending on which you select is your best option. So indication for use is endovascular coagulation of the blood vessels, GSV, SSV, anterior accessories, and then perforators, which we'll talk about in a little bit too. And then, of course, the contraindicated part, which is don't use it with thrombus in the vein segment to be treated. Catheter size overall, it's an excellent low profile 6 French system. It's got dual heating elements, and you just touch the screen and it selects between the 2.5 and the 10. And then you've got your curved tip markings too. So overall, excellent trackability. You can maneuver it in a vessel because GSVs become significantly tortuous depending on the knee bend. Sometimes they've got multiple varicosities leading off them, so you can maneuver this actual vessel by manipulating the external force on the skin and pushing it through and kind of tracking it through. So it works extremely well. So radiofrequency ablation, quick hands up. Who knows what a radiofrequency ablation is? Quick. Oh, we go. Okay, that's a few. Good. And so initially when we do this, we'll do this for superficial reflux. When you get an ultrasound mapping, if you have an ulceration, if you've got severe venous claudication, severe pain, and you've got severe reflux in it, and it's lifestyle limiting, these are the indications to actually move forward with an ablation. And using the heating element, you can do using tumescence, which is a saline bag full of bicarb lidocaine. You bathe the actual vessel itself in this kind of solution to collapse the vein, and number two is to dissipate the heat that you generate because this catheter generates heat up to about 120 degrees. You'll do a couple of cycles per length and move it out until you get out of the area, and then you can do the subsequent cleanup work if you need to. So what is RF ablation? It's a minimally invasive endothermal procedure for treating venous reflux. The reflux in vein is thermally coagulated, which means you technically are shutting it down, and it's, what your legs do is bypasses it to a different vessel. I tell my patients this: if you think of the highway as the femoral vein and the GSV as a service road, your service road or your GSV has multiple potholes and traffic is backing up and it's not working anymore. So we're going to close it down and reroute everybody to the highway. So hopefully that works, and you can share that with your patients and then send some money towards me because I coined that. Anyway, so moving on procedure, close of the vein, the blood will reroute itself to the healthy veins. And so how it works, like I mentioned, the heating element generates up to 120 degrees using 20-second burn cycles. And moving on, or the vein closed Maven itself, which is the purposely built for the perforators, is 130. And so here it is right here. This is the most likely the Maven catheters. You can tell the smaller burn cycles with the X's. Normally the bigger catheter has 3. This one has 2. Is a 0.5 centimeter burn with a pullback going from there. There's a case at the end here. Let me see if I can move on. And so patients treated with vein closed here ablation itself, you've got this large varicose veins coming from, most likely originating from the GSV, because you can tell it's on the medial aspect of the leg. And this is probably and this is after a phlebectomy also. You get great results, and we've had a slew of these results coming back.
That's a good point. So when I was training and learning, I mean, you see these pre and post pictures of varicose veins, and you're like, okay, so this catheter is going to get rid of that. And the answer to that is you're treating you're treating the conduit. You're cutting the head of the snake off, is what I call it, right?
Correct.
And the tail of that is the varicose vein, and then that's what you're going to be addressing secondarily with phlebectomy and so forth.
Correct. Yeah. So, yeah, don't be fooled. This is like, as Dr. Naya said, you're actually cutting off the supply to this, and over time, once you have external compression when you wrap on it, the blood should not fill in there. Once the blood fills in there, then you get the coagulum that becomes phlebitis, that becomes extremely painful, and then you're going out there. So external compression on something like this is key. If you you can do segmental phlebectomy while you're at it, just making little cuts in there just to let the blood drain out of there. But something like this big is obviously need to be pulled out at some point, and this is post phlebectomy. So the venous disease is there, and there's a lot to do in this realm. So moving on to the Maven perforator catheter, like I said, the smaller 0.5 centimeter catheter. It's the only one used for incompetent perforator veins. So those underneath actual ulcerations itself on the medial malleolus or anywhere, there'll be large perforators, most likely coming from the posterior tibial vein, and you can find those perforators and then actually pinpoint and locate them and actually ablate them. And of course, the contraindications are thrombus, of course. So 0.5 centimeters resistive heating element right there. It's also a low profile, and it's a shorter shaft length with 40 centimeters, also very trackable too. The procedure-wise is different to this, using either the vein close itself is either 6 or 7 French, starting at the GSV distally, just below the knee. This one you can use on either angio catheter, or you can use the sheath itself, depending on which one you're comfortable with.
Well, let me ask another question for the fellows as well. Perforator branches. Why do you treat perforator branches? When do you treat perforator branches? What clinical scenarios?
Ulcerations, a lot of this is, if you really have you're going to need a really good ultrasound tech to find this. And that's your key, is finding that tech who's going to take the time to do an ultrasound. That's not just going to look for DVTs. They're actually going to look for incompetent varicose vein or incompetent vessels in general. The perforators are a little more challenging because it takes a lot longer to find them. But if you can tell them, hey, look, I need you to find me a perforator because I think that's really what's going on. And clinically, the perforator has to be about 3.5 millimeters in size with reflux of greater than 1 second. Otherwise, insurance companies will not qualify you for that. It doesn't necessarily have to be an ulcer. I've treated perforators which have 13 plus seconds of reflux, causing recurrent cellulitis in a left lower extremity. And this was recent, about a month or two ago. It was a reflux and varicosity on the medial side of just below the knee on his left leg, recurrent cellulitis. He was on antibiotics. He's like, "Doc, help me, help me, help me." Found the perforator, ablated it, and he came back a couple of weeks later, completely asymptomatic.
So on average, seat 4 and above.
Seat 4 and above, correct.
Check 1, 2.
So this is the Maven. Actually, the generator itself is very similar to both. You just plug it in and you kind of play, and the catheter is actually recognized right here. The other device, it's a kind of a bluish color, which goes all the way across, and you can click this button on here on the screen and it selects it down to a 2.5. And you're looking for time here, burn temperature, and then watts. You're looking at least 20 seconds or 10 seconds less than 2. So treatment here, as you can tell, ulceration, finding that perforator underneath here will significantly improve this. Along with general conservative therapy with compression, ambulation, weight loss. There's other modalities out there which we won't go into, but perforator wise, you can get dramatic results in short periods of time. And so let me go over this case real quick. I got a couple of minutes. I'm going to kind of go through this. Let me make sure this. Okay. So usual case video stuff. Let me see what going on. So 78-year-old female, long-standing chronic venous insufficiency, decades of heaviness. You'll see this a lot, achiness. Nobody's helped her, cramps at night, tingling, restless leg. These are key questions to ask your patients. Developed a right leg ulcer when she cut herself on the fireplace. Took years and years to heal. Wound care was unsuccessful. Has another wound on her other leg and heal for treatment. Of course, you start off looking at the central vein system. I typically do for anything 6, SEEP 6. And so 4 and above, I typically go to a venogram first and then and go from there. Let me kind of move on here. We're going to look at some perforator, going over the case itself. SEEP 6, barely a 5, but however, VCSS score is 17, which is significantly elevated. And she's got that 5.6, so it's over 3.5 millimeter perforator in diameter with significant amounts of reflux. All right. So ultrasound is key. This is where your techs come in handy. So having a great team with you is important. The ultrasound tech is pretty much the only one that's going to help you here to get access. Unless you're really, really competent and IR guys, you're probably really good at ultrasound stuff, accessing it. So you've got the perforator right here, leading it to this area. This is the most likely anterior tibial vein, which you got to stay away from. And the artery is probably just below it right there. And as the ultrasound going from there, they're going to check to see the reflux. They're measuring the distance, and you should stay at least 0.5 centimeter to 1 centimeter away from the junction itself and go from there. Depending on the length of the actual perforator itself, the Maven is key for this area because it's a small segment. You could use the Maven at the regular vein closed catheter if it's a long segment at 2.5, but the Maven itself is ideal for this area because it's just a short area where you need to ablate in this general zone right here. And you can get controlled focal thermal burn from it. So access wise, you tumescent, you're coming at the angle of the ultrasound guidance, and you're actually going to enter right here coming into the vein. Here you see the actual needle coming in, and this just takes time and practice to do. Over time, this will be easy for you guys to do, and then you access it. And like I said, you can use the regular needle. There we're using an aspiration, a micro needle, and then the wire will go in. This is typically what I use. You can use an angio sheath if you need to. I'm kind of running out of time, so let me move on. And then make a little incision, numb it up, put the wire in, and you see the wire going down into the area of the distal perforator.
Sure.
And let me move on here. Here's the sheath itself. As you can see, ultrasound is key. It goes the catheter. You see it go in. You pull out the actual sheath itself once you've done the tumescence. And let me see if I can move on a little bit. Spend some time. Here comes out the sheath. Make sure you've measured from the distal or the deep veins for a sec, because you don't want to cause those. And here's your ultrasound guide, tech measuring. and you start your cycles, 20-second burns, about 6 burns per cycle. Here's some more tumescence. As you can tell, tumescence is going in, and then they're going up with the heat. Let me see if it gets going. Here we go. And you can tell it's on the screen here. And we're going up to 130, 15 seconds burn. You'll probably do multiple burns in this segment as you pull back 0.5 centimeter and then go from there. And then afterwards, you pull everything out, hold manual pressure, and then go from there. I know it's kind of quick whirlwind, and it's a post-op ultrasound. As you can tell, the perforator is right in this area. Here's the deep system, and it's completely shut down.
So that's a great example of how we treat perforator branches and superficial venous insufficient. I just want to let the fellows know, I hope you're all here on Friday because we're going to actually show a case where we're going to be treating iliac vein compression and utilizing de novo stents, I believe.
Yes, it's a pseudo live case. So it's
Yeah.
supposed to be a live case, but it's hard to find some of these if we don't have some of the diagnostic modalities in Lafayette. So we kind of preemptively taped it and it worked out well. So
and then we're also going to be doing a SEEP6 superficial venous ulcer procedure. So hope to look forward to, I look forward to seeing all of you on Friday at our vein session as well. So I think we should end it here. I appreciate all of you for sticking around and I want to thank Bart again for hosting this lunch symposium. And we're available for any questions. Should you all have any questions, we're here all week. All right. Take care.
thank you.
Ladies and gentlemen, it is time to join your scheduled rotation.
Run the show now.
Okay, guys, my name is Bob Beasley. Let's get started on the workshop rotations. It's going to be cut a little bit short because those guys went a little bit long, but that's good because they had some excellent information. I got to tell you, venous disease is huge out there and you need to learn to take care of it, just like they were saying. So I am going to give you a hard stop right around 1:30, and then we'll get started with the afternoon session. You gonna help clean this off? You're okay. Take care of it, all right? But you get somebody that's super good and knows what he's doing. Read online. I'm in Miami. Hey, guys, I want you to switch to your next workshop. We're gonna have to cut this a little bit short since we went a little bit over on our lunch presentation. So go to workshop number 8 right now, so you'll have some time visiting those folks.
Not great. You're, well, part of it was also just lack of product. We finally got it. There's a bunch of accounts still waiting to get started. All the hospital, and my site included. I'm still not in yet. Yeah, I'm the national PI and I still can't do the project. But I told them that it's gonna take a while to get hospitals up and running. 'Cause that's done. Hospitals, the contracting process will take 6 months. That's good. What is this? Why does CIS have a booth? I don't know. Are they part of the rotation? It's interesting. Oh, yeah, there, I mean, almost always there's like non-fellows. Well, it's all private equity. Yeah, that's interesting. Paul Vascular, but isn't there already a PE company backing Paul Vascular? Self-funded. Yep. if the original people want to do it, they'll get a nice healthy exit with it.
Yeah, you know, it did stay maybe 4 or 5 years. I'm going back now.
You got that?
Well, it's 4 or 5 years. I'll be, you know,
Yeah.
I'll still be, no, I'm not gonna practice. You know. Like 16, get out. I'll do something, but I'm not.
You can't, I mean, what, you're still, your mind's still active, you're still doing stuff. I mean,
You know what? I can see myself getting up late, going, you know, whatever, eight guys, like 9:30, 10, play until 2 or 3, start having drinks. Next thing you know, home by night, cooking, grilling out, and that kind of stuff. And you know, you can do that.
Yeah, what do you do? Yeah, after that, you get bored.
If you do that for a month, like this,
Yep.
you know.
Yeah, I saw what happened to my dad when he stopped working.
Yeah, the kids.
And he just declined fast.
My dad was doing 85.
My dad worked till he was 80, 85. No, 80, 83, as a physician. And then he retired when he was 83. And then, just spent a lot of time on the computer reading stuff, but like didn't work out or exercise and just declined pretty rapidly. He just died. He died at 86, recently.
Well, my dad made it 89, but he was, the last year, he was seeking daily. Trail. I think we'll get you coming down to my meeting. 27.
Yeah, she's coming to the meeting on Wednesday. Yeah, man, she's great. Love her. I'm trying to get her to leave Biotronic and go to one of the startups, you know, the reflow guys been talking with her. She's got both CV and PD experience. She's been in the industry now for 8 years. Yeah, no, so just, yeah. Hey, Kristen, yeah, well, I think she knows of her. Kristen, I was trying to remember her. I think they met before, but yeah, Kristen actually wanted to see if she was interested in joining the market. And I was like, oh, I don't know. I'll ask her. But you know, she's she's 46 and she can't do sales forever, you know, so it's like, wants to do something different. Either do training or marketing or youngest is 10. Yeah, we're doing good. And actually, the ex is supportive of the new relationship and everything. So far, so good. And that's all I hope for. Is I hope if she does ever decide to be married, she says she doesn't want to, but she does. As long as she picks somebody good, then we'll go from there. But she's very pro kid, so I think that's helpful. And she wants to. She's not going to use the kid. I paid a shit ton of money. I'm going to give her like $8.5 million. Pretty much wipe me out. You know what? So I'll make it back. Yeah, I'll do well. And I'm a simple guy. I don't have a lot of stuff. I don't really need much. And my girlfriend also is the same thing too. She doesn't need much. And we get to travel and see things. You know, she's willing to support me along the way too, and all the different stuff. She comes to the meetings, which is great. Yeah, well, I mean, he's 26, the older one. And my two are with her daughter's 13 and his youngest. So, and they live, the oldest stepson, he's out of the house, been out of the house for a while, so. So the two younger ones are, they do great. Yeah, we were all hanging out together this past weekend too, so, yeah, so it was good. 30 seconds.
Okay, guys, let's get to our seats, please. I would like to introduce our first speaker for the afternoon session. It's a great pleasure to introduce Dr. Jay Matthews. He is going to speak today on how we deal with arterial thrombosis and emboli. Jay?
All right, thanks so much. Pleasure to be here as well too. These are my disclosures. I do work with a lot of thrombectomy companies, and you'll probably hear me talk about thrombus at this meeting several more times. So just a couple things. I think these are some very important points when it comes to acute limb, recognizing the 6 classic Ps: pain, pallor, poikilothermia, so it's cold, pulselessness, and then 2 late findings: paresthesia, which is ischemic neuropathy, or paralysis, ischemic myonecrosis. So if you've gotten those 2 last Ps, at that point, there's irreversible damage, and the risk of amputation goes up quite a bit too. So this is the thing though, you'll be at sites, or you maybe even your fellowship or whatnot too, where they say, oh, I just put the patient on heparin, we'll come in the morning and take care of it. Well, there's a golden time window. It's about 6 hours before there's irreversible damage. And the reality is these patients have come in from home and they've already been sitting there occluded. And some of them, if they're younger, will present very acutely, but some of them have been sitting there in pain for a while and not come in. So at that point, you're already kind of past that window anyway. And so the amputation rate goes up quite a bit too, the more time you wait. So 6% if it's within 12 hours of symptom onset, 12% is performed within 12 to 24 hours. And if it's, it's almost over 20% if performed after a day. And that mortality rate is the same as that of inpatient mortality rate for AMI. So we think about time as muscle, and for STEMI cases, well, it's the same thing is true for the legs as well too. It is associated with increased risk of death. So what are the etiologies? Well, everyone thinks, oh, it's cardioembolic and whatnot too from AFib and whatnot. Well, that's actually only 15%. But 15%, that 15% is mostly cardioembolic. Most of it's primary thrombotic itself too. So you get in situ thrombosis. It can be due to just having severe PAD and just stasis, and you get thrombosis as well. And there are other etiologies as well. If we look at what are the first line ways to look at this, you want to do arterial duplex. It's easy, it's fast, tells you what's going on. Don't mess around with a CTA, certainly not an MRA. A lot of these patients have renal insufficiency, so you don't want to give them a contrast as well too with a CTA. And then these limb stages you really need to know because I think it's very important. And for the teaching was that anything up to a Rutherford 2A was fair game from an endovascular approach, but we do now know that our Rutherford 2B patients, these are patients that have an immediately threatened limb, and the Doppler signals are usually inaudible, but the venous signals are still audible, and they have some maybe early muscle weakness, but not frank muscle loss or paralysis at that point too. These are the patients that still potentially could benefit from an endovascular approach rather than having to go in for an open embolectomy procedure. So certainly heparin is good. Remember, heparin doesn't actually dissolve the clot, it just prevents clot propagation. Your body's endogenous fibrinolytic mechanism is what actually allows for clot dissolution or external TPA. And then pain control, you want to improve the perfusion, keep the foot dependent, use bear huggers, maximize oxygen. And certainly if the blood pressure is low, you want to support them, but You do not want to use a lot of vasopressors because you can worsen the whole situation. And surgical embolectomy was the first line for a lot of these patients. It's certainly still something that's okay to do. But a patient's got extensive thrombosis. Sometimes surgical embolectomy is very limiting. And maybe you'll end up missing a bunch of stuff, especially a lot of tibial clot, or if you have a upper extremity case, you may miss stuff in the hand itself as well too. CDT certainly is good because it addresses some of that microvascular thrombus, but there is the risk of lytics, and then also the time it takes for the process to happen. Because if you just drop a lysis catheter and you have no flow, you're still ischemic. And so that ischemic time is prolonged. Pharmacomechanical thrombectomy combines CDT with also some type of thrombectomy. So you can get away with less lytic, but at the same time, you're also extracting out the clot. And so there's less bleeding risk associated with that too, and it's faster time. But catheter embolectomy, which I'll talk a little bit about, and thrombectomy it has the benefit of not requiring any lytics at all, and really it's probably the quickest way of doing it. Now, what happens if you wait? Well, the problem is reperfusion syndrome. So with prolonged ischemic time, and then let's say you go ahead and open everything back up, then you have this reperfusion phenomenon. And then you have the release of inflammatory mediators, of vasoactive factors as well too, free radical damage, swelling, and swelling into the compartments. And then you get muscle ischemia as a result, and further cell death. So the limb will appear hot, swollen, and these patients require emergent fasciotomy. And so if you don't do this, they'll lose their limb. So some centers advocate for upfront fasciotomy. We don't do that. Oftentimes, what we'll do is we'll just do frequent calf, thigh circumference or arm circumference, depending on which limb we're talking about, and make sure that this is not happening. And if it does happen, you do urgent fasciotomy to release the compartment so that they can maintain their limb. And these patients will often require a wound vac and then delayed closure afterwards. So what are the thrombolytic or thrombectomy technologies rather? Well, there's a lot of different ones out there too. I'm not going to go through everything, but you have an ultrasound assisted thrombolysis using acoustic pulse therapy, ultrasound waves, and TPA, rheolytic thrombectomy, which is kind of the angiojet device, which uses high powered saline jets, rotational embolectomy, extraction embolectomy, where you actually literally extract the clot out, aspiration thrombectomy, both powered and manual aspiration, and also thrombus fragmentation devices that break apart the thrombus. And when it comes to aspiration technologies, bigger is better. So this is just indigo as an example, but there's lots of aspiration devices out there. So the larger the orifice area, the shorter the catheter, the more powerful the aspiration force. And that's simple physics. So if you compare like say a 6 French catheter versus an 8 French catheter, it's 150% more powerful than the 6 French catheter. So I think that's something that's very important to understand. And then if you're also going to do the extraction technique like this, there is a technique where you can actually sit on the clot. And a lot of times for discrete embolic phenomenon, if you sit on that clot for approximately 90 seconds, you're able to draw it into the catheter and pull it out of the body. And you're going to want to use a sheath that has a removable valve, because if you try to pull it through a valve, it's going to shear off in the sheath. You're going to clog off the sheath, or lose it's going to fall back out again. So you want to have ideally a sheath like a destination sheath or a dry seal, which you can deflate the valve. That way you can remove it, pull it out of the body intact, and you'll find that you've got a little clot stuck in the end of the catheter. But again, more time is better. So the longer you wait, the more time you have to digest the clot into the catheter itself. Well, there's other technologies coming as well too, and I'm not going to go through all of them. I'll give other talks later during the meeting where we'll discuss some of the other technologies out there. But one of the more popular devices that's out there too is this concept of computer-aided aspiration for ALI. And there's this so-called 12 French catheter. There's also a 16 French catheter called Lightning Flash. This is from the Penumbra Indigo system. And this is mostly a venous offering, though the 16 French catheter and 12 French catheters are oftentimes used for aortic cases. We'll even use the 12 French catheter for the SFA, because the outer diameter of that catheter is only 4.04 millimeters. So 12 French catheter can only go down to the TP trunk sometimes. And sometimes you need to go bigger in order to suck out very discrete, hard clot, sometimes clot that's indistinguishable from bone. That type of material requires direct extraction. And if you're not going to cut the patient open to do embolectomy, you need to be able to extract it out intact. So you'll do a pre-close technique, and then you'll go ahead and go down with a 12 French catheter, and you'll be able to pull it out and do single session type therapy, and not potentially have to use thrombolytics. There's also this new technology, which is called Bolt. And this actually is a very interesting technology I want to talk about very briefly. And I'll show you in just a moment here. And there is data that supports its use. And this comes from the STRIDE study that showed that Target limb salvage was seen in 98% of patients with very low mortality in comparison to patients on what open embolectomy. So this is the bolt system. It's interesting. It's got this pump here, and what this does is it vibrates a column of saline back and forth. It doesn't actually exit the catheter. And by doing that, what it does is it actually changes the friction of the clot, allowing it to actually come into the catheter. So it's cycling between this when it encounters occlusive thrombus versus going into this clot detection mode, where if it's an open vessel, it's actually cycling the pressure so that very little blood is coming back. But when it's on clot, it's going to grab it and suck it and max out the pressure. But when it's totally occlusive, it's been occlusive for a while, it switches into that vibration mode to help bring that clot into the body. And this technology is actually very interesting. Actually I did a case of this actually last night as well too. And what's different here is that I don't think you can hear it, unfortunately, with the audio down, but it sounds almost like a jackhammer when it goes. And what you're seeing here is actually not blood, it's actually saline, because and I should play it again here to hear that sound. That vibration sound is actually the jackhammer. That's saline with very little blood loss. So 90% of that will be saline. And then you can see here, this is the catheter going in, a case of a fem-fem bypass that was presented, late presentation. The patient presented several hours after having shown up to the hospital. You can see this is what we started with. This is with just the wire crossing. You can see total clot through the whole fem-fem bypass going into the whole left leg. Go in with the device. This was done within just a few seconds. And then you can see we have some haziness in the proximal portion of the fem-fem bypass. Put a stent across that. And this is the organized material that was removed. So this, this whole case only took a couple minutes, very quick. So these newer technologies actually are quite beneficial in making these types of endovascular approaches to thrombectomy a lot easier. Many new devices from a lot of the companies that are coming as well too, that will hopefully make these kind of cases more efficient. So remember, it's a life-threatening condition. When it comes to acute limb ischemia, ultrasound is very useful. Direct removal of thrombus with endovascular techniques often can give you rapid resolution of symptoms and hopefully reduce the risk of reperfusion syndrome. When reperfusion syndrome does happen, rapid identification is very important so you can avoid limb loss. And obviously, we need better technologies to reduce blood loss and make these cases a lot more efficient. Thank you.
Hey, Jay, thank you very much. Was that the last technique you used, the bolt technique, or is that with Penumbra's
Yeah,
system?
that's the lightning bolt technology. Yeah. So I've switched to using that now. To actually, I used it 4 times this past weekend. So it's like there are other technologies that are out there as well too. But the idea is you want to minimize blood loss, but make these really organized type clots more efficient to remove.
What an improvement. Okay, next up, thank you, Jay. Appreciate that. Next up, we're going to have Dr. Sahil Parikh. He's going to speak on a pretty big subject, drug-coated balloons and stents in the SFA.
Hey, Bob, and hello, everybody. It's a privilege to be here. I'm going to try to quickly go through stuff. You already heard today from Dr. Ahmed about the SFA. It's going to be where most of you spend a lot of your time doing arterial revascularization. It's a difficult artery to treat, but because of all of these mechanical stress-strain relationships, it's also very highly likely to restenose. I'll summarize a lot of data very simply, saying that basically, so far with non-drug-eluting technologies, there's a linear relationship between lesion length and restenosis. You saw several predictors of restenosis in Dr. Ahmed's talk, but essentially if you use plain old balloon angioplasty, you have a slope that's steeper than if you use nitinol stents, but there's still a slope that's escalating the longer the lesions are. Now, if you're like me or Bob in our practice, the lesions we treat mostly are out here. Long lesions is really the normal day in their life. So how do we improve that? We learned from coronary drug-eluting stents that when you give a drug to the luminal interface from within the artery, that drug will distribute across the artery and then get cleared. And the concentration of that drug over time is related to its effect at inhibiting intimal hyperplasia. I'm focusing on this first principle because it's very important in how you understand how the different products work. So we have in the peripheral arteries drug-coated stents like Zilver, drug-eluting stents, which have a durable polymer that release the drug slowly. Drug-eluting balloons, you'll see very soon an Orchestra biomedical balloon that releases sirolimus like this, and then drug-coated balloons that leave a slurry of a drug and an excipient or a binder on the artery wall, sort of like paint. And that allows for this gradual distribution of drug. And all of them will release drugs at different rates. So to put it in perspective, if you give a drug-coated balloon, you're giving a huge bolus of drug to the artery, and that drug will decay away over time. Whereas if you give a drug-eluting stent, it's more slow in its overall elution. And the area under this curve is related to how much drug artery concentration there is and how effective it is. There's a therapeutic window, and then if you give too much, there's toxicities. Fortunately, with most devices, we never reach that toxicity for very long. So using these first principles, the Zilver PTX stent, which is coated with Bayer drug, paclitaxel, was shown about 15 years ago, and now definitively 10 years ago, to have improved patency compared to angioplasty plus a bare metal stent. And the difference was almost 20%. So a number needed to treat of 5 in order to reduce one restenosis event. Pretty significant. And on the basis of these data, this stent was approved. We learned from Zilver, from our colleagues in Japan, that there were several rules that you should follow. One is you want to be careful about lesion length, because there was still a loss of patency if you had long lesions or if there were small caliber vessels. And if the more of these factors you had, the greater your risk for restenosis. In addition, these devices required antiplatelet therapy, just the way we learned we needed antiplatelet therapy in coronary stents. Later on, the Illuvia stent, which is now currently available also, is a polymer-coated drug-eluting stent. It was shown to be superior in terms of primary patency at 1 year, and then subsequently at longer-term follow-up. And basically in every lesion subset, Illuvia was as good or better than Zilver. And interestingly, even in long lesions, there was still really, really good primary patency. And so the lesion length to restenosis slope was further reduced. When comparing bare metal stents to drug-eluting stents, this is a trial called Eminent that was published a couple of years ago now. If you take Illuvia versus any nitinol bare metal stent and look at 1 year primary patency, you'll see that basically the patency is better for every lesion subset if you use a drug-eluting stent compared to a bare metal stent. Parenthetically, this is exactly what we've learned in coronary intervention, which is why almost nobody ever uses a coronary bare metal stent anymore. And these are the data even out further to past 1 year. So really have to look for a reason not to use a drug-eluting stent, in my opinion. What about drug-coated balloons? Now, drug-coated balloons are a little bit different. All the drugs that are used currently in the US are paclitaxel. But even if you have a paclitaxel-coated balloon from one manufacturer versus another, they are different. So this is an experiment from Juan Granada, who works at Columbia with me. And in our animal laboratory, they took 3 different drug-coated balloons: Ranger, Impact, and Lutonix. This is in pig arteries. What they showed was that depending upon the excipient and the drug dose and formulation, you could get different pharmacokinetics of the drug in the artery wall. So say, for example, Lutonix has very high uptake immediately, but it rapidly decays and goes to almost 0 by 30 days. Whereas Ranger and Impact, Ranger has a lower dose and Impact by almost 40%. Nevertheless, the concentration in the arteries is almost identical. And this is seen in long-term histopathology. Ranger and Impact have very similar reductions of in-stent restenosis as an experimental model compared to Lutonix. If you look at the clinical data, Impact, as perhaps one of the paradigm setters in the field, has curves that look like this: patency that's measured out to 3 years, always superior to bare metal or bare balloon, and then freedom from clinically driven TLR after 4 years. Again, always better than bare balloon. But if you look at 2 compared to one another, this is the compare trial comparing Ranger to Impact, different drug formulations, different drug doses, but they had the same pharmacokinetic profile in animals, and that actually predicted that they would perform the same in people. At 1 year, they have overlapping curves for primary patency, freedom from TLR, whether or not they got stents, whether it was short, medium, or long lesions. All of the curves basically overlap. So the preclinical pharmacokinetics predicts their clinical outcomes. So this is all going to be important when you start comparing it to new devices, and Dr. Walker is going to talk about sirolimus balloons in a minute. But basically, all the drug-coated balloons in the clinical trials were studied in short lesions with low bailout stent rates, but in the real-world registries, the lesion lengths are much longer, and the stent rates are also much higher. So basically, when you're talking about DCB in the real world population, it's really DCB with bailout stenting for most patients. So you saw earlier, there's a veritable menu of options for treating the SFA. How do I choose which devices I should use? Well, I would argue that for the claudicant, you're going to be judged by your primary patency, because that's what's going to keep the patients out of your clinics complaining of intermittent claudication. And so if patency is the measurement that you're going to use to judge yourself, then there are appropriate use criteria that you can lean on. Both SCI, which is an interventional cardiology society, and a multiple society consensus have shown that really drug-eluting technologies, this is DES and DCB, shown better here, that's really what should be used for definitive therapy for the femoral popliteal segment. You have to look for a reason not to use it, in my opinion, because in every lesion subset, those patients who get drug-eluting technologies have better primary patency. So if you're to sort of think about it schematically, bare balloons have a slope that's steeper than nitinol stents, which is steeper than drug-eluting technologies. And you've heard a little bit about vascular mimetic implants like Supera and covered stents earlier today. But really, the drug-eluting technology should be the mainstay of your treatment for the SFA. So you can come up with your own algorithm for how you treat things. This is just sort of my personal view of how I use things. And it's influenced a lot by the fact that drug makes a big difference. Excuse me. There has been some noise in the field about the risk of mortality with paclitaxel. This paper was published in 2018 and really caused a big stir in the field. All I can say is that the real world data from a host of people, Eric Sisemski, who'll be here later this week, and a group of us, the Voyagers trial, a randomized trial in Sweden, and a large Medicare database review have all shown that there's really no mortality hazard in every pre-specified subgroup. The hazard ratio is actually less than 1, and the confidence intervals cross unity. So we don't see really any mortality hazard in real world data. And I would just stay tuned. There's going to be a big paper coming out this summer that will probably put this to rest. So if you look at all of the trials, again, the point estimate is right on 1.0 for risk of mortality with using paclitaxel. So drug-coated balloons or drug-eluting stents should be the mainstay of your therapy. Here's the summary of all the real-world data. Everything is either advantageous for drug or neutral when it comes to mortality. So what's next? You're going to hear from Dr. Walker about sirolimus-coated balloons. There's 2 big programs, the Magic Touch program from Concept Medical. There's a whole host of trials that are forthcoming. And then the Med Alliance sirolimus-coated balloon program, which also has a whole series of trials, both above and below the knee and parenthetically in the coronaries. And Dr. Walker is going to talk about those later on. If paclitaxel isn't dangerous anymore, how do we decide what to use? I would argue now, these are data from the IMPACT series of trials at 5 years with excellent long-term freedom from clinically driven TLR and safety and freedom from major adverse events. So I would say that if you get a sirolimus device above the knee, you want patency greater than 80%, freedom from TLR of at least 70%, and less major adverse limb events and mortality. So that's where the bar is set now for above the knee. Couple of quick things that I'll, in the last few seconds, there's a few new devices. You can imagine stents that have struts unequally distributed around the clock face will have hot spots and cold spots of drug. We're going to see in the next couple of years a hybrid stents that come out with nitinol platforms and a mesh coating that will unify how much drug can be delivered. This will help us deliver sirolimus from stents. They're already doing this in coronaries. And then there's other devices that are going to use both paclitaxel and limus agents in a combined drug formulation that will allow us to give both drugs, which will have some benefits because you can reduce the dose of either of them, which we think might be related to toxicity. So to summarize, I think DES and DCB should be part of the definitive treatment of most patients with FEMPOP disease. Data about paclitaxel safety has been called into question, and it's now been thoroughly disproven. Newer generation drug-eluting stents are better than the older generation, BMS, and the sentence should say, but may have differences in performance. Newer DCB should be a viable strategy for treatment, and new limus-based DCB are forthcoming for above and below the knee. And the next generation strategies of stents and drug-coated balloons will hopefully lead to even better patency and clinical effectiveness. Thanks very much.
Thank you. Dr. Parikh, just briefly, so in your opinion, with this new data coming out on paclitaxel, so you don't think the higher concentration versus the lower concentration paclitaxel balloons right now mean that much?
Yeah, I mean, there's been a lot of marketing discussions about it, but it turns out that most of the drug on the balloon never gets into the patient's arteries, and most of it is washed out of their circulation within 48 to 72 hours. So the dosing on the balloon probably doesn't matter that much. We'll see more data about dosing from this forthcoming manuscript. And I don't think that there's any evidence of a dose effect that's so far been shown.
Very much. Okay, with that, I am going to introduce myself. I'm going to speak on some infrapopliteal stents and give a little bit of information before that. My slides, please. Okay. No disclosures relevant to this. So there's a significant burden of CLI in the world. Over 200 million people worldwide have PAD, whereas cancer affects only about 43 million people, so it's 5 times more prevalent. The mortality risk for CLI over 1 year is about 25%, and over 5 years, it's about 60%. So it is deadlier than cancer. The major amputation rate goes up to about 25% over a year. It's highly morbid, incurring significant mortality, limb loss, pain, and it leads to a considerable economic burden on a national healthcare system. It's been shown in multiple studies that CLI is a very complex disease. It's not like PVD, treating SFA disease. It's extremely complex with multifactorial problems. Dr. Baumann showed us there's significant recoil. Post-PTA in almost all the patients he took a look at in his series. Dirk Scheiner has shown that PTA alone fails to attain less than 30% restenosis and up to 40, about a half the cases he looked at, and dissections occur in about a third of all of the tibial angioplasty. So what happens when we have failed tibial angioplasty? What's the bailout? Well, the bailout right now is still what it's been for many, many years. Off-label use of balloon expandable coronary drug-eluting stents, and these have significant limitations, none of the least of which is compression and crushing of the stent. The evolution of CLI before the 1980s, really mainly all we did with CLI was amputation. Then we started with some medical management, smoking cessation, diet, exercise, weight management, medications, etc. Surgical bypass was then adopted for some distal bypass if you have a nice target lesion. And then endovascular intervention from the 80s and 90s has just progressed with balloon stents, then drug-coated devices as well. And this has pretty much been applied from the coronary interventions. It's also been shown by Andre Schmidt that up to 2/3 of tibial vessels are treated with balloon angioplasty develop restenosis within the first 3 to 6 months. And a large series showed that following balloon angioplasty, the majority of lumen loss is primarily caused by recoil and negative remodeling, with neointimal hyperplasia playing a lesser role. So again, the early recoil is frequently observed and may contribute to restenosis, as shown by Dr. Baumann. He did a series where he looked at elastic recoil, and he said that was observed in almost all the patients in his series with a luminal compromise of about a third at 15 minutes post-dilatation. So the goals of CLI endovascular intervention is to revascularize the target arterial pathway to restore inline patency to the ankle and foot. The preferable pathway is to the angiozone for wound healing to reduce amputation risk. If you're diabetic, you have a lifetime risk of 30% of developing a large diabetic foot ulcer. CLI and infection are the major cause of lower leg amputation in these folks. So let's just talk a little bit about stents. What's on the horizon? As I said, right now, the really only stent that we use is balloon expandable coronary drug-eluting stents. TACs are approved and we can use these in vessels that are not so calcified, although heavy calcification is probably the norm in tibial disease. The drug-eluting stent that was just trialed was the Saval stent in the Saval trial, and it's failed to meet its safety and efficacy endpoint. As far as drug-eluting scaffolds, the Esprit stent in the Life BTK trial is finished as far as enrollment goes, and the results will be reported very soon. The other drug-eluting scaffold is the Motive study, and it's the sponsor is Riva Medical. It is ongoing in this resorbable stent. And then there's a woven nitinol stent, the micro stent, which is in the STAND trial. It's almost complete. Again, we'll take a quick look at the Motive trial. The primary efficacy is composite of limb salvage and primary patency, 6 months. Primary safety, freedom from major adverse limb events and all-cause perioperative death at 30 days. And again, it's just started the trial. The Esprit stent was looked at in the Life BTK randomized multicenter clinical trial. 225 patients randomized 2-to-1 below the knee stent versus PTA. The 6-month primary endpoints are going to be adjudicated very soon. I think at one of the other meetings coming up. Safety endpoint, freedom from male pod, and efficacy endpoints, a composite of primary patency and limb salvage at 6 months. Microstent clinical trials, the STAND ultrasound U.S. pivotal trial is ongoing. Very close to being wrapped up, randomized control trial, 2-to-1 microstent versus PTA with the similar endpoints that we just mentioned for the Saval trial. The HEAL European Registry is an ongoing all-comers trial, post-market perspective and retrospective data study. Primary endpoint efficacy, primary patency at 6 months with ultrasound, and safety male pod at 30 days. Dr. Marco Manzi, who I think is going to be given a live case, is one of the is the PI in Europe. Microstent has a tightly woven nitinol design with a platinum core, which provides great visibility in angiography, IVUS, and duplex ultrasound. It has a low profile delivery system, 3.2 French, for a retrograde or an antegrade delivery system with 5 links and 5 different diameters. This is some examples from the microstent European study. Rutherford 4 patient with a high-grade lesion treated with a 3x40 microstent, post-procedure 10% residual stenosis, and 12-month follow-up. The patient was Rutherford 1, and there was no TLR. Another case, very similar, high-grade stenosis, posterior tibial, treated with a microstent at 6 months, no major adverse limb events or target lesion revascularizations. This is another one from the European study. A Rutherford 4 patient had a 95% stenosis, was treated by a 3x40 microstent in the posterior tibial. You can see the stent is very, very easily visualized there in the middle panel. And then at 12 months, the patient remained Rutherford 0 and had a patency there. This is a study. This is a case from the feasibility study here in the U.S. Rutherford 4 patient presented with a 99% stenosis at the ostium of the anterior tibialis, as well as a high-grade stenosis of the perineal. You'll see here treated antegrade and retrograde. The antegrade treatment was with a balloon, and the retrograde treatment was with the microstent. Following aggressive predilatation, the stent was stacked up against the balloon, and then in a pin and pull model, we were able to release the stent. And then the patient at 6 months remained Rutherford 0 with wide patency. You can see the stent on the far right-hand panel is highly visible. So in conclusion, critical limb ischemia is a global epidemic with few effective tools, although in the future, very soon, we're hoping to have dedicated, intentionally designed devices which are going to be available for treatment, disease management, and wound healing. Thank you very much. Now I'd like to introduce Dr. Craig Walker, Chairman of New Cardiovascular Horizons. Dr. Walker is going to speak to us today on sirolimus-eluting drug-coated balloons.
Thank you, Bob. It's indeed a pleasure to get to speak on something which I think could potentially be a transformative treatment going forward, and that is the whole concept of sirolimus drug-coated balloons. These are my disclosures. Now, we know that there are sirolimus-eluting balloon benefits, and there's solid clinical evidence in coronary artery stents in the past which show that sirolimus is the anti-restenotic drug of choice. At one point, we had paclitaxel stents as well as sirolimus stents and sirolimus analog stents. And clearly, time showed that the sirolimus stents performed better in the coronaries. That does not mean they'll necessarily perform better in other parts of the body, but certainly this was very interesting data. Now, there was interest in creating sirolimus balloons, but these have simply not been developed until recently. Why is that? The most commonly used drug was paclitaxel, which is highly lipophilic and therefore easy to deliver. Sirolimus, on the other hand, was not easy to deliver. But if we look at the effects of the drug, we can see why there was interest. To begin with, the mode of action. Sirolimus and its analogs, or which I like to call the limus drugs, are cytostatic, whereas paclitaxel is cytotoxic. The margin of safety is much higher with sirolimus and its analogs. The therapeutic range is wide. It is anti-restenotic, and it's also anti-inflammatory. And we know some of the early reocclusion is related to some inflammation. Market acceptance is very positive, particularly with the wide experience in coronaries. Problems are that the tissue absorption is very slow and tissue retention is very short. Now, when paclitaxel balloons came out, I was on a panel and I was the last guy to get to speak of the 20-person panel. And people were saying these paclitaxel balloons are the answer that we've been waiting for everything. And every single speaker agreed with that. And this was about, I guess, a dozen or so years ago. And they got to me and I said, well, I don't know if I believe that. In fact, I don't know if I believe that is going to be the drug at all below the knee. And I was sort of looked at as if I had three eyes. And they said, why would you say that? And I said, well, paclitaxel stents did not work below the knee, whereas sirolimus stents did. Now, I really believe, likewise, that paclitaxel may be better for in-stent restenosis because killing those cells might be useful, not just trying to prevent other forms of restenosis. But even early on, many years before it was in vogue, I believe that sirolimus might be the drug of choice, and we'll soon see whether that's correct. So as we look at paclitaxel, because it is so lipophilic, it absorbs quickly and it tends to localize in the subintimal space, and it partitions significantly in the adventition. Remember, we have cell migration from the advent tissue, which results in restenosis. Sirolimus, on the other hand, absorbs very slowly. It spreads through the entire artery where it dilutes to subtherapeutic levels. So historically, with just using the same mechanisms that were used with, let's say, an excipient used for paclitaxel, we were unable to achieve therapeutic levels that we wanted. So in order to design something more effective, engineers had to evaluate these issues and try to solve for them. One, they had to enhance tissue absorption. It's difficult to get sirolimus to enter into an arterial tissue within 30 to 180 seconds of balloon dilation. Hence, we need some form of instant glue, if you would, to transfer the drug from the balloon to the tissue efficiently. Secondly, we need to extend the tissue retention. Sirolimus must be continuously delivered over time, so some form of time release mechanism must be employed to maintain therapeutic levels. And finally, we must protect the drug. A non-crystalline, readily absorbable form of sirolimus from wash-off during balloon delivery and from embolizing during drug employment, because this does not as readily adhere to the balloon as does paclitaxel. So one company came up with this mechanism. There are several Olimus drugs being evaluated, and I do not think that they're all equivalent. This is the sirolimus releasing balloon from Meta Alliance. They're a Swiss company. Now, what have they done? Well, they've created a proprietary micro reservoir technology. And these micro reservoirs combining sirolimus and a biodegradable polymer slowly release the drug. In fact, with release kinetics similar to that of drug-eluting stents. These micro reservoirs are actually miniature drug delivery systems. They have optimal size micro reservoirs to achieve pharmacokinetic release profile similar to best-in-class drug-eluting stents. This gives us consistent and predictable drug release and sustained a therapeutic effect for at least 90 days. Now, we all know that restenosis in the peripheral space occurs much further out than it does in the coronary space. This is, of course, important. And finally, they used a technique which is called cell adherence technology, which is called CAT technology. And here they use a proprietary amphipathic lipid technology, which binds the micro reservoirs, if you would, like glue, to the balloon surface, and then allows the transfer of these to the endoluminal surface of the vessel to allow consistent, predictable release of drug. So there are three ways of binding this coating to the membrane, and they use all. Mechanical occurs as the balloon expands. Biological occurs with these highly lipophilic cell adherence technology coatings. And the third is an electrostatic attachment of the drug. So what about this balloon? Well, here we can see that this utilizes a low dose of drug. And Med-Alliance, and if we look at it and we compare it, the arterial concentrations, even though this is using 1 microgram per millimeter square, you can see that even though it's using a lower amount, the therapeutic drug delivered at 1 hour, 7 hours, 7 days, 28 days, and 60 days is higher than the much higher concentrations drug delivery systems using paclitaxel. And if you look at the drug dose per balloon size, we can see that the amount of absolute drug on the balloon is less. So less drug on the balloon, less drug being wasted, the drug is actually being delivered to the vessel. Now, this is perhaps the most important slide. Notice what the Xiant stent, certainly one of the best stents ever made in terms of drug elution profile and patency. Look at this. It is very similar in terms of its drug elution to the solution device. It is very similar. It has prolonged elution of drug. Now, if we look at this in other ways, we can see there's more efficient drug transfer. There's very little drug lost during the procedures, therefore no drug embolizing downstream or very little. More is retained on the balloon, but notice how much more is delivered to the patient, not just as a percentage. Keep in mind, they have a lower dose and yet are delivering a far higher concentration of medicine to the vessel. So if we look at the solution device, we can see this drug, which is an Olamus analog, it's sirolimus per se, and it's competing with paclitaxel. The coating durability is very robust. Wash off is very low. Drug transfer is 20 to 40 times better than it, 20 to somewhere between 4 and 20 times better delivery of the drug. Therapeutic levels are much longer, and the drug dosage on the balloon is much less. And keep in mind, the whole concept of sending drug downstream when it's paclitaxel is potentially problematic, as it can cause necrosis, and this can be problematic. We've all seen this slide from Forrester showing the sequence of restenosis in coronary arteries. But look at this same slide adapted by Ida in peripheral vascular things. The timing of restenosis is longer in peripheral arterial disease than in coronaries. Therefore, even longer elution profiles are needed in these vessels. Now, unlike nanoparticles, these microspheres can be precisely manufactured to an exact and repeatable particle size and elution profile. And so we see these have been used extensively in the pharma industry to do things, to solve manufacturing problems and create extended release profiles and reduce toxicity for otherwise rapidly absorbed drugs, to improve drug stability by encapsulating the drug in a protected polymer, to create precise elution and bioavailability profiles for labile therapeutics, and to deliver local drug therapies to hard-to-reach locations inside the body. Now, this drug was evaluated in a 2-year study by Dr. Tom Zeller as the principal investigator in the solution trial. And we can see late lumen loss was actually quite low with the solution device. And we can see that 6-month need for revascularization was lower than it was with any of the previous studies. Now, these were not head-to-head studies. Nonetheless, at least it suggests this is an effective drug, and we do need head-to-head studies. And once again, we can see the characteristics of this versus other agents which were used. Now, one of the fears based on Katsanis's early article was that paclitaxel drug-eluting devices might have higher rates of death. That has been somewhat debunked. But there were no cases of death in this, no minor or major amputations. Primary patency was exceptional by any standard. And we can see freedom from index leg amputation quite high here. And this was the case even in calcific lesions. So there are a lot of potential applications here, and I'm anxious to see how these work. We're involved in these trials right now, but there are many potential applications in the periphery, the SFA and below the knee, of course, in coronaries, in treating in-stent restenosis, in treating small vessels where we don't wish to place a stent, or in treating bifurcations where we will treat the side branch with a drug-coated balloon and the main branch with a stent. In AV fistulas, to reduce the likelihood of restenosis in shunts, to keep dialysis access open longer, and erectile dysfunction. You know, historically in the Zen trial, stents were placed in the pudendal artery. These are hard to get to, they're hard to deliver. You have to dilate to a fairly large size because the stent will obstruct otherwise. Here one can underdilate with a smaller balloon, less risk of perforation, because if you perforate a pudendal artery, you can bleed to death. There is nothing to stop that bleeding. So this certainly gives some safety. So the initial results are encouraging. We will need head-to-head comparisons against paclitaxel to determine which will prevail. If I were to guess, I think this is going to be better below the knee. I think this will be better in coronaries. I suspect for in-stent restenosis, it may not be as good. Those are my postulates. I have no data on that, but I think there's reason to believe these. I'm particularly interested in sirolimus DCB results in small coronary lesions, in bifurcation lesions, and in below the knee vessels. I thank you very much for your attention.
Thank you, Dr. Walker. Next up, I'd like to welcome Erica Fadone. She's going to be speaking about a spectroscopy to determine O2 saturation, how to do more to achieve limb salvage.
Yeah. Can I get my slides, please? Great. Okay. So I'm here to discuss a new technology that was pretty instrumental in my endovascular training with Dr. Walker. We used it multiple times a day, and it was just amazing. So O2 saturation imaging, chronic wounds are a major health problem, as I'm sure you've become aware of by now, that can have devastating consequences such as limb amputation, which leads to premature death. Understanding what cannot be seen by the eye is the challenge, and that's where this technology comes in. So the most important factor for determining healing potential of a wound is perfusion to that affected segment. We have imaging modalities that have emerged as alternative, less invasive options to assess perfusion. We can determine if tissue is receiving enough blood and oxygenation after revascularization with this device, and it can predict healing and potential clinical outcomes. So types of perfusion testing, of course, we have our ABIs and our Dopplers that measures macro circulation. We have our transcutaneous oxygen monitoring, which measures free oxygen at the skin surface. We have ICG, which measures oxygenation in the microcirculation. However, it's invasive, requires IV dye. And then we have the near infrared spectroscopy, and that's what I'll be talking about today. So it measures not only the perfusion, but it actually measures the oxygen exchange at the tissue or at the cellular level, and it's non-invasive. So the application, it can be used in multiple different ways, used in planning and intervention, and angiosome directed surveillance of the perfusion of the affected segment after intervention, and it can delineate wound topography. It's dynamic, it's fast, it's easily repeatable. You can do it in the exam room. Just going over angiosomes, this delineates a specific vascular territory supplied by a specific artery. It consists of all tissue layers from the skin all the way down to the bone. It helps us treat tissue defects caused by CLI by enabling us to target the artery that feeds that wound in that foot. And then the treatment is based on the angiosome concept, can help wounds heal and may preserve limbs. This is just going over what the angiosome concept is and what each artery feeds in the foot. So the science behind the near infrared spectroscopy, about 5% of the total blood volume is within the capillary network. And this is where the critical exchange of gas, nutrients, and waste occurs, is in these capillaries. If the blood is shunted away from the capillary beds, the tissue bed around, or the tissue around this bed, will be depleted of blood and oxygen, which results in improper metabolism and starvation. So most non-invasive measures of tissue health used in wound management today only assess perfusion and oxygenation at the macrovascular level. And this device measured it at the microvascular. So it provides a non-invasive measure of the oxygen content bound to hemoglobin in the blood just below the surface of the tissue being imaged. So the science behind it, we have oxygen that binds to hemoglobin, and then this device sends 6 different lights of different wavelengths down into the tissues, a few millimeters down into the tissues. That whether that light is absorbed, whether the hemoglobin is oxygenated or deoxygenated based on the electron clouds. And then the light that is not absorbed is reflected back to the machine and presents this picture within seconds. So again, non-invasive, comprehensive measure of hemoglobin oxygen saturation at the microvascular level. So in general, with this device, red is good. Red means we're nice, we're oxygenated. However, we can have a few different causes of red that doesn't mean good. So again, you can revascularize it. You've done a therapeutic intervention such as a debridement, hyperbaric medicine, but you can also have red if you have decreased oxygen utilization. So you have some kind of perfusion mismatch between the deoxygenated blood from the heart and the pulmonary capillaries, or you can have some mitochondrial dysfunction and the inability to use oxygen. But for the most part, red on the imaging is good. And then again, blue, bad. So causes, most common, decreased local perfusion, decreased oxygenation. You can have it with decreased cardiac output states, anemic states, hypoxic states. And then if you have increased extraction of O2 from the hemoglobin due to a hypermetabolic state, such as inflammation or infection. So this helps you in real time think about what's going on. Does the patient have adequate perfusion to facilitate healing that wound in the wound bed and around the wound? You can also document what phase of the wound it's healing in. So is it in the inflammatory phase, the proliferative phase, or the maturation phase? Is your current treatment plan working? Do you have a decrease in the actual area over time? Are you starting to see more red every time you take the picture, therefore an increased perfusion and neovascularization? And does the patient need any more debridement? So is there any non-viable tissue that isn't evident to the naked eye? So again, going back to what we're used to, ABI is the current gold standard for measuring PAD, but 29% of CLI patients had normal or near normal ABI values. Over 100,000 amputations with 40% amputation rate national average within the first year of diagnosis. Challenges with ABI, of course, non-compressible vasculature, which is not uncommon in the type of patients we see in our clinic. You can have collateral circulation, even with complete occlusion of a main arterial supply. It does not assess perfusion to the foot. There's obviously variations in technique based on how it's done, and more advanced arterial disease equates to less reproducible results. Then we have TBIs, not commonly performed. About 13% of CLI patients had normal TBI readings. Again, variable technique, lack of use, documentation, reproducible results makes this not ideal. So going back to the oxygenation and the perfusion, this is a nonlinear relationship. So oxygen drops when the cellular demand is greater than the blood oxygen that is supplied. Makes sense, right? So the oxygen measures the balance between the local oxygen supply and the demand. ABI, TBI, laser Dopplers, Again, they only assess perfusion, but not actual oxygenation. So again, infrared spectroscopy measures cellular respiration. It measures that oxygenation at the tissue and at the cellular level. It's actionable data on oxygen delivery and extraction, helps in clinical decision-making. So you see what lies beneath. So here's a history of arterial disease, developed a right first metatarsal gangrenous toe. He underwent great toe amputation. The picture on the left, the skin, you know, to the eye doesn't look too bad, but you take an O2 stat and you see that around the wound, clearly, he's not perfusing well. So it shows a risk at the flap. So he underwent additional amputation because the initial amputation failed and underwent secondary amputation. So it's time saving. This would help determine the level of viable tissue without having to wait for that tissue to fully demarcate. Again, vascular interventions. So picture on the right, you see him in clinic, doesn't look too great. Pre-intervention, obviously his AT is out. Post-intervention, opened up the AT. You clearly see much more red, much more perfusion, much more oxygenation. So you see the result of the vascular intervention. The phases of wound healing again. So hemostasis begins on the injury. Then you have the inflammatory phase. That's what this would look like on the O2 saturation imaging. You have oxygenation around that peri-wound bed. Then you have the proliferative phase where you have granular formation, angiogenesis, and you start to see new blood vessel growth within that actual wound bed compared to the peri-wound bed. Then you have your remodeling phase where you have your collagen synthesis and actual closing of the wound. And that's what a closed wound would look like on this saturation imaging. So again, research has shown that adequate debridement correlates with wound healing, and this is where this device can come in handy. So you have a wound pre-debridement, 22% oxygenation in the actual wound bed. He underwent more debridement and it went up to 88%. Again, pre-debridement and post-debridement images shows a job well done, but there's still a little bit of section needed more. So this is where we would tell our podiatric colleagues, hey, can you debride this a little bit more? Again, just another pre and post debridement of what that would look like. The other thing that near infrared spectroscopy helps with are cellular tissue products and how is that product taking to that wound. So 1 week post application, you have your skin substitute. Then you see 3 week post application, how much oxygenation, despite, you know, if patient came in with that kind of wound, it's bleeding, it looks good for us, that looks good, but the patient may be like, this doesn't look right. But you can show them in real time, no, it's actually really doing well. Here's all this oxygenation. Here's the data to back it up. Again, exact same thing at implant at 4 weeks and at 8 weeks. And again, you can show your patient what exactly is going on, reassure them that things are going in the right way. And it's just going to take some time. So again, this saturation imaging allows us to access the microvascular tissue oxygenation, not just the perfusion, in a matter of seconds. You literally just take it into their exam room, you click it like a camera, the image comes up within seconds. And then it supports treatment decisions, documents healing progression, and helps us to positively impact patient outcomes. So thank you, guys.
Erica, quick question. Is there any reimbursement for this type of imaging? I know it's amazing, but
No,
do you
no,
know?
not that I know of.
It's crazy because it's so.
It's a really great technology. I wish there was.
Okay, awesome.
Hopefully soon.
Thank you.
You're
All right. Okay, guys. So I guess we're ready for the 9 and 10 workshop rotations. So we'll get pretty much most of these in. And then after that, we'll get ready for a long afternoon with a lot of talks. So go ahead and go to your respective stations. Got 20 minutes. What time is it? It's 27, so. Very much.
You know, he cut my talk off 2 minutes, just like in the last week. I got a statement on May 15th that said 12 minutes, and then last week, 10 minutes. I don't know, I might be a little bit rushed, but we'll see. Don't, you don't, it's not gonna make a cane and take me off the stage, right? No. Oh, there, all right, okay. Well, you got 10 minutes. No, if I go over, it'll be a minute.
We're gonna rest, we're at Senator 13 things. How you doing, man? Let's see. Oh, for sure. Yeah, sure. Tim's here, Tim, and Warren's coming on Friday, Thursday, I think, so, yeah, so here, we're around. Yeah, Okay, guys, let's get started here. I think we'll go ahead and start the next part of the afternoon session. There will be no more workshops today. We'll just have some talks, and then after talks, we'll go down and have a cocktail hour of Meet the Titans. So. So let's get started a little early. We have some folks come in. I'd like to, it's my pleasure right now to introduce Andy Blum from Chicago. He is going to speak on the evolution of medical therapy and peripheral arterial disease. Andy?
Thank you, Bob. And I want to thank the meeting organizers for the privilege of talking to you today. Fellows, we were fellows once, you remember, Bob? If you are fellows here today, then you probably have just taken your boards, or maybe you're studying for your boards. And so you may be up on latest data on medical therapy for arterial disease. So what I've been tasked with in the precious few minutes allotted is to talk a little bit about the evolution of medical therapy in peripheral arterial disease. In other words, we're going to review the landmark studies that got us to where we are today, as well as to talk about some of the bumps in the road. And these are my disclosures. So I think I should preface this talk by saying that evolution is not always a step forward in the right direction. And atherosclerosis is a lifestyle disease. And so no medical regimen that we've developed and no pill that we can give a patient is as important as encouraging them to adopt a healthy lifestyle. So it all began with the Framingham Heart Study, and this was commissioned by Congress in 1948, and now is well into studying the third and fourth generation of the populace of Framingham, Massachusetts. And it was Dr. Cannell, who was the director of the earlier phase of the study and the author of the first paper that came out of the Framingham Heart Study, that first coined the term risk factor when it comes to cardiovascular disease. And he identified the risk factors that still are the traditional risk factors that we refer to today. And he also noted that the more risk factors that a patient presents with, the more at risk they are of significant cardiovascular events. And so as doctors, we've learned a lot since those days. You know, the only disagreement from doctors back in those days was not whether or not to smoke, but which is the best cigarette to smoke. So obviously we've come a long way. And this is not a landmark study, but it's an interesting study nonetheless, because it looked at peripheral arterial disease patients who'd undergone bypass surgery in Australia. And it proves to us that it's never too late to quit. In other words, patients who had undergone surgery were encouraged to quit smoking. And you can see that their survival curve, which is depicted here in red, most closely approximates the normal census population survival curve in comparison to the patients who were failed to quit smoking. So aspirin has been around since the time of Hippocrates in a natural state, and was first synthesized by Bayer at the turn of the last century. And within a couple of years, it became the #1 drug worldwide. And it's interesting to note, as in this early advertisement for aspirin, that the prevailing thought was that it does not affect the heart. Of course, now we know differently, that there is multiple beneficial effects in regards to aspirin when it comes to cardiovascular events. The antithrombus trialist collaboration was the first look at aspirin, the first meta-analysis look at aspirin in patients with peripheral arterial disease. It was a systemic review of 42 clinical trials with thousands of patients, noting a 23% reduction in serious adverse vascular events with patients on antiplatelet therapy, which is by and large aspirin in those days. And the benefits were consistent across all PAD subtypes. The Capri study looked at patients with coronary artery disease, specifically at patients with high risk of ischemic events. And they noted in the patient population that there was this pitted clopidogrel, single antiplatelet therapy versus aspirin, and noted a cited benefit in terms of cumulative event rates in the patients on single antiplatelet therapy with clopidogrel. And looking at the various subpopulations of these patients, you noted that it was the patients with peripheral arterial disease that generally drove the the positive outlook in this trial. The CURE study looked at a different patient population, patients specifically with acute coronary syndromes. And this pitted dual antiplatelet therapy, clopidogrel plus aspirin with aspirin alone, and noted a 20% relative risk reduction, but at a cost of bleeding. Major bleeding complications were increased in the patients on DAPT. But if you drill down the bleeding complications into aspirin dose, you see that in patients who were in low-dose aspirin therapy, bleeding rates were very similar as compared to the high-dose aspirin therapy patients. So there comes the notion, if we're putting a patient on clopidogrel, we want to put them on low-dose aspirin. PCI CURE was a subset of the CURE study, looking at patients specifically who undergone PCI, and again, a dramatic relative risk reduction in the patients on dual antiplatelet therapy with clopidogrel. CREDO, a similar study, long-term benefit of dual antiplatelet therapy, clopidogrel versus aspirin therapy alone. So now we have 4 different studies, each with similar patient populations, some of them which included patients with peripheral arterial disease, all pointing to the benefit of clopidogrel, either alone or with aspirin in patients with cardiovascular disease. So what about patients with peripheral arterial disease? We give DAPT to our patients, but is there data in that regard? And it turns out there's little or no data. This was one attempt to study the benefits of dual antiplatelet therapy in patients undergoing bypass surgery. And you can see that in a outcome that included graft occlusion, no benefit in terms of patency and major adverse cardiovascular events, yet at a cost of bleeding. A similar study with warfarin was attempted versus aspirin therapy, and bypass graft patency rates were no different. And this was at a cost, a really severe cost of increased bleeding. I think the death knell for warfarin therapy in patients with peripheral arterial disease was with the results of the WAVE trial. And the WAVE trial pitted patients with peripheral arterial disease, whether or not they underwent an intervention, with antiplatelet therapy versus combination therapy, aspirin plus warfarin. No benefit in terms of MACE, no benefit in terms of MACE and MALE, yet at a cost of bleeding. So about a dozen years ago, we had the introduction of stronger antiplatelet agents, prasugrel and ticagrelor, both with proven definite benefits in ACS. And this is the Triton study with prasugrel, showing a 19% relative risk reduction in patients with acute coronary syndromes, with really a very small cost of bleeding. Similar study with ticagrelor, very similar relative risk reduction at no cost of bleeding. So with the Euclid trial, the makers of ticagrelor, AstraZeneca, really shot for the moon. They pitted ticagrelor versus clopidogrel in patients with symptomatic peripheral arterial disease, primary endpoint being major adverse cardiovascular events as well as limb events, but no difference, both in MACE and MALE with ticagrelor compared to clopidogrel therapy alone. So when you look at the guidelines with in terms of DAPT, all we can say with confidence up top here is that the effectiveness of dual antiplatelet therapy is not well established, and very weak recommendations based upon limited data that maybe DAPT is reasonable in patients after lower extremity intervention. And this sets the stage for alternative pathways, such as dual pathway inhibition with rivaroxaban. And if you were at the breakfast session today, you heard Craig Walker cover COMPASS and Voyager very well. And we'll talk about this tomorrow in the main session as well. Let's move on to statins, first introduced by Merck in 1987, touted extensive lipid-lowering benefits as well as pleiotropic anti-inflammatory benefits with claims of substantial reduction in all manifestations of atherosclerosis, both primary and secondary prevention. The first large analysis was the 4S trial, looking at patients with coronary artery disease, simvastatin versus placebo, dramatic benefits in terms of survival. The heart protection study looked at a similar patient population, including patients with peripheral arterial disease. And you can see the patients with peripheral arterial disease benefit as much as any other patient subset. Statins have a number of other proven clinical benefits in the periphery, including increased patency rates, decreased restenosis rates, increased wound healing rates, even increased walking distances, less claudication with patients on statin therapy. The HOPE trial looked at the benefits of blood pressure management with ACE inhibitors in a high-risk patient population, including coronary disease, stroke, and patients with peripheral arterial disease. And you can see a demonstrated benefit in terms of MACE when it comes to Bramipril in comparison to placebo. And again, looking at the subpopulations of the study, you can see it's the patients with peripheral arterial disease that drove the positive outcome in this trial. So diabetes, we know, is a very bad actor when it comes to patients with peripheral arterial disease. And only in very recent years have we have new classes of agents now that are available to us with dramatic demonstrations of decreased MACE and MALE. And we'll be talking about these agents in the main session as well. So in conclusion, peripheral arterial patients are at highest risk of major adverse cardiac as well as major adverse limb events. Treatment of peripheral arterial disease should always include modification of underlying atherosclerotic risk factors, and large randomized controlled trials focusing on antithrombotic therapy, lipid-lowering therapy, blood pressure control, and diabetes management over the past several decades have developed therapies that are proven to result in reduction in MALE as well as MACE. Thank you very much. One last study to mention, benefits of aspirin in combination. This is reported in The Onion. Aspirin taken daily with a fifth of bourbon greatly reduces awareness of heart attacks. Thanks.
Thank you, Andy. That's excellent presentation of the current evolution of medical therapy and peripheral arterial disease. So next up, the role of radiation protection. This is Dr. Robert Wilson. Is Dr. Wilson here? So what we'll do is go ahead and get started to the next presenter. If Dr. Wilson shows up, then we'll break him in at the in between the cases. So why don't we go ahead and is Dr. Bernardo here? Nelson, are you around? Okay, so why don't we go ahead and have Dr. Nelson Bernardo speak on subclavian intervention, patient selection, and technical aspects. So Nelson, come on up. And then again, if Dr. Wilson should arrive, we'll fit him in, guys, in the middle of the next one, okay?
Good. Yeah, thanks, Bob. Good afternoon. Thank you, Bob, for inviting me over. So I've been tasked to give a talk on subclavian intervention. Basically, I would say I touch on the technical aspect of how we do it on a daily basis, not daily basis, but the cath lab. So no disclosure here. So quickly, right? So I had recently seen a patient, 73 years of age with CAD cabbage, presented with presyncope and angina. So typical history of diabetes, hypertension, and lipids are up. And so they did a cath. This was in another facility and showed mid-LAD lesion. And then as you can see from the angio, right? The left subclavian is totally occluded. You can see the reflux from the LAD to the lima, then all the way to the subclavian artery. And actually, you can even see up to the vertebral and then down. So what they did was they PCI the mid-LAD because the rationale was that patient was having angina. Unfortunately, even with the PCI of the mid-LAD, there was not much improvement of the pain and symptoms. So I got a call and see if I would like to tackle the subclavian. So we brought a patient in, and you can see from my aortogram, right? And typically I do this on an LA of 40, between 30 to 50, but 40 is perfect. And you can see there's the bovine aortic arch. And true enough, when you do a selective shot of the lima, of the LAD, you fill up the lima, it goes all the way up top, right? So the patient was referred for management. So before the patient came, I requested to get a CT of the head and neck. Just want to see the vertebrobasilar system, and it was all patent. So kind of unusual that the patient was very, very symptomatic with a very patent vertebrobasilar system. So anyway, at that time, talking to the friend, I said, okay, that's fine. We'll tackle the subclavian, and hopefully clinically, I'll improve both the subclavian steal and, more importantly for the patient, coronary steal syndrome, right? Because he was having a lot of angina. So let's talk about subclavian innominate artery, right? So typically, Clinical presentation is hand claudication, which we rarely see. Most often, the referrals I get would be Still syndrome from cerebral hypoperfusion. And of course, we also get this corner still post-cabbage with the lima, like what I see in these patients, right? Then, of course, sometimes I've seen this once in my career, limb ischemia because a patient had an axillofem bypass. And so when you have liver, you get ischemia of the legs, right? Then typically findings, literature would say 10 to 20. I typically use a 20 as my cutoff. That means I seem to see 20 millimeters gradient difference between the right and left arm before I say it's significant. Then, of course, you look for end organ ischemic symptoms, upper extremities, brain, and heart. So typically, the referrals we get all the time is mainly from angina and, of course, for presyncopal episodes. So notable, though, is that I think you've seen a lot of cats or patients with occluded, suboccluded subclavian, and usually they are asymptomatic, right? And actually 6, 7 decades of life, and typically they have PAD risk factors. And I'm just listed down all these different etiologies that we see. I've seen a couple of Takayasus, and of course treated a lot of radiation exposure patients with compression of the subclavian, right? And then of course, sometimes unusual congenital issues that we see. So when we talk about revascularization, I kind of highlighted in circle the subclavian we talked about, and I highlighted with the glowing mark would be the innominate artery. This is actually a different set of, I would say, pathology, which I'm going to tackle shortly, right? So typically, if you look at the aortic arch, right, left subclavian is a more frequently involved vessel, and usually it involves the ostium of the vessel, right? And like I said, majority of the patients are asymptomatic, so you don't have really to do anything. And if you look at the literature, actually only less than 10% requires any intervention. I mean, so you see subclavian, leave them alone. You don't have to do anything about it, okay? Now, of course, if the patient is very symptomatic and you decide, hey, patient needs revascularization, so you have two options, right? Either you do medical therapy, which we should do in all our patients, then of course revascularization. And what are the options we can offer this patient? So basically you have either endovascular interventions, which we do in the cath lab, or if not doable, you can send them for bypass or surgical revascularization. So for us, basically as of 2023, stenting is the way to go. And I just plus minus lesion modification because of the new technology available. And then of course, you can ask your surgical colleagues to do either a transposition, right? They just basically reattach the subclavian to the carotid artery or the vertebral artery. Then they can also do a bypass using EPTFE grafting. And of course, rarely you undo a carotid axillary artery bypass if you need to, right? So if you get a patient, refer the patient with subclavian stenosis like what I have, basically the primary treatment option is basically endovascular, right? I think it's an acceptable fact that endovascular is the way to go. So looking at the literature, right, this is the biggest series I could find in terms of indication to do subclavian Still syndrome. This was a paper from China in 2016, where they had about 37 patients and all of them were successfully treated endovascularly. And like I said, this is more of a current technology. All of them were stented and basically a very good patency in 44 months, 94%, and they had 1 TIA, right? So if you think about it, right, subclavian endovascular treatment is the way to go, right? You have minimally invasive. You don't have to get winky talking, right? You don't need to get a cardiac clearance, right? You can just do it right away. And the risk is very, very low. Right? Risk of the procedure is very, very low. And then avoid general anesthesia. And I think there's a lower cost per unit of treatment. And of course, patients, you give them a choice of surgery or endovascular, they always pick endovascular. And I think the more important thing is our long-term patency is very, very good. It's as good as surgical, right? So basically the role of surgery would be if you have unsuccessful endovascular intervention, that's the time you send them to surgery. Now, I'm gonna go through the technique now, right? So how do I do this? So I typically use a VTK catheter, right? A VTEC to cannulate the ostium of the lima, right? Other choices you can do, if you look at the literature or in your practice, you can use a JR4, which is often we use, and then you can use a Simmons catheter. Typically, just pick a Sims 2 right away. Then if a big arch, you go Sims 3, smaller, you got Sims 1. Then of course, my go-to is using the VTK catheter, right? So What I do is a VTK catheter is you preload it on a guiding sheet. The sheet, which is typically I use a 70 cm. You can use a shuttle, Ansel, or a Terumo, right? The length is between 70, 90. You should be fine. You have enough length in terms to go to your subclavian. So it's preloaded. And, you use an 014, 018, or 035. It's up to your choice. So the approach to the treatment would be either antegrade, that means you go for the femoral, which is my usual access, 7 French or 8 French, and I will talk about that shortly. And then, like I said, the length 70 to 90 is more than enough. 70 is more than enough. Then, of course, you do retrograde when you have a very unfriendly aortic arch, a type 3 arch, which you have difficulty doing antegradely, right? The only thing I need you to remember, if you do retrograde from a radial approach, then the sheet size is going to be an issue, right? If you need a 7/8 French, maybe you can go for the ulnar, right? But if it's radial, most by 6 French, then of course you can always go for brachial, right? The only problem with brachial is, as I think you're very much aware, complication rate, vascular access complication rate is about 12% to 15%. So that's an issue that we have to face. And of course, sometimes as CTO, you have difficulty to antegrade. You can do a combination of both, right? You can have a big sheet in the aorta, from the femoral, and then you can have a 5 French, 6 French sheet in the radial to cross the lesion. So you can do a combination of these approaches, right? And then, of course, I was able to cross with Astato, whisper wire very quickly, right? Then we cross the lesion, and look at this, it's very heavily calcified. So what's a treatment strategy? I would say 5 years ago, or 6, 7, 8 years ago, balloon and stent and get out, right? In today's world, you can have modification strategies, right? And then the question all the time is, would I increase my embolization risk? Now, remember, when you have a calcified lesion, either in the coronary, in the legs, or anywhere, we know very well it impairs our crossing with our devices, balloons, stents, or whatever, right? And of course, the more important thing is our definitive therapy, which is stenting. You won't have good opposition to stent to the wall, and so we think, or it's been shown in the coronary world, that it increases restenosis. And of course, one of the things that we worry about all the time is you increase the procedure-related vascular complications. Okay, so what are the toys available? I think you have it all in the booths here, right? Available for lesion modification. You can use rotational atherectomy. You can do a directional atherectomy, mechanical atherectomy, or IVL. And you know very well that one of the if you look at the literature on the fears of our seniors in terms of treating subclavian innominate is embolization to the CNS, right? So I would say choose a device with a low embolization risk. And I think I highlighted here with this slide that if you look at the literature, subclavian artery intervention has a very low embolization risk. It's not well described, but if I treat a subclavian artery today, I'm going to have embolization, which is very, very different from innominate artery. So why is this so, right? This is a question all the time from our fellows that train with us. And sort of this is the answer I'm going to give you, right? This was done way back in '84 from, I think this was from Switzerland, right? Where they've shown on ultrasound that if I have 60 to 70% stenosis of the subclavian artery, right, you can see that, yes, antegrade flow is there, but most of the time I can get retrograde flow. And actually, if you do hyperemia of the upper extremity, you typically see retrograde flow, right? So that means it's very, very dependent on that, what I call the pressure gradient. If I get 80% or more stenosis in the subclavian, that's it. The flow is purely reversed. That means to say flow of the vertebra, which is what we see in subclavian steal syndrome. Then, of course, if you have total occlusions, right, it's basically reverse flow all the time. So like in this patient of ours, which is totally occluded, the expected flow on the subclavian is reversed, right? And the funny part is, even if I open the subclavian, they've shown, right, and this was actually initially described in the late 70s, 80s, that even if I open the subclavian artery, the flow is not antegrade until about 20, 30, 40, 30 seconds after the intervention. And actually, most of it were more than 4 minutes from the intervention. And actually, for full antegrade flow, it takes about 24 hours. So that's what I call as your natural, basically, protection from embolization, right? Right. So treatment plan for this patient was IVUS calcified. I'll do some IVL, then stenting. And I'm not able to advance the IVUS catheter, so I decided just go for the IVL. Now, I think you've seen these pictures all the time, often, right? You see that dilates it. Now, one thing for you guys, right? If you have a complex lesion, after you balloon, just advance your sheet across the lesion. So you won't be struggling in terms of pushing your stent or any device across the complex lesion, right? And then if you are dealing with a very angulated angle, this makes life a lot easier. So make it a habit, right? Advance your sheet across the lesion. Use balloon assisted. Don't just push it in. Either get a dilator or use a balloon. Now, in terms of IVL, the safety, this was from the group of Pete Sukas in Rhode Island. They did 7 patients with 13 lesions, and everything was successful with no complication. I think I'm going to ask to wrap up. So again, this is for fellows, right? So when you stent, these are the views you need to remember. So I got the view at LO40 is our working view, but don't stent in this view, right? Always take like an REO 30 or actually even REO 30 with some caudal, about 15 caudal. And with this view, you can see the takeoff very nicely of your lima as well as your vertebral artery. So that becomes your landmark. So typically what I do in stenting is I do put the stent in, then go RAO caudal right away, and you see where the tip is. Then for deployment, I typically use an LAO caudal view. This is what I call you get the letter T. So that means you'll never miss the ostium, right? If you deploy, I'll tell you, if you deploy an LAO 30, 40 all the time, you'll see that after the procedure, your stent could be hanging out into the aorta. Okay, so this interventions expect improvement symptoms 95% and do a surveillance study. So just to show you how good we are these days, right? If you do stenting, I would say about 10 years on the data that showed on 138 patients, about 84.7%. But remember, this study was a combination of both stenting and balloon angioplasty. So I bet if you do stenting, it could be higher. For surgical revascularization, transposition is the best, right, 100%. But the typical case that I see in the hospital would be do a bypass using a EPTFE grafting, and that's only about 66% patency. So let's do this quickly. I'm out of time, right? So this is basically a patient I just did recently, right? Basically, innominate artery occlusion or stenosis. This is the big difference. Patency might be good, right? 79, 93%, right? This is basically comparable to surgical patency, which has a very high mortality rate. The problem is the stroke rate, right? If you look at this from the European guidelines, they quoted a death and stroke rate of about 6% if you touch the innominate artery. There was one paper recently that I was able to review, and on an N of a 93 patient, 4.3% stroke rate. So that means to say, if you don't really need to touch the innominate artery, leave the patient alone, right? Don't touch the innominate artery if you don't have to. Interesting on this paper was that this was a European consortium. Is that very high risk stenosis rate of 32%, but they were good at looking at the stent that they deployed. If bare metal, 28%, but if you use a covered stent, it dropped down to 4%. So almost like a COBES trial of the iliacs that they showed that if you use a covered stent, you get long-term patency. So let's go back to this patient quickly, right? Again, the views is very, very important. I go LAO 40, then I typically go REO 30, again, I will call that about 10, and you can see, right, the pictures, the takeoff of the innominate and the takeoff of the carotid and takeoff the subclavian. It's very, very important, because the last thing you want to do is you lay a stent and you cross into the ostium with the common carotid artery. Then, of course, I use the VK. One of the technique that I do is, because remember, when you want to use a shockwave, IVUS, everything, you can use an 014-018 system. So the support system is not there. So one of the trick that I do is basically once you cross the lesion, bring it all the way down to the brachial, axillary brachial, then bring it down to the ulnar or to the radial. And with that, even with an 014 system, you have enough support to bring any device down to the lesion. So that's a rule to do, right? And also get the loop so that it's safe, you don't perforate anything. Then with this, I was able to lay a second wire for the common carotid, right? And you can see that's the filter. The filter I typically use is a NAVS 7.2, is the biggest filter we have available these days, right? Now, question is, why did I use an 8 French sheet, right? Because I was planning to use a filter, right? That means to say you have to have enough room to advance a filter. And again, like I said, a second guy for the APD, and of course, we might be using a covered stent. So typically an 8 French would be best in terms of delivering a covered stent. So I was showed no calcification. So all I had to do is balloon angioplasty. You can see it opens beautifully, right? But then of course, there's a lot of recoil, and then we end up with stenting. Again, stenting, the views is very, very important, right? So before I delivered the stent, we advanced the sheet up across the complex lesion. Then after that, we took out the filter, right? Because, right, I have to deliver a stent right now, right? Could I use the 014 to deliver a stent? Yes, you could, but it's just, I think it's easier to deliver on an 018 wire system than 014, especially on this bulky. I think I use an 8 or 9 millimeter stent. Actually, we use a 10 millimeter stent. So we just stent it, deployed, then flare the ostium, and then you get very, very nice result. Okay. Then take down's view and look, right? Look at the filter. So I said EPD saved the day, right? Very, very different from a subclavian on the left side. So something to think about, right? When you, if you don't have to treat an innominate artery, leave the innominate artery alone. Okay, just keep that in mind. So just a sort of before I end my slides is, what about asymptomatic patients, subclavian? Because I must tell you, you're gonna see that all the time, right? I would say if the patient has a lima to LAD, I think you have no choice, right? You open it up because you want to perfuse the lima. Very, very important. Then, of course, you have bilateral subclavian stenosis. I think you want to open one in order for BP monitoring. How many times have we seen patients who are normotensive, and you do an aortogram, and the aortic pressure was 240 over 120, right? Because of subclavian stenosis, right? Then, of course, for dialysis, right? For IPSI dialysis. So final thoughts, right? Endovascular intervention is the first line. I think nobody's going to question you with regards to that, right? Then symptomatic and selected asymptomatic. And I think as of 2023, with the technology available, we can have good long-term outcome as good as surgery. Then I think caution is don't touch the innominate artery if you don't have to. Thank you.
Nelson, thank you very much. That was a very in-depth presentation. And you answered my questions. I was going to ask you about asymptomatic. So thank you. Dr. Wilson went to the wrong meeting room, so he is back, and we're lucky enough to get his talk on the role of radiation protection. Thank you very much.
Well, thanks very much. At least I went to the right city. So he always worries you get older a little bit. So I can't in 10 minutes tell you everything you need to know about radiation protection, but I can try and motivate you a little bit about going to get the radiation protection. The radiation protection industry has changed. Really, not much happened for 50 years. And in the last 2 or 3 years, the level of protection that you can get has dramatically improved. These are my disclosures.
So a very busy interventional.
I want to play this video for you.
Of course, their lifetime may get as much as 50,000 chest X-rays exposure to their head. Well, if you look at nuclear power plants, or an interventional cardiologist, the average interventional nuclear cardiologist will get probably 3 to 5 times the radiation exposure of a nuclear power plant worker.
I don't think any interventional cardiologist does it sometimes at night, lean back and think about what would happen if they get a glioblastoma of the brain. That's, I would say, every interventional cardiologist's fear.
I was diagnosed with prostate cancer in 2018. A year later in 2019, I was diagnosed with lymphoma.
I sort of looked in the mirror one day and thought there's a bit of a spot on my nose. And I thought, well, it's just a spot. Then I got a call to say, actually, you've got a highly malignant, highly invasive basal cell carcinoma with very nasty features, and you're going to need to have it operated on. Sorry. I haven't really spoken about it like this. But it was, you can see, it was a really difficult time. by that stage, I had sort of decided I was going to give up cardiology.
You know, the administrators look upon it as a cost to simply keep a person protected from getting radiation. One day, either have a major orthopedic injury, a spine injury, a knee, a hip, or a cancer. And literally, they'll say, oh, we can't afford it. The insanity of saying you would not do everything humanly possible to protect healthcare workers is nuts.
I don't think I should be making those choices. It's my health or the patient's health.
I'm angry with hospitals that deny the fact that we are at increased risk and that actually we're dismissed in a way. And that if you have a problem, it's because you haven't been wearing your protection. That's why systems which cut down scatter, I think, are going to be important.
How many of you are concerned about the amount of radiation that you get in the lab? So I would say that's a majority. And I think as you get to be older, you're going to have a lot of friends that have problems, and you're going to probably wish you'd been more protective than you were. So just a little bit about scatter radiation, only about, and this is surprising to me, only about 1% of what comes out of that X-ray tube actually makes it to the detector to make the image that you see. The other 99% are either absorbed by the patient or they're reflected to you. And by the way, the X-ray tube housing is not completely safe either. About 18% of the exposure that you get comes from leakage from that X-ray tube housing, not the part of the primary beam, but the halo of the primary beam and leakage from the side of the tube housing. And as mentioned on the video, interventional cardiologists have the highest radiation exposure of any profession in the world, almost 3 times that of a nuclear power plant worker. This comes from the International Atomic Energy Agency. And then, I just did a little calculation. You all remember the Fukushima reactor leak in Japan a number of years ago. These are the radiation levels in Fukushima at various spots over the first week. And you can see they trail off quite a bit after the first week. At the end of the first week, the peak level was 24 microsieverts per hour. A week later was 3 microsieverts per hour. Interventional scatter radiation is between 4,000 and 4,000 microsieverts per hour, depending on whether you're on fluoro with a little person or on cine with a big person. The translation of that is that one day in Fukushima is 27 microsievert exposure, and one day in the cath lab is 125 to 300 microsieverts. So every day you're in the cath lab, you've been in Fukushima for almost a week. And what's the effect of that? Well, it takes 50 years to know what happens with 30 years of chronic radiation exposure on a daily basis. And we now have that data. The incidence of cancer is about 3-fold, mostly leukemia, lymphoma, myeloma, and as Matt Price noted, glioblastoma. By the way, my uncle was a nuclear engineer, died of glioblastoma. Cataracts, about a 6-fold increase in incidence in cataracts. And that's across all geographies. This has been shown. The number is always around 6x. Vascular injury, because the endothelium is very sensitive to radiation, accelerated vascular disease. The carotid intima is thicker on the left side than it is on the right side. The incidence of spontaneous coronary dissection appears to be greater on the left side than on the right side in interventionalists. And then all these other dimension, chromosomal changes and the like. The point is that there is real risk. And so this is from the radiation guidelines, and there's a small section on occupational exposure, and this is from that. This is the National Research Council and their estimate of radiation-related cancers for people that work in the cath lab and radiation-related mortality from the job that you do. If you're a high-volume operator, your risk of cancer is about 4%. It's higher in women than it is in men. There is some breast cancer from the lateral aspect of the breast getting radiation through the apron. Risk of mortality is about 2%, again, higher for women than for men. And that translates to about a 1 in 25 high volume operators will acquire radiation related cancer, and about 1 in 50 will die as a result of their occupational radiation exposure. So where is that radiation? So when you look around the table, this is a study that we did. You can see that we measured scatter radiation exposure at 6 points around the table where people typically stand. So, where the echo person would be over the left shoulder for structural heart, where anesthesia or right heart access over the right shoulder, the angiographer position, the rad tech position, and the nurse. And what you can see here is the positions around the head are hot. So the blue bars are the average scatter radiation between the floor and 2 meters up. We measure every 20 centimeters. The red bars are the point within that 2 meter height that has the highest dose. And so again, there's a big halo around the top. We think that's mainly from scapular reflection. The scapula, it's a very complex reflector, and they really get this halo that goes right around the front. The angiographer is the next worst. The rad tech standing next to it, they have the best. That's the lowest exposure of anybody in the lab. The nurse 1.5 meters away is actually getting more than the rad tech is getting. So that's the circumferential distribution. This is the vertical distribution. In this case, we set the table at 1 meter. These are the scatter radiation measurements from the floor to 2 meters up for each of those 6 positions. And what you can see is that the bulk of the scatter radiation is tabletop and below. So a little over 2/3 is below the table, a little under 1/3 is above the table. And that means that if you're going to get effective prevention in the room, you've got to be able to protect around the head. You got to be able to protect below the table, as well as where we think of. We always think about above the table, but the reality is, that's where not all the action is. And since you guys are going to be doing peripheral procedures, it's worth noting that the abdomen is a lot denser than the chest is. And so the dose that you get for aortoiliac and pelvic procedures is about 4 times the dose that you get for chest procedures, 4 times the amount of scatter, and you're closer, so it's probably even more than that. And then finally, I don't know if anybody here still has obese patients in their practice. I know that we have a few left in Minnesota. We're trying to thin them out, but Ozempic is just not working. This is a great study from about 4 years ago. There's INSERC intervention looking at the patient radiation dose based on the BMI and the operator scatter dose based on the patient's BMI, not the operator BMI. And what you can see here is that as the patient BMI goes up from 25 to 40, the patient dose goes up by about 2-fold, a little over that. But the operator dose, when you go from 25 to 40 BMI, goes up by 7-fold. So as the patient gets bigger and bigger, they scatter a bigger and bigger fraction. And of course, they get a bigger dose. And so that creates even more. This just tells you a little bit about the effect of angulation. I know everybody wants to do steep angles, and sometimes you need them, but sometimes you really don't need them. And this is the effect on that. We tried to get an idea of what the total volume of radiation was in the room where you're standing. And so we added up all the scatter measurements from the floor up to the 2 meters in all 6 positions to get a kind of a room volume. And you can see that here, that the dark bars are no shielding, total volume. And you can see as you angulate the X-ray, and particularly as you get out to iliocaudal, the dose is almost 4 times. So imagine a 40 BMI guy in the iliocaudal projection. You can imagine the dose is, astronomical compared to what it would be for a thin guy in the PA projection. So you say, well, I'm wearing a lead apron. That's great. Lead apron covers about 60% of your body. The other 40% has no protection, 0. You're just standing in the room. And let's remember that the thickness of the lead apron really depends, the lead equivalency really depends, determines how much shielding you get, because these lead aprons, they're really filters. They're like sunglasses. They're not shields. They're filters. And so you can see that if you're only wearing a 1/4 millimeter thickness, almost 20% of the radiation is coming right through to you, every bit of your body up and down. If you're at 0.375, you get a 10% leak. If you're at 0.5, you get a 4% leak. So 4% of what's coming at you, whole body still being radiated. And these lead aprons have a life cycle, and a lot of them have defects in them. And you would be surprised what's considered to be an acceptable defect in the apron industry. It turns out that you can have a hole of 3 or 4 millimeters at a very bad spot, and that's still considered to be an acceptable apron. So Houston, we've got a problem. Chronic radiation exposure for hospital X-ray staff is significant. The radiation around the table is not evenly distributed. The majority of it's tabletop and below. Zone around the head is a very high head zone, and the tube housing leaks. Peripheral procedures generate a lot higher operation exposure doses. Obese patients generate higher operation exposure doses, up to 7-fold. Lead aprons are filters, are not shields. Cath lab personnel have a higher risk of cancer, cataracts, cardiovascular disease, and skin lesions. What can be done? Well, it turns out there's a lot that can be done right now, because there are a lot of new shielding systems out there that really protect people dramatically from not just the operator, but everybody in the room from this significant radiation exposure. And I would encourage you, if you're concerned about your exposure, to go out and look at those systems and to encourage your hospital administration, not encourage, but demand that your hospital administration employ these systems, because they would do it for patients for sure. The question is whether they're willing to do it for you. Thanks very much.
Thank you very much, Dr. Wilson. That's excellent talk, and we need to keep this into perspective during all our cases. Next up is Rich Kovach, and he's going to speak on renal artery stenosis. Are we still doing that?
Hey, thanks a lot, Bob. One thing I'll just actually add to the last presentation is not only do we need to be really concerned about radiation exposure, but also in your careers, if you expect to have a long career, is orthopedic injuries as well. Having being a large volume operator and having had a total hip of just a few weeks ago and another total hip probably in a year or so. So hips, knees, and backs, making good use of radiation, actually getting rid of lead completely if you have those types of systems available, and also keeping good posture, the high table heights, et cetera, and being conscious of that all the time in the lab to prevent. For interventional cardiologists, it's hips, knees, and backs are what go bad over time. So onto my talk. Renal artery stenosis, is intervention dead? In a word, no. I guess I could stop the presentation right there. Renal intervention is alive, but still remains somewhat of a confusing issue. These are my disclosures. The problem with renal artery stenosis is that actually it's quite common. The real conundrum is when to intervene on those patients. Which are the appropriate patients to actually perform a procedure, put the patient to a risk of a procedure, risk exposure of contrast or dissection or injury of the kidney, and who you're going to help and who are you not going to help. Anywhere from 22 to 59% of patients with any degree of PAD have some degree of renal artery stenosis, and roughly 7% of patients over the age of 65. Obviously, most of the time, renal artery stenosis is typically aorto-osteal disease, often intensely calcified. And that's what you're going to see primarily in adults. Fibromuscular dysplasia, probably the second most common form of renal artery stenosis, is more common in young females. Something that's a topic for another discussion, but something that's actually, there's less debate about, and that's these vessels respond very well to balloon angioplasty alone to break the fibrotic bands, and it's kind of a one and done procedure. Patients going for angiography, prevalence found anywhere from 25 to 30%, especially those with aortic disease. Again, just a summary on the left, you see FMD before and after balloon angioplasty, and on the right side of your screen, a typical atherosclerotic lesion. Obviously, you do need to rule out some less common causes of renal artery stenosis before making your final decision to proceed, if you're going to proceed and if it's appropriate. So when are you going to consider intervening, and when is it going to be appropriate to do so? Well, first of all, hypertension, but specifically refractory hypertension, uncontrolled hypertension, and being defined as being on at least 3 agents, maximum tolerated. And I have to stress maximum tolerated. We see plenty of patients on 3 agents at homeopathic doses. So essentially they're not being treated for their hypertension at all. And at least one of those has to be a diuretic. Pickering syndrome is flash pulmonary edema without any other obvious cause, normal ventricular function, no valvular disease, no ischemia, but extremely high blood pressure leading to severe afterload and flash pulmonary edema. And ischemic nephropathy, but specifically in patients who still have a salvageable kidney, meaning proteinuria less than 1 gram per day and a pole-to-pole size of at least 7 centimeters or greater. And certainly patients on hemodialysis who have renal artery stenosis, you're extremely unlikely to help. Treatment options, we already talked about. Medical management is still going to be your first step, no matter what the degree of renal stenosis is. Surgical revascularization in the interventional area is going to be obviously far less likely unless you're opening the belly for another reason, operating on a AAA, having to replant the renal arteries, et cetera. And apropos to this discussion, percutaneous intervention. But in spite of the guidelines, there's still a lot of debate about the effectiveness of PTA or stenting of the renal arteries. The challenge, well, this is such a multifaceted disease, the combination of renal artery stenosis and hypertension. Not all renal artery stenosis causes hypertension, and not all hypertension is caused by renal artery stenosis. So again, we come back to that question, which patient are you going to intervene on? Which one is it actually going to be, are you going to help out by intervening on that renal artery? There's plenty of bad historical data out there that leads to the confusion. We'll talk about a couple of the classic, I use that in quotes, studies that are created more confusion and more harm than good. Underlying CKD and its progression, even if you do open up the renal artery in somebody with severe stenosis, that may not affect the progression of their renal failure. Other things like diabetes, systemic disease, including neurohormonal factors associated with heart failure and reduced cardiac output. Embolization during PTA is always a risk. Restenosis, stenting is always a risk. And importantly, and this applies not only to renal artery stenosis, but any aortoosteal disease, is geographic miss. The vast majority of time, renal artery stenosis, if treated, is going to be osteal disease. And if you don't treat the ostium, you haven't treated the patient. Diagnosis of renal artery stenosis, ultrasound can be useful. I don't know about, as was just mentioned in one of the previous presentations about my patient population, but unless you have a superb ultrasonographer and a patient who weighs 50 kilograms with a scaphoid abdomen, you're lucky to see the kidneys, let alone the renal arteries. CT scan can be very useful, except again, the aortosteal lesions are often very heavily calcified, which creates blooming artifact, which can overestimate the degree of stenosis. DSA is actually not as good as you might think, unless you're absolutely perpendicular to the origin of the vessel. Because of the way DSA works, overlap of the vessels, you can actually miss the stenosis. Taking multiple views with standard angiography is actually a much better way of identifying the stenosis if it is present. And into this era of having pressure flow wire evaluation, confirming your diagnosis of significant or physiologic reduction in blood flow is measuring a gradient that's at least 20 millimeters mercury or more, or more specifically an FFR less than 0.8. So how do we do FFR in these vessels? It's different than the coronaries. We don't use nitroglycerin. What is important is using a 0.014 system, but your vasodilation, maximum vasodilation is going to be achieved either with papaverine or dopamine. Also extremely important when you're measuring a gradient is to make sure that the guiding catheter is disengaged from the renal artery. It's not uncommon to have, a 5 millimeter renal artery and put a 2 millimeter guide catheter in it, and voila, you have renal artery stenosis with a gradient because you've created a false or a pseudo gradient by your guiding catheter. Procedural success, balloon angioplasty does not work, in a word, does not work in aortosteal disease, especially because these are typically very heavily calcified lesions. Stenting, technically done technically properly, is successful more than 98% of the time, and 6-month patency is vastly superior to balloon angioplasty alone. Now we'll discuss briefly the two bane studies that are banes of our existence in dealing with this disease. First, the Astral study. There was an editorial done on this by another interventionist, which started out with Kismai, and you can fill in the rest. But this was an unblinded 2-arm study of medical therapy versus PTA. Major flaws of these study, and I digress for a minute. You guys are bombarded with literature constantly. You're trying to learn everything, and I think it's very common to read the abstract, read the conclusions, and use that as a guide to your management of patients. But as the saying goes, the devil is in the details and what's in the middle. And it's important to any study you want to read and rely on for your practice, understand what they're really saying in the study. This is a classic example. There was no core lab to adjudicate the degree of stenosis. And, eyeballing to one person might be 80%, to the next person might be 40%. 40% of the patients in both arms of this trial had less than 70% stenosis. In other words, a non-hemodynamically significant lesion. No consistent measurement of stenotic gradients. Only 83% randomized to revascularization actually had it. Only had 76 had a successful procedure, which is in 2023 dismal, is unacceptable. Serious complications in 9% of the PTA group, which is again in 2023 unacceptable. 65% of the sites randomized less than one patient per year. In other words, novice or inexperienced operators. And the endpoint was a change in renal function, quote, meaning an improvement in renal function. Well, 25% of the patients in that study had normal renal function or minimally abnormal renal function. So if something's normal to start with, how do you judge an improvement in a quarter of those patients? Coral was another one. This is a randomized trial of optimal medical therapy alone versus stenting with the endpoints as listed there. I'll move a little faster here since I'm getting close to the end. Again, atherosclerotic renal stenosis greater than 60% with a 20 mm pressure gradient. Well, how did they measure the pressure gradient? In 2006, we really didn't have pressure flow wires. So how are you accurately measuring a great pressure gradient in these vessels? 80% stenosis with no gradient. Well, you might ask yourself, how do you have a high-grade stenosis with no pressure gradient across it at all? And systolic hypertension greater than 155 mm mercury. Well, again, that's not what I would consider on only 2 meds, uncontrolled or resistant hypertension. Again, as the core lab typically estimated stenoses as less than the site-reported lesions. I want you to look at this, procedural duration, 70 minutes in these patients. I mean, renal artery stenting should be one of the simpler procedures you're able to do. It should take literally minutes. Contrast exposure, 140 cc's almost per. You should be able to do a renal artery stent with 10 or 15 cc's of contrast tops per kidney. Ostium covered in only 75% of the cases. That means in 25% of the cases, the lesion wasn't treated. Adverse events also unacceptably high in this study. So commentary, again, as I mentioned before, coronal nostril lesions are rather lessons in how not to design a trial or how to design a trial if you want it to fail in the first place. Many of those patients, as mentioned, did not have uncontrolled hypertension. A lot did not have severe obstructive disease. Interventional complication rates are extraordinarily high. Balloon angioplasty done used in these studies doesn't work, and geographic miss was unacceptably high. Current indications, again, what we reminiscent of the first slide that I presented, which is when you go looking for renal artery stenosis. And this current indications, I'll let you peruse the details on your own on this slide, which is available to you, but pretty much what we talked about at the beginning of the procedure. A quick comment on stenting technique. Again, aortoosteal miss, you've missed the procedure. You need high radial strength sheaths. Avoid hydrophilic wires because you can, the peripheral vasculature in the kidneys is very fragile. It's very easy to perforate the vessels, create a renal hematoma. Minimal contrast usage, obviously you don't want to hurt the kidney that you're trying to fix. Distal protection is often difficult because these renal arteries typically branch and you can't protect all the branches. And coaxial guide engagement so you don't risk dissection is important. Stent placement, again, can be very difficult. Schematic diagram here. Typically the renal arteries come off in an caudal angle. So if you shoot to hit the inferior edge of the vessel, you miss the superior edge. If you shoot to hit the superior edge, you hang the inferior edge out. Or if you're not perfectly coaxial, the entire stent is extending into the aorta, which can make future engagement of the renal artery difficult. This is where using a device such as the osteal flash balloon is useful in not only renal artery stenosis, but any aortoosteal disease where you really need to be sure that you've covered that ostium. Schematic, actually a model on the left and a corresponding angios on the right. In this type of instance is the way we typically treat renal artery stenosis is we hang the stent out into the ostium intentionally, 1 millimeter or so. We then post-dilate the stent with this dual lumen balloon. The first lumen anchors the device into the renal artery. The second balloon is a highly compliant balloon that expands basically as much as you want it to by filling it with contrast. What that does is it flutes or trumpets the ostium, rather the proximal edge of the stent. So in doing so, you've accomplished both things that you want to do in renal artery stenting. One, treat the ostium, make sure 100% sure that you treated the ostium, and two, make sure that if and when the thing restenosis, you have access in the future. Get a close-up view showing the fluting or dilation of the ostial edge of the stent, confirmed by OCT. Quick case example before we quit here. This is a woman with vascular path, carotids, AAA, coronaries, peripheral vascular disease, uncontrolled hypertension on multiple medications, maximum doses, antidiuretic, consistently 180s, 190s, and often over 200. Now you'd say, why treat this left renal artery? Well, you can see there's very poor vascular filling, no peripheral blush, but this was greater than 7 centimeters from pole to pole. So we thought it was worth at least giving that a shot. Pre-dilated it, placed a stent, and post-stent, you see vastly improved blush of the peripheral vasculature in the kidney, and I have confidence that this kidney will start to function more appropriately. She also had high-grade, what appeared at least, damping with a pressure tracing on engaging on the right, but we did withdraw, do a pressure flow evaluation that was positive. This is an example where, as you saw, the other lesion was proximal, not ostial. This was ostial. Stent extended into the aorta, dilated with a flash balloon, and post-dilatation, you see a nice, easy re-engagement with the guiding catheter. I don't think you can see the flare on this large screen. So in conclusions, conflicting data exists as to the benefit of PTA for renal artery stenosis, largely due to the lack of large, well-designed, randomized control studies, multiple factors contributing to the progression of renal disease, as well as various procedural and technical consideration. Larger studies with better design may help to clarify many of the remaining questions about effectiveness of stenting. Stenting for renal artery stenosis should carry a very high technical success rate and a very low complication rate in experienced hands. Distal protection may or may not be helpful. Covered stenting, again, we don't know. There are very limited experience with that or no comparative studies. Geographical miss is common. Ostial devices such as a flash balloon may help with that. Thank you.
Thank you very much, Rich. Complete coverage of the renal artery issue of today. Next, we'll have Dr. Vinky Ramaya speak to us on treatment of aortic aneurysms with the endovascular approach.
Thank you, and I'd like to thank Dr. Walker for the kind invitation. I think it's late in the day and now you're approaching the big boys club. How many of you do endovascular repairs or seen endovascular repairs as fellows? Good. So abdominal aortic aneurysms and diseases of the abdominal aorta is typically said by Dr. Osler that there is no disease that is more conducive to clinical humility than aneurysms of the aorta. You can be reduced to tears when you clamp the aorta and you no longer have an aorta under the clamp. So abdominal aortic aneurysms are the 13th leading cause of death in the United States. Rupture carries almost a 90% mortality actually. And of course, the prevalence is 3 to 6% in men over 65 to 74 and 12% in elderly males. It all depends on the size. They say size doesn't matter, but in abdominal aortic aneurysms, the diameter of the aneurysm is extremely important. So when you approach 5 to 5.5 centimeter aneurysm, your risks of rupture go very high. And that is why if you look at data, most of these abdominal aortic aneurysms are fixed at a diameter of approximately 5.5. If you look at all of the endovascular trials, most of them include indications are at least 5 centimeters in diameter of the aorta. So if you look at the annual risk of rupture and you have about a 7 to 7.9 centimeter aneurysm, there's a 20% chance of rupture. So the question then is, how do you treat these patients? When do you screen for these patients? And at what stage would you follow these patients so that they reach that diameter? And there have been a lot of trials about small aneurysms. When do you fix them and why do you fix them or why you don't fix them? Because if you look at the natural history, rupture is related to the diameter of the aneurysm. The SAVE Act was instituted by Medicare and basically covers patients who are at high risk for abdominal aortic aneurysms. These are men and women with a family history of AAA and men aged 65 to 75 who've either smoked or had cigarettes in the past. It provides for a free one-time ultrasound screening for abdominal aortic aneurysms. So most of these aneurysms are detected incidentally, unless you know you've had one and then you follow them with serial ultrasounds. So if you do have an abdominal aortic aneurysm that's say less than 4 centimeters, then you need to follow these patients by serial ultrasound at least annually. If it is between 4 to 5 centimeters, every 6 months. And if it is between 5 or symptomatic or growing by more than half a centimeter in 6 months, that patient needs to be referred to a vascular interventionalist or a specialist. So that's the fundamental principle of how you detect aneurysms. When do you treat them? And now we'll come into how do you treat these abdominal aortic aneurysms. This was traditionally what we used to do. Nowadays, we do them with single punctures in both groins, put an endograft, and most of these patients go home the next morning, if not the same day. If you look at open AAAs, you'll see that the survival for 5-year survival for elective AAA is 70%. So there used to be a lot of debate. The first endovascular aneurysms that were FDA approved was in September of 1999. So we've been doing abdominal aortic aneurysms for a long time endovascularly. There was a lot of controversy saying that this is a failed experiment and open repair is better. But I think endovascular AAA repair is here to stay, although there is still the open surgery that could be the gold standard in certain groups of patients. So Dr. Parodi is credited with transfemoral endoluminal stent graft repair in his landmark paper of 1991. So let's look at, if you want to do an abdominal aortic aneurysms, there are at least 4 factors that you need to pay attention to. The patient, the operating surgeon, I say surgeon because I'm a surgeon. I would say interventionalist if you are not one. The device itself that you're going to use, and of course the technique that you need to use. So let's look at the patient. The patient's anatomy, which is most important, which is basically the neck of the aneurysm and the access. You have to also look at surgical risk of the patient in terms of morbidity, COPD, hypertension, other factors. You have to look at the access. So let's look at the anatomy. This is probably the most important part of the anatomy that you need to pay attention to when you're doing endovascular repair of abdominal aortic aneurysms. The neck is the most important. It has to be a healthy portion of the aorta. It has to be infrarenal, and it has to measure, based on the device that you're using, at least 1.5 centimeters in length, and the diameter is within less than 30 millimeters. So every device that you use has indications for use, and you have to stay within those indications or IFUs. So this is an ideal neck. It's greater than 15 millimeters in diameter, less than 28 millimeters, in length and diameter. It's cylindrical. There's not much calcium. There's no mural thrombus, and there's little or no angulation. This is a slam dunk case, basically, if you believe in slam dunk cases. On the other hand, look at this aneurysm. It has a greater than 60% angulation. It's a large aneurysm. And so if you really not follow the IFUs of a device by more than 2 or more combination or unfavorable factors, then you're likely to get a very bad outcome, not only in the short term, but maybe in the long term too. Obviously, access is very important. And there is data that has said that if your neck length is less than 10 millimeters, your risk of a type 1 endoleak is 10.9%. And if your length of the neck is greater than 15 millimeters, then your risk of endoleaks are much higher too. Same thing with the angulation. If the angulation is greater than 60%, your chances of migrations and late type 1 endoleaks are very, very predominant. So you got to look at the access, you got to look at the infrarenal neck diameter, infrarenal neck length, the angulation, and of course the distal seal zone in the iliac vessels also to get very good outcomes. Now, access is extremely important, and you know from structural heart and your Abiomed and your other devices that you use that I get called all the time when Dr. Bernardo ruptures the iliac artery. So access has to be extremely important. You've got to pay attention because these are large bore devices. They're getting much smaller. This is Dr. Bernardo's case where he pulled the iliac artery on a stick. Hey, Nelson. So you don't want this at any cost. You don't want a rupture of the iliac vessels. And I've seen very few nowadays. Previously, we would do conduits, we would do endo conduits and all of this stuff. But nowadays, the devices have gotten much smaller. The profile is much less. You have devices like Shockwave and things like that to get over these calcific access. Then you look at the next group, which is the surgical patient. Age, female, gender, and ASA class always contribute to your morbidity and mortality. So you need to have octogenarians have a higher mortality, access site complications. So you need to look at your patient as a whole rather than just the anatomy of the aneurysm itself. There is a definite risk for patients who have pulmonary disease, cardiac disease, and of course, diabetes mellitus too. And these patients actually end up with longer hospital stay and ICU admissions too. Then you got to look at what is known as your own experience. So if you look at data, obviously the more patients you've treated, the better your results. So it has been stated that you've treated about 38 to 91%, your mortality rate actually decreases to about 7% compared to people who are just starting out. So my advice to you is if you want to deal with abdominal aortic aneurysms, you should have a good team. You need to make friends with me and your team of vascular surgeons and cardiologists and intensivists and things like that. So if you don't want to dabble in this situation, you want to be committed, you need to have a good endovascular team. Only then will you progress to other devices and other complex cases that you can do. Now, look at the devices. Everybody has a bias. Every device is different, and not all devices are equal. As long as you understand that, then you can make a decision for yourself as to which device you want to use. So you have on the left-hand side, you have the Cook device. Then you have the Gore device, which is the excluder. You have Endurant, that's made by Medtronic. You have the AFX device, which is a single piece bifurcated, fully supported device that was actually made at Arizona Heart. Then you have the Alto device, which is probably the lowest profile and a sort of a different out-of-the-box configuration. And then finally, recently, the Terumo device got FDA approved too. So Gore is a modular device. All of these are more or less modular devices. The two simple principles for a good endograft are what? Fixation and seal. The device has to be fixated, and you have to get good seal at the level of the infrarenal neck. Those two are the most important parameters for any endovascular device. So Gore has anchors. Gore also tilts, and that's why you got to be careful of the angulation. You have conformable grafts now that you can adjust accordingly. Cook is another suprarenal fixation device. It's low profile, and it also has an aorta uniiliac device in case you have bad access on the other side. Endurant, again, is a modular device. It has hooks and bobs at the proximal end. It's a modular device, and you can also see the device is made out of fabric and nitinol. Endologics used to be a single-piece bifurcated, fully supported device that you can land at the aorta bifurcation and then extend upwards if you need to. And so this allows for up and over access. Most of these modular devices, the bifurcation is raised extremely high, though you cannot get up and over to treat peripheral arterial disease and stuff like that. The Alto is the device that I generally tend to use. It's the lowest device on the market, and it's got polymer technology, which allows you to basically treat pretty angulated and short necks. It's FDA approved for a neck that's 7 millimeters in length. And so it is probably the only device that can treat a less than 1 centimeter neck with the lowest profile available on the market. And it's got this O-ring technology. It does not create the radial force of the other devices and things like that. So Alto has become my go-to device. And these are a few examples of the ovation and in patients who have bad access. And then, of course, finally, you need to focus on the technique. Whether you do open or you do percutaneous, you need to focus on the C-arm angles to make sure that the device is well-oriented and it sits across the lowest portion of the neck. And this is a chip shot which you should start accordingly when you do your first few cases in association with your vascular surgeon. So this is the little things that you need to know before you start your endovascular practice to treat abdominal aortic aneurysms. Thank you.
Thank you very much, Vicky. It's an excellent presentation of all the different grafts. And I must say, if you do want to get into it, you must have a really talented vascular surgeon that you can work with. Next is Dr. Bernardo again, and Nelson is going to speak now about vascular access and how to achieve hemostasis.
Thanks, Bob. Thanks again to Dr. Walker for the invitation. So I'm going to tackle now about treating complication of vascular access, how to achieve hemostasis. So I would say 10 minutes is not enough time to talk about this. So what I'm going to share with you today is more of the principle that we follow at the hospital center on how we manage these patients. And actually, you just follow the principle, you'll do fine. Okay. You don't have to call Vinky to bail you out. So no disclosure. So whether you like it or not, right? You could be an expert, like Vinky was saying, the big guys, you still can have a complication, right? And I can see that as of today, our biggest problem is always the hemostasis, right? We have gone past those stage of oversizing, rupturing the iliac, those kind of things. So I see that maybe once a year now, because we're very good in looking at the CT, measuring everything before. So our problem these days is mainly hemostasis. It's basically failure of closure, right? And if you look at it, it's about 5%. Even at the hospital center, I look at our rates every year. We're hanging around 5-6%, even with all the devices we have available. And of course, our goal when we do a procedure, either just a regular cardiac cath, I should say regular, but a cardiac cath, to a large bore access, EVAR, or even a TAVR is uncomplicated, right? Good hemostasis, right? So unfortunately, with your generation, right? Most coronary work these days is basically being done radial way, right? So, and we have lost the art of doing it from the femoral axis. But I would say that if you want to be an accomplished interventionalist, right? You want to be on the top of what you do, you have to have a comfort zone in dealing with femoral, right? You have to, right? And actually, I do with our fellows. I know we do everything by ultrasound. Actually, once they're very good, I would say do it blindly. That means to say, stick the artery with no ultrasound, see if you can get it. Because you'll need the time when you're coding somebody, you don't have the machine, you need to be able to get it. So these are the things that you have to, right? So when you have complex PCI, no radial, no ulnar access, and whether you like it or not, large bore access is here to stay, right? We're doing all these Impella devices, EVAR, TVAR, TAVR, right? And the key thing is when you do these procedures, you need to recognize that a complication is happening, right? And then deal with it ASAP. So you don't send anybody to the OR, right? I would say that if you have bleeding complication, especially large bore access, actually, even small bore access actually can kill a patient, right? And actually, and I would like to basically to you that like in hospital center, we do everything percutaneously, right? I'm proud to say that for our TAVR program, we published our low-risk TAVR and we had 0 groin complications. So we're able to manage it in the cath lab, but the patient has to go to the OR, right? Now, there will be no randomized trials, right? You won't have read anything, right? It's basically, I'll be honest with you, your fellows, right? You're finishing, you're joining a practice. It's going to be dependent on the local institution that you're joining. What's the expertise in that institution, right? One thing you have to keep in mind, bleeding complications, I would say morbidity, mortality is equal to bleeding duration. The longer the bleed, the higher the mortality morbidity is, right? And I would say that all I'm going to tell you today is how we do it in a hospital center. Now, data, right? And you have to be careful. I know this was a publication we have a couple of years ago, and I was fascinated by it because they reported, oh yeah, we go radial, you drop your complication rate for RP bleed and everything. True, from 0.09, 0.03. But then if you tease out the data at the 0.03, their mortality rate is 8%. So that means, yeah, you drop the denominator, but you haven't changed the mortality rate, right? So that means to say, even if you do it, if the patient will get an RP bleed, the chance of dying is still high, right? So you need to know how to manage this patient, okay? So you start. What I call it first is diagnosis comes to the prepared mind, right? After a TAVR, right? Fluoroscopy showed this, right? What's this? A classic sign of the dental bladder. That means to say, patient could be stable. If you see this, you better call somebody in the lab right away. Don't send a patient to the floor, right? So I'm going to share with you the algorithm that we follow. All our fellows follow this algorithm that we have in the cath lab, even our techs, right? So the first thing you have to do is a pathology. So I'm in lab 10, they're working in lab 3. They'll call on the phone. groin complication, TAV, or whatever, right? So the first thing we typically ask, obstructive, bleeding. If it's obstructive, I say, oh yeah, you can wait. Let me finish my work. Give me 5 minutes. I'll come over and take care of it. If it's bleeding, you drop everything, you run, right? You drop everything, you run. So it's very, very important. And then you have to train your people to do what I call temporizing hemostasis. Don't just stand and do nothing. You have to temporize. I'll talk about that, right? So then the first thing we typically ask the fellow is, where's the bleed? Above inguinal ligament, which is very different, or is it below the inguinal ligament? And I think you know why those questions being asked, right? So check the angio right away, right? For us, every access, before you put the sheet in, there should be an angiogram, right? And you can see in reference to the inferior epigastric artery, if you're above or below the inguinal ligament. Then of course, apply temporizing measure. So what's temporizing measure? The typical thing that you're gonna do is put pressure on top of what are bleeding, right? It's instinctive. Is it effective? Not really, right? People talk about the literature, about occlusion balloon and everything, but you need time. You need to access the contralateral, right? The easiest way to do is what I call as reinsert. Just put the sheet in. And actually, my rule in the lab, put a 14 French sheet. Even if access was 22 French, 18 French, 16 French, put a 14 French, you'll get hemostasis. That has been shown time and time again that 14 French will do the trick. So typically like this, a bleed, just put a 14 French sheet, right? And this is what I call quick and easy, and always provide complete temporal hemostasis. That means that when you do that, bleeding stops and you can take your time to do what you have to do. So we have what I call a tool cart. That means to say, if they call me for a bleed, one of our techs would be rolling the tool cart. And on it, I have all these guide wires in the cart. I have all these support catheters in the calf. That means to say, with this tool cart, I can treat any groin complication. Then I have all the sheets in the cart. It's just a small cart, but you have everything. Then I have the balloon catheters that's needed. And of course, the stent and stent graft. This include all the covered stent that we need. And also, actually, I included the ovation stent graft. This is basically if you do a transcaval and you have a bleed from the transcaval, this is a graft we put in. You can put this on a 12 French or 14 French sheet, and so you can access the aorta easily, right? So this is what we call a tool cart. That means, if they call for a bleed, I run to the lab, and this cart comes with me to the lab. That means you'll be able to do a procedure right away. You don't want to be saying that I need 5 by 20, and then somebody's running, takes you 5 to 10 minutes. Because remember, when you have a bleeding complication, you have 5, 10, 15 minutes at the most. If iliac perforation, better do it in less than 10 minutes or the patient going to be dead. So the next question we ask all the time is anticoagulation. I keep ACT high. Do I reverse? No, we never reverse. No protamine, no reversal. Through the years, we've learned when TAVR started, when we have a bleed, the anesthesia would give like 50 milligrams of protamine and everything. Then the next thing I know, I have, after fixing the complication, I have to thrombose the whole SFA all the way down to like thrombose, and you have to deal with it. So no reversal, no heparin, right? I always tell the people, if there's an 18 French hole, your ACT could be 100, ACT be 350, it's gonna bleed because it's a mechanical issue, right? Has nothing to do with anticoagulation. Then supportive therapy, if it's bleed, it's always automatic. Get the units of blood right away, 2 to 3 units of blood. The reason I say this, we publish this data that once you have a bleed, you will need 2 to 3 units of transfusion ASAP. Then the most important thing for you to do is vascular access. What do I do at that point in time? Remember, you have to get contralateral vascular access, right? Or you can do ipsilateral below the SFA. So typically, if it's an obstructive lesion, 7, 8 French sheet is more than enough. If it's a bleeding complication, it depends on the size of the stent graft. But these days, you can get away with just putting 8 French sheet because we have balloon expandable EPTFE that will go to 8 French sheet. So you can get away with that. I don't believe in using EPTFE balloon expandable stent in the common femoral artery, but if you're basically end of the road, you can use it. And people get away. It's been reported that it's safe to do that, okay? Then definitive therapy is very simple. When you have a bleed, you only have 2 decisions to make, right? I always say, if it's a disrupted vessel, you just exclude it, put an EPTFE covered stent. But if you're dealing with a perforation, then excluding it is not going to stop the bleeding, right? You have to occlude that vessel, right? These are the principles you need to remember. If you have a bleed, don't just say, oh, just put a cover stent, you'll be done with. Nope, that's not the answer, right? You need to know where the bleeding is coming from. Okay, so very simple. This dented bladder, right? So we know that there's an RP bleed for sure, right? You have a dented bladder. So true enough, I accessed the other side. The operator was very, very astute. They saw it and they called us right away. And you can see that there's an RP bleed, right? So the plan here is what? It's a disrupted vessel. You exclude the vessel. So that means a covered stent, right? And all I had to do is put a covered stent. So the question you have to ask all the time is what size of self-expanding stent you have to use, right? And so the key things to remember are this. In our system, the CT scan is always on the II. That means to say, if I go in the room, I should be able to see the measurement of the femoral artery and the iliac artery. Never rely on what you see on angiogram, right? Because I always say, if you're vasoconstricted, you got to be undersizing your stent all the time, right? So you have to have diameter and length, and you have to have the vessel size. So those are easy. And these days, with all the community we have available, actually, they always have the film above. So you can look at it and then determine the size, right? So my 2 cents on sizing, right? I know we typically size 1-to-1. I'm sorry about that. I typically go 20%. Actually, I can go back, sorry. I don't know if I can go back. Yeah, so that's it. This going back here. So typically I go 20%. Why? When you have a disrupted wall like this, you can see it very nicely, right? Basically, you lost the wall, right? And so that self-expanding has to expand more, right? So if you undersize, then you won't get the seal in this segment here. So I typically do a 20%, right? And this is also the time when I tell our fellows that when you access for large bore access, go high on the common femoral artery. Of course, not above the inguinal ligament, but high to the bifurcation. So you have a landing zone. Very, very crucial. Okay. So that's it, right? Then like this one, we did a procedure in 12 minutes. Still got 2 units of blood, right? That means to say that's an issue. Quickly, this one case, 53, 843, 11, right? And again, on the floor, hypotensive, brought back to the cath lab, right? And so what did we find? It's basically now bleed from the inferior gastric artery. So I mean to say the treatment plan is very different from the first case I showed you, right? The first case, the disruption of the wall, put a cover stent, you'll be fine. This is a bleed from a branch. So I have to occlude that branch, right? So you have to use embolization material, right? So when you occlude, we have what I call 3 options. You can do coils if you want to, and these are all what called permanent occlusion. That means to say, if it's a CTO, you won't be able to recanalize that vessel again. Then you see the literature about fat pads. Have I done this? Yeah, I've done this once or twice. Does it work? Yeah, it works. It's painful. You need to have a big sheet. You can't do it on micro catheter. So I've abandoned this technique. And I've typically what I do is use temporary embolic materials, right? So I use a thrombin blood patch. I use a gel foam. So all you have to know is when you do this technique, you need to know the size of the catheter to deliver the device you're in. You need to use the support catheter or even a support balloon catheter support catheter. Just remember, when you do this, you have to rule out possible type 2 endo leak because that would make your procedure ineffective, okay? So go back to this case quickly, right? You see where the bleed's coming from. All I do is basically engage it, put a microcatheter in, then I inject thrombin blood patch. What's thrombin blood patch? We wrote this up 10 years ago. Just blood mixed with thrombin, then you fill the gooey stuff. Then that's what I do. I basically injected clot into the system, right? And so with this, you get good hemostasis. Very simple. If you want to use gel foam, you can use a gel foam. You want to use coils, you can use a coil. It's up to your expertise, right? So this one, in 20 minutes, we got it closed. But look at this. It's still 3 units of blood, and the H&H even dropped to 9.2, right? So what caused a complication? Most probably because of a guide wire. If we look at our data set, ITSIC wrote this up about 6-7 years ago, and 40% of the RP bleed was from a side branch, right? So the lesson here is when you advance guide wire, even a micropuncture guide wire, always do it under fluoro, right? And something I want to share with you, it's the end of my talk, right, is you have to do it. You listen to me today, you won't retain much of this, but maybe 5-10%. You have to do this on a daily basis to become an expert. And when you start teaching your fellows and your colleagues, then that's time you become expert on this procedure. So when you join a practice this coming July, what's the standard of care? It depends on the institution going in, right? The IC could be doing, the IRs could be doing it, the vascular surgeon will be doing cardiothoracic surgeon. So you have to find your place in the place you're going to, right? Then it all depends. Some institutions do open surgical repair right away. They can open the OR in 30 minutes and get it done. Or like for us, we can do it at cath lab in 5-10 minutes, we're done. So it depends on the practice you're joining, right? And basically, the most important thing, you should be able to promptly deliver the effective therapy and of course, with consistent outcome. So in conclusion, right? I think what I'm going to project is that you should have a low threshold in bringing your patient back to the cath lab and perform endovascular intervention. Thank you.
Nelson, thank you very much. Great information for us as we're coming out. Next, do we have Aaron Murphy for iliac vein compression? Is Aaron here? Okay, so I guess Dr. Patty Thorpe is going to give a talk on iliac vein compression syndrome, pelvic congestion, and diagnosis and treatment, including technique. Thanks, Patty.
Thank you. Thank you to Dr. Walker and his team for including me today. I'm very happy to be here with you. Dr. Murphy called me last week and told me something very sad because I had a dog die in March, so I know the sorrow, but her family dog had to be put down today. So our hearts are with her, but she couldn't come to the meeting. So I told her I'd be glad to give this talk. It'll be different than what Dr. Murphy was saying in a way, but it's the same anatomy. And everybody you hear teaches you something that you'll remember. So it's good to hear it from different people. Let's see. These are my disclosures. No, this isn't the right talk. This is the superficial talk.
Hey guys, do we have the talk before this? It would be the talk on iliac vein compression syndrome, pelvic congestion syndrome, etc. This is the superficial diagnosis. She can do this first, and then just load that one up afterwards, okay?
Okay. So make sure if your leg starts to feel funny or jumpy, you get up and stand around, walk around so you don't get DVT. We all think that DVT is just for older people or people who are going to Europe or Hawaii. That's not true. We'll talk about that. So this is a different kind of talk because I wanted to share with you some things that will stick in your mind because you will all be learning how to do RFA ablation if you're interested in treating veins. RFA ablation started in about 2000. And it's been coming on for quite a while, more than 20 years. And now there's no limit to who can try. So our goal amongst those of us in this room is to make sure that you have the very highest standards when you practice RF ablation and venous disease care, because there are so many people in the community who are unethical and do things to patients that they don't know. It's like taking your car to the place, get it fixed. You don't know if they're telling you the truth or not because you're not a car mechanic yourself. And I see so many patients come for another opinion, and it turns out that they don't have what they were told they had. And I can't make it up because it's in the ultrasound. So this is a woman who had a iliac stent placed by a cardiologist, and he did a good job. And then she was complaining of some more discomfort, and she had some small varicose veins related to her saphenous vein, which is properly treated. And you can notice that her leg is a little bit discolored and right down here in this area. I'll just show you a bigger picture. It's hard. And it's uncomfortable to her, and the top of her foot is a little swollen, and it gets worse during certain times. It actually gets puffy. So it domes, and her toes can get a little bit fat. And does anyone have an idea of what's going on here? She had a phlebectomy and sclerotherapy, more sclerotherapy down in this area of the ankle. And not only that, the sheath for the SFA ablation was placed in this vessel down here, the distal SFA. So that can damage the vein, but more likely than not, she had sclerotherapy in this area to treat some small varicosities or even spider veins. She has spider veins over here. So what happened was that she got lymphangitis, and she's left with lymphedema, which in this case, on this picture, is pretty mild because the foot isn't domed and the toes aren't really swollen. But lymphedema is a case where the lymphatics are damaged and they run right next to the veins, and her vein was sclerosed, but there was spillage of the polydocanol or whatever that is very caustic to vessels. Now, I've seen this a lot, and there was actually a lot, meaning more than I'd like to see. People who have an iliac stent placed by someone other than me, and they come and say, well, I thought it was really good, but her left leg is still swollen. Well, there's something a little bit wrong with this stent as well. But then they go ahead and perform their superficial treatment after they look at all the greater saphenous, et cetera. Well, there's no cure for this. This is with this lady for life. So you have to be very good about your technique when you're doing sclerotherapy. And I know everybody wants to be, but it's really important because she's not very happy, but she can't do anything about it except wear a stocking. And there's a lot more patients coming to our clinics now with lymphedema because it's on the internet and people are talking about it. But I bring this to your attention because it's something that hopefully can be avoided with really perfect technique. And it's not uncommon, unfortunately. By the way, her stent wasn't placed high enough. Her left leg was a little bit swollen because the left iliac stent was too low. So we did go in and place another stent in there. So when you start out doing venous disease, you're welcome to come and be in my lab or go look around. There used to be, before COVID, we had really nice educational programs with Philips and other companies that would send you to a lab to watch iliac stenting done. I think you got a lot out of those cases, but now we have to learn some of our technique on ViewMedi, I think. And you can go to his lab. But it's really important for you to see someone like me put a stent in and talk to you that day when you're there. It'll save you a lot of grief. Now, here's the case that has varicose veins, right? What would you do with this case? Well, you get an ultrasound, and these are accessory veins. They're a little bit unusually placed for a saphenous vein refluxing, right? Don't you agree? So there's something else going on here. You see, I'll show you a picture. Then we do a standing evaluation of her veins in her right leg and in the distal calf. What do you see here? It's not a phasic line, is it? You need to see phasic flow in a vein for normal, unless there's a proximal obstruction. Now, this is a lady who's never had DVT. I can't go backwards. She's never had DVT. She doesn't have a history of DVT. But we discovered that she has an arterial venous fistula in her right lateral calf and the massive veins. Now, what are you thinking now? She's gone to a lot of doctors and was really leery about getting phlebectomy. I don't blame her. And here's a picture of her mother who was in the waiting room. I asked her to pull up her hands and show me her varicose veins. There are a lot of veins on the back of her leg. They're large. It turns out her grandmother had varicose veins like that. Have you ever seen a case like this? That's why I'm, really, have you? Have you raised your hand if you have? That's why I'm showing you this case. This is a gift to you. Now, what you're gonna do is you're never, ever gonna do phlebectomy on a case like this in your life because you've heard about this. It's very rare. It's called Parkes-Weber syndrome. It's part of the Klippel-Trenery conglomeration, where you have a genetic defect, which were her grandmother, her mom. None of her children have this. And none of her cousins. It's just she got it. And it's associated, if the Parkes-Weber syndrome part takes effect, it's associated with AV malformations. So what happens is if you go in and try to do phlebectomy on this without proper investigation, you're getting a huge trouble. And they just multiply. So these are not common, but I wanted to point that out to you so that you would always make sure that your patient with, doesn't go backwards, with varicose veins doesn't have this condition. Now, notice it really doesn't bother her that much, except the fact she's been to at least 10 physicians looking for someone who could treat her varicose veins. And I think how big they are and how numerous they are makes it a little bit leery for doctors to check into that. But she will she can get some help by someone who's a specialist in embolization, but she's getting her MRI for that to evaluate more. Now, all you need when you're doing RF ablation is to have a very good ultrasound tech, more than one, and they must know how to do the saphenous, great saphenous, short saphenous, and all the accessories, and give you a good drawing of what's refluxing and what's there and what is refluxing. And then you can make a plan for how you're going to proceed to do either RF ablation or Varithena or laser, whatever is best for that patient. But you cannot do this without an excellent ultrasound department and drawings that explain it to yourself right off and then also to the patient. It's very important to communicate to the patient. And I think my opinion is less is better. Less is more. And when it comes to doing RF ablation, you have to be very careful that your technique is good and that you don't overdo it. And just a little vignette, interestingly enough, 20 years ago at the American Venous Forum, there was a whole group of people, at least as many as you are, in a room talking about RF ablation because it had just become a thing. And everybody was talking about where they cut down to put the catheter in. And I looked at him and I was the only interventional radiologist in the room. And I said, excuse me, I said, you know, you don't have to cut down. You can do it with ultrasound. You can learn how to get a micropuncture set and go into the vein you want and just put the sheath in and you can, and you know what? Then everybody started doing that because they came from a vascular surgery background and they didn't know about micropuncture sets and how to use an ultrasound probe to find the greater saphenous vein distally. So it's really important that we all kind of keep exchanging information like this so that you learn from each other. I know that was a short talk, but I wanted to make those points because I thought they might stick with you. And better than hearing a 20-minute talk that you don't remember, don't you think? So let's talk about pelvic venous congestion and iliac obstruction. It confuses a lot of people about what's happening. And I think maybe it's almost mostly women. But we want to talk, how come it's not going forward? Let's push a sweet spot here. Is that better? Okay, yeah. Just need to go backwards. There we go. Yeah, it moved, it did show, okay. Thank you. May and Thurner were two pathologists, and they understood that by doing their work in the 50s, they said about 22% of the people had an iliac narrowing in the left side, which was by either a bone spur or the vein itself was totally scarred. But I dredged up a literature early in my career and found that Bauer was a German pathologist. And in all the autopsies he did after the war, during the war, he found that about 30% of human beings have an iliac compression, a very narrow left iliac vein, which could be compensated for so the patient isn't symptomatic. And I have done venograms on a 90-year-old woman who had a very tight iliac compression and she was never symptomatic. So there are people who go through their life without knowing, but by and large, it's 30% of the population, so that 1 out of 3 of you has some degree of an iliac compression. You may know it because your left leg is a little heavy or a little swollen sometimes, and most people learn to live with it when it's not very serious. But over time, it gets worse in many, many people. And over time, it's a risk factor for DVT. And how many of you think that it's mostly in women than men? Iliac May-Thurner syndrome is more in women or men? Well, the syndrome itself may be more in women because there are risk factors that cause a perfect storm so that the thrombus will form. And one of those risk factors is hormone therapy. The other is pregnancy, weight on the vein. But the actual iliac compression itself is equally divided between men and women. So when men started taking testosterone about a decade ago and thought it was the hottest thing ever, a lot of men got DVT in their left leg because they had a setup for it. And they added the hormone therapy and bam, they had a perfect storm. If maybe they sat in their car too long on a trip or they went on an airline and sat for 8 hours to go to Hawaii, it just takes about 3 or 4 of those issues lined up on a given day to cause you to have DVT in your left iliac when you have a left iliac compression. Now, liken it to these storms, these bad storms that we've seen, tornadoes or hurricanes. You always have hot air, you always have cold air, you always have updrafts and downdrafts. There's always water, but there's not a hurricane every day. And why is that? Because there just has to be a perfect combination of the risk factors that line up in one day, and they're all there at the same time, and then it makes a hurricane. The same thing with DVT. You remember to tell your patients that when you see them, because they don't know how they got a DVT. And what did I do wrong? Why me? Sometimes it's genetic. So there's a genetic factor. Factor 5 can help. And in my research over the last, 30 years, I've come to know that people with O blood type have fewer DVTs and people with A and B have more DVTs. So there's a blood type factor. There's a anatomy factor. There's a factor about whether or not you're having surgery So it happens in young people when they start taking birth control pills. It happens more in A and B blood patients. But if you ask Americans, they usually don't know their blood type. Although people in Europe and South America usually do. So it is it's here to stay. And I would, if there are 1 million DVT a year, probably at least a third of them are with iliac compression. And there aren't enough doctors to help all these patients with DVT. And an awful lot of DVT goes unnoticed until the patient has a pulmonary embolus. And so it's a very serious disease that causes a significant amount of morbidity and death. And it's unfortunate that we've separated arterial disease and venous disease in our practices, because everybody needs to be aware of this vascular condition. Now, when I show you the IVC and the iliac veins coming up in the center, you can see that it gets pretty complicated in the pelvic area. And what happens with an iliac compression right here is that it inhibits flow from going into the cava, pushes it back down into the internal iliac, into the pelvic veins. And here is the ovarian vein on this side. So the ovarian vein can get overloaded with an iliac compression. The right side doesn't suffer as much. Here's the gonadal vein on the right. It comes into the IVC proper. This goes into the left iliac vein. So the anatomy is important to know that, and we'll see what we have next. Here's a compression of an iliac vein, left iliac vein. Now, all of the x-rays are taken with a patient prone, usually when we start doing their popliteal approach. If it's an iliac approach, it'd be on the left, but this is a left iliac compression. You can see how the indentation, so look for that in your venogram. And globally, the population is 8 million people, but if it's only a third that have iliac compression, you're looking at more than 2.5 million people. And the 11% equals 70% goes to IR. They're all, you know what this is for, counting the number of specialists in the country that know how to take care of this. So we don't really have enough people in the United States or the world to treat the number of people that get a DVT each year. Now here's another picture of an iliac compression right here. See how it makes this vein very wide compared to normal. Here's where it was normal, then it got. So in an iliac compression, you have not only this part, which is abnormal and compressed, you have the pre-stenotic dilatation, which is abnormal. So when we teach people about IVUS imaging of iliac compressions, there are two areas that are important to know and measure: the compression itself and the pre-stenotic dilatation, where the vein is not a good vein anymore because of all that pressure all those years. Here's another picture of an iliac compression right here, very clear. And then you can see in this case how it's shunted into the internal iliac vein and goes all the way over to the other side. So if someone comes to you and you say, well, your iliac compression is on your left side. They say, yeah, but my right leg hurts too. You say, why? Well, they don't have a compression on the right side. They just have a venous overload on the right side because the body is unloading the volume over into the opposite leg. And that's very common. Now, here's a picture of a patient with a thrombosis. And when you have thrombosis, your body does a natural shunting into the gonadal veins. This happens to be a woman, so these are ovarian veins, sorry. And here's an ovarian vein over here. And the body makes this U-shaped shunt when there's an iliac compression. There's no iliac flow right here. Sometimes we see this with IVC iliac thrombosis on both sides. So that's a very common look. Now, what about people saying, well, iliac compression and varicocele might be due to nutcracker syndrome? Nutcracker syndrome is this, where you have the mesenteric artery compressing the renal vein as it goes into the cava. This is a post-op diagram of how they can shunt it like that. But if there's a lot of pressure in this vein, it'll go down the ovarian vein or the testicular vein to the pelvis. And very often this is the cause of varicocele in men. About 10% of the population, the male population, has a varicocele. And just like May Thurner, it's not a genetic thing. It's an anatomical variant. And this is not genetic. It just, everybody has a superior mesenteric artery. And in about 10% of people, there's quite a compression of the vein. And it can be posterior too, and it can also compress the duodenum. So nutcracker syndrome itself, it gets mixed in with the iliac compression because the symptoms are sometimes the same. But more often than not, it will have hematuria because there's clotting from the compression and the clots go retrograde into the gonadal vein. So clots going down your testicular vein or your ovarian vein will cause a lot of pain and you'll get hematuria. You don't get that with May Thurner syndrome. Varicocele is, I put it there, orthostatic proteinuria is a sign of nutcracker as well as orthostatic intolerance. So it's not as common as May Thurner. And sometimes, very rarely, people will have both conditions at the same time. The pain pattern is abdominal or left flank pain in everybody. If they have this left back pain here for the renal part of it. The trouble is pelvic congestion syndrome, just from the iliac alone, can affect a woman's hormones. And she gets premenstrual cramping. And it feels like you're having your menstrual cycle and you can get left flank pain with that. So it's confusing. You have to take a really good history on these people. The pain can radiate to the buttock or the posterior medial thigh. It can be exacerbated just by riding a horse or being in a bumpy car. And I mentioned the thrombi in the ureter is painful, but varicocele is always left-sided, not right-sided. So you think that this kind of compression of the left renal vein has to be associated with varicocele. And left renal vein hypertension is the issue. And I want you to write this down. There's a great reference, Mayo Clinic Proceedings in 2010 with our friend Tom Rook, who often speaks at our meetings, and Andrew Kolinsky. It's a very good article that explains nutcracker syndrome. So you should get that in your repertoire. Now here's the varicocele in a patient that I treated for iliac compression. But in his venogram, this is what I saw down into his left testicle area. And actually, he only needed a iliac stent because he was overloading the left iliac vein because he had such a compression. So that overload of the venous outflow in the gonadal vein will cause the same symptoms as a pressure point in the kidney, renal, the renal vein. So this is when you do a venogram where they have those symptoms and you can actually see these in the examination, look first for an iliac compression because that's more common. But in men, I always look for the renal vein compression too. So how common is pelvic congestion? 15% of women between 18 and 50 years have this syndrome. And it's probably closer to 45% globally. Chronic pain is really a hard thing. They actually have specialists in chronic pain now, chronic pelvic pain. And I don't know if any two people ever kind of understand it the same, because the gynecologists kind of go in one direction and the interventional radiologists go in another direction. Kind of almost depends on what you can do to treat it. But it's really important to get CT imaging and MRI imaging when you're suspicious of this. It was first described almost 200 years ago. And it's associated with, 30 to 40% associated with PES, pelvic congestion syndrome. I think I already mentioned that hormonal and anatomical factors kind of come together to create this perfect storm for people. You know what the problem is we have now? Is they used to give authorization in insurance companies for varicocele treatment. And you treat varicocele with embolization. And when I was a surgery resident, I was the one who was called in to put on a lead glove and put my hand and hold as hard as I could in the left groin when they injected boiling hot contrast into the gonadal vein to embolize it. And that was before we were using coils. But you see, any way that you can shrink and close the gonadal vein, you can get rid of the pressure coming into the scrotal area, which causes a varicocele. And in the case of women, pelvic varices. So although men don't have much of a hormonal factor, they have the anatomical factors that you have to look at. We did go over that pelvic congestion does bother men. Now I want to share one last thing in this talk, just to have you hopefully remember it. This is just a picture of the pelvis with the left renal vein, the iliac veins, the pelvic veins, and the gonadal veins. But if you have a patient who comes in with May Thurner, complaining of left leg swelling, back pain, some premenstrual problems that always kind of feels like she's having her period, what are you going to do first? Are you going to put an iliac stent in if she has an iliac compression and you see a venogram that's abnormal? Or are you going to embolize her dilated ovarian vein? So I want to share a concept with you. This is the front door, the iliac vein. And this is the back door, the gonadal vein that goes up to the renal vein for outflow. So when this is closed, the flow comes into the pelvis and goes up the ovarian vein and into the IVC. So if you close both, the patient's going to have a lot of problems. So you have to decide which one is best to start with. And we have all been trying to keep record of this, haven't we, for years? And in our experience, we think that about 87% of the patients do better, get better with their symptoms, including their leg, with an iliac stent. And then some of the patients, like 1 out of 10, will still have those symptoms associated with pelvic congestion syndrome, like premenstrual pain and left flank pain. And then we will go investigating the left renal. And if the left renal is compromised, it was kind of looking like we would stent it. And some people have stented and some people have had good results and some people have had disastrous results because the stents will embolize. So there are people in the country who advocate surgery for that. But anyway, I hope that here's a case of a woman. We did do stents years ago for IVC iliac obstruction, and I didn't take care of her congestion syndrome until recently, because now her stents have stayed open for like 15 years. So now she has both front door and back door issues, and we know that her legs are staying open. So I'm out of time, and I just want to thank you very much for your attention. I can tell that I hope I said some things that will stick with you for a long time. Oh, thank you.
Thank you, Dr. Thorpe. There was very good talk on superficial and deep venous problems. Now, Dr. Matthews, Jay Matthews, is going to come up and speak a bit on pulmonary embolism and deep venous thrombosis.
All right, back again. So probably in the interest of time, I might skip DVT. Dr. Thorpe obviously did touch on that a little bit too as well. These are my disclosures. They haven't changed since this morning. With regards to PE, systemic thrombolysis has been associated with lower mortality rates, yet we really haven't made any major change with regards to the overall mortality in PE2, which remains between 25 to 30%. Now, CDT does seem to relieve RV strain faster than anticoagulation alone, but also carries bleeding risk. And there's a number of trials that are currently in progress that are going to be prospectively looking at catheter-based aspiration thrombectomy technologies. Yet, the efficacy of this in comparison to anticoagulation alone is still really unknown. When we're looking at these patients too, the population that we're primarily looking at treating is that submassive and massive PE with interventional therapies. Minor non-massive PE, they seem to do pretty well with anticoagulation alone. Those are the patients that typically would treat with DOACs and whatnot too, and they can be largely discharged as well too. But these patients, you want to really tease them out a little bit too, especially kind of the lower risk submassive patients. Many times when you walk them, do a 6-minute walk test, you'll see that they're actually quite symptomatic, and these patients may potentially benefit from some more aggressive type therapies. But the patient with a submassive PE, they're going to have RV dysfunction. You may see that as evidenced by an enlargement of the RV relative to the LV on CT or echo. You may have myocardial necrosis with elevated troponins, elevated pro-BNP. But these patients are not like the massive patients who may have low blood pressure. They may require inotrost, may have severe bradycardia or profound tachycardia and symptoms of shock as well too. So that's a different population altogether. And the reason why I show this, you've seen the spiral many, many times, but it's very important to understand that as you wait, this spiral continues, and you really want to try to get to these patients before they get into the point where they have decreased cardiac output and go into frank cardiogenic shock, because their mortality is much higher at that point. So the timing of intervention is really unclear, and it hasn't really been proven yet, because if you talk to 10 different PE operators, they'll give you 10 different answers. Many of us think that early intervention helps relieve these symptoms and potentially gets the patients out in a safer fashion, but really hasn't been proven yet in terms of timing. And then if you do, what we do know though is that patients with very large RVs in stepwise fashion, the larger the RV is relative to the LV, there's higher mortality associated with that too. And this mortality is upwards of 60% at 3 months. And these patients could be hemodynamically stable, but if you have a huge RV, think about this specifically, these are the patients that are going to have highest mortality. So this is a big giant slide with a lot of the trials that have been available as well too out there. So if we look at Extract P, one of the first studies looking at aspiration thrombectomy, FLAIR was done with the FlowTriever device from an RE Medical, and the Seattle 2 was with the ECOS, and that's a CDT thrombolytics trial. And you can see that in these trials as well too, all did show improvement in the RV to LV ratio. But you can see that major bleeding was increased primarily in the thrombolytics trial. And this is driven by access site related bleeding, not really intracranial hemorrhage. Timing is interesting because in general, the mechanical thrombectomy trials were able to accomplish what they needed to do in a short amount of time in comparison to thrombolytics trials where you were talking about a prolonged duration. Now in the more modern era, we have several other studies that have come forth. We have the FLASH registry, which was a large number of patients, 788 patients. Again, demonstrating efficacy at 48 hours. Again, this is not randomized data, but in general, they did show, again, overall low procedure time and very good outcomes. FLAME was an interesting study looking at high-risk PE, again, non-randomized, but, really the first study looking at high-risk patients. As expected, these patients are going to be sicker in general because of high-risk population. These are patients that are potentially in shock, and they had a higher adverse event rate, around 30%. 19% treatment related. Major bleeding was higher. Again, a lot of this was access site related. Overall smaller N, so the complications are potentially a bit higher. But overall in-hospital mortality is relatively low. and their length of stay was low. So this, showed feasibility for mechanical thrombectomy in a high-risk PE population, a patient population that previously was just not treated or given thrombolytics. Rescue is a CDT trial. This is using thrombolytics, and again, show improvement in RV to LV ratio, low overall adverse event rate, very low rates of bleeding because they use a very small amount of thrombolytic, and then did do a 5-hour infusion afterwards too. And again, it shows that there still may be a role for thrombolytic therapy in this patient population. So what are the upcoming trials? We've got HI-PYTHO, which compares CDT versus anticoagulation. And then a number of mechanical thrombectomy versus anticoagulation or CDD trials. We have Peerless and Peerless 2 with FlowTriever, Storm, which was with the Indigo Flash device, and also a Lightning 12. And then P-TRACK, which is an NIH-funded study looking at mechanical thrombectomy or CDT versus anticoagulation. And hopefully these trials and our CTs will give us better guidance to change the guidelines and give you some understanding of whether or not these technologies are in fact superior to anticoagulation alone. We believe it. We think it's true, but we need to prove it. And unfortunately, the studies largely have been single-arm studies that have not really shown us this. So when you talk about a PERT pathway, this is important for your hospitals if you're going to be interested in this too, kind of having some type of algorithm for your hospital staff or your emergency departments to be able to follow and ultimately have a team approach to doing this. You can have the vascular interventionalists, radiologists, intensivists, your critical care physicians, and a number of other players as well too. And your PE program can be as big or as small as you want it to be. Ultimately, have a way of actually treating these patients. And then device algorithms. These are going to be specific to your institutions and also your experience as well too. You may choose different devices. And I want to just point out for the fact that we used to say that mechanical thrombectomy is king right now too, but some of these high risk patients, CDT actually still does work. And so it may be an option for these patients with really big RVs that maybe these patients do benefit from small catheters with license. And again, we need to prove that to show that that actually works. So there are a number of PE devices out there too. I'm not going to go through all of these. I talked about some of these things earlier in the arterial talk, but ECOS, which is acoustic pulse therapy, has been around for a long time and was the mainstay of therapy for many years. Prior to that, just Craig McNamara catheters or pigtails infusing TPA. And then you have the option to do multiple zones as well too. The Bashir catheter, which is another form of catheterectomy thrombolysis with a mechanical component as well too, because you have these times that expand out. Again, you can infuse thrombolytics locally and also in an infusion fashion as well too. A manual aspiration with fragmentation, you have the FlowTriever device and the Triever 16, 20, and 24 Flex, which are large bore. Now also you have the ability to return blood as well through a filter, which is the FlowSaver device. AlphaVac, also large bore embolectomy with a very complicated but fancy manual aspiration syringe. And then the powered aspiration devices. And most of these, other than Indigo, are investigational. JEDI has yet to do their IDE trial. AngioVac, again, is not actively being studied for PE applications, but has been used before. And there are a number of pre-market devices as well too. And as mentioned before too, the Flash device as well too, which is a modification. You guys had a chance to see this in the back there. This is a dual clot detection algorithm system for both pressure and flow differential to potentially save on blood loss, while at the same time maximizing orifice area under continuous aspiration. I'm going to show a quick case here as well too. This is a patient, 92 years old, massive PA pressures are quite high, heart rate is very high. She does have normal tension, but this is a patient whose RV is quite big and high risk for decompensation, especially in a nonagenarian. And you can see the CT scan shows a large saddle PE, and on the left here too, you can see that kind of coming across here as well. So moving forward, you can see that this initial picture shows a large clot burden in the left main PA. I went up with the Flash device into, and after this, you can see that after just one run, and this run lasted just a few seconds, we had a rapid resolution of the clot burden on the left side. Flip over to the right side, you can see this lucency there, and that's the saddle that's sitting right there. It's kind of hard to see, but then after that, just turning it on, you can see that we had resolution of this. And this device, navigating within the pulmonary arteries, you can use it without a wire. The tip is very traumatic, and so it's a kind of nice option. And again, there are multiple devices out there that you can use for these applications, large bore devices that are quite effective, like the FlowTriever and the AlphaVac and whatnot too. So it's whatever device you guys are most comfortable with. In this situation, you can see that the PA pressure dropped pretty dramatically. Patients who have high PA pressures greater than 70 most likely have underlying pre-existing pulmonary hypertension. So you have to be really careful in them because they don't really do well with large bore catheters, especially small patients, especially small women. These are the ones that will have decrease in the RV function and have decompensation. So you just have to be very cognizant of that. Her heart rate did drop. She was normotensive still, and her oxygen saturation improved. Overall case time was about 5 minutes or so. So this is quite nice to be able to do it in a rapid fashion. So it makes the case for mechanical thrombectomy. If we can offer rapid resolution of these symptoms, potentially gives an opportunity to get these patients out of the hospital faster and potentially reduce their mortality. But again, we still do need to prove this in a clinical trial. So I'm going to stop there in the interest of time and leave the DVT talk for another time.
Jay, thank you very much. That was an excellent talk on pulmonary embolism. Next, good for the mind, Dr. Wayne Zhang is going to speak on endovascular repair of visceral artery aneurysms.
Thank you, Bob. Good afternoon. Thank you for still being here and stay awake. Okay. Stuck. Okay. Oh, so let's just go back to the end. So to yeah, this.
Can we go back to the?
Can we go back to the front? Yeah. Excuse me. Let's just do it again. Okay, here we go. Yeah. Oh, all right. I have nothing to disclose. Visceral artery aneurysm actually is relatively uncommon. So account for 5% intra-abdominal aneurysms. So most patients actually are asymptomatic, but if it's ruptured, death rate can be as high as 70%. So majority of the patients have aneurysm from a splenic artery and followed by renal and hepatic arteries. So one of my patients, you can see multiple visceral artery aneurysms. So how do we manage those patients to avoid rupture risk and avoid unnecessary treatment, but minimize the risk of rupture? So here's recommendations from Society for Vascular Surgery, and this is a busy slide. I like to kind of summarize it to help you to remember it easier. So for splenic and renal arteries, if the aneurysm greater than 3 centimeters, then we should treat. And after that, since celiac and hepatic arteries, 2 centimeters still cutoff numbers. Previously, we used a 2 centimeter for almost all the aneurysms, but now we changed. For the aneurysms from the artery supplies the intestine, we go more aggressively. Any size of the aneurysm diagnosed should be treated, but this is controversial and debatable. So we have been following up patients with SMA aneurysm for like less than 2 centimeters safely. I have never seen any patient that ruptured SMA aneurysm less than 2 centimeters. Have you, any of you seen that? No, unless it's like a pseudoaneurysm from trauma or infection, something like that. But otherwise, you can safely follow SMA trunk aneurysm less than 2 centimeters. So how do we approach for that? How do we treat this? This is from a Society for Vascular Surgery and recommend in general if anatomically approachable. So we should treat this aneurysm with endovascular techniques. I'd like to share a couple of cases with you and discuss the techniques we can use. So the first patient, 62 years old male, 4.8 centimeters splenic artery aneurysm. So CT pre-op look like this. How are we going to treat this? We can do open surgery to resect it, but it's not going to be easy. So large aneurysm with like a tortured artery, like cluster over there, and the pancreas is sit next to it. So if you try to dissect out, you can cause damage to pancreas. A pancreatic leak is going to be a disaster. So for endovascular treatment, if a patient have good proximal and distal landing zone, of course, cover stent is probably best choice. But for this patient, we took the patient to OR, did an angiogram, different, angles and projections, still cannot figure out which one is the distal, outflow landing zone vessel. So try the wire probe is always coiled in there. Based on these findings, we just decide to pack the aneurysm sac and also the drop-off cups, coils to the distal vessels and tightly pack the feeding artery. So that's follow up a few years and the patient still doing very well. So is this a acceptable approach? You can completely occlude the splenic artery. Yes, that's still from a society's guideline. We do not have to routinely preserve or do revascularization of the splenic artery. You can safely coil it because the spleen still gets some blood supply from short gastric. But you have to remember, if you decide to occlude the splenic artery, you have to vaccinate the patient. If selective case, you give the vaccination 2 weeks before, but if it's emergent for ruptured, now you have to give for 2 weeks, within 2 weeks after the procedure. Okay, case 2. 35 years old female, 2.6 centimeter right renal artery aneurysm. So not even 3 yet. Should we treat this? Yes, it's like a childbearing young lady, right? So it's indicated. So, and you have to kind of carefully evaluate and see how many branches from this. So you can see it's not only 1 or 2 branches, it's like at the traffication. So we have to be careful. If you coil it, may occlude the outflow artery. So do open surgery, again, it's a very, like a big procedure. You make a long incision, you take a kidney out, flush out the blood, put the kidney on the ice and transect the artery. You can leave the ureter intact, but you still need to do a very complex open repair and place the kidney back. So we did this with the endovascular approach. I used the body wire technique. You can see there's 2 wires here, and the one got into a distal vessel, just in case if the coil migrate, I still got access to like a bare metal stand to save that the big branch. So the second wire and catheter in the sac of the aneurysm, I did this with the retrievable coils. And after that, I did an angiogram and showed everything looks okay. And then I pull out the wires. You can see this follow-up and both, the right kidney is perfused well. Okay, that's a coil embolization technique. So case number 3, 71 years old male, left flank pain, symptomatic, 3.1 centimeter left renal artery aneurysm. It's lobular. It's not just one component. Patient is high risk, 71 years old, and the plus patient refused to have open surgery. So what are we going to do about this? Carefully evaluate the images and make your plans. We have different ways to treat this, right? So we discuss with the patient and, do a coil may not completely kind of seal the lobular aneurysm. So I think that's a big branch. You go into the majority of the parenchyma to go the lower pole. We decide to kind of put a cover stand in that, sacrifice the upper pole small branch. So that's the intraoperative angio. We pass the cover stand there and deployed, and you can see that the aneurysm was completely excluded. And the follow-up CT scan, the stent's open, and you can see the upper part of the kidney a little bit smaller. It's atrophic, but the lower part is still normal size. The patient's renal function was in normal limit. So this is a cover stent technique we can use to treat aneurysm. Case number 4, 55 years old male, 2.8 centimeter fusiform celiac aneurysm. It's above 2, right? For celiac and hepatic, also indicated for treatment. And now, how do we approach this one? We do a cover stent. Do we have enough proximal landing zone for that? Probably not, right? So, and if we do a coil embolization, we may have to sacrifice the splenic or hepatic artery. That's what I did. We put a bare metal stand in there and a second wire and catheter in sac the in the sac of the aneurysm. We deploy the bare metal stent first and the coil the sac. And this will keep the coil in place, it won't go anywhere. And at the same time, you can see this, and we can exclude or seal the aneurysm and still keep the blood flow into the important organs. This is called stent assisted coil embolization. So tips and tricks to treat this visceral artery aneurysms, preoperative planning is very, very important. You need to know the size, the shapes, and location, the length and the width of the neck, landing zone, proximal and the distal. And you need to know which branches you may have to sacrifice. If that happened, and what could happen, you got to have a backup plan for that. Okay, like this patient. And the access, most of the patient we can do from a femoral artery access, but if you have a target vessel with a sharp angle to the aorta, you may want to go from above, like this patient. It's easier to go from above to get into a celiac artery. Okay. So got to know your blood supplies and the coils, the catheters, steerable sheaths sometimes is very useful, and the bare metal and the cover stand, and how to use it. And during surgery, there's a teamwork, right? So keep communicating with your assistant, anesthesiologist, nurse, and the radiology tech. Don't let your assistant or a junior, resident partner pull out the wire before you finish the case. Okay. All right, we talk about the available techniques, A, B, D, E, but I never use the C. Have you guys use this for direct puncture? I use this for AVM or pseudoaneurysm, femoral pseudoaneurysm, if the patient have a long, narrow neck. But for visceral artery aneurysm, I do not recommend. If you really want to do it, I recommend you to use a balloon, temporarily occluded neck, and inject the glue in that and do a completion angio if okay, and you just finish. But I really do not recommend that. Thank you so much.
Thank you very much, Dr. Zhang. That was an excellent presentation on visceral aneurysm closure. Next is Dr. Brett Wickman again. He's going to speak on prostate, uterine, and geniculate artery embolization. Thank you.
Thank you, Bob. Challenging task to talk about 3 different subjects that probably would take 30 minutes each to give adequate time to, but nonetheless, I will talk a little bit about both or all 3 of these, some quick indications and a little bit about technique. My disclosures here with nothing relevant to this talk. So let's jump right in with uterine fibroids. As most people know, these are non-cancerous, very rich in blood supply tumors that are estrogen dependent, and they're benign smooth muscle tumors. Most commonly present in the 30 to 40 year old age group. More common in African-American versus other races and ethnicities. And there are about 600,000 hysterectomies in the United States performed per year for symptomatic uterine fibroids. You can see that they grow anywhere within the uterus. They can grow on the serosal surface, they can grow in the intramural portion, and they can grow in the submucosal area. Those are the ones that typically end up causing significant menstrual bleeding. The ones that are on the serosal surface are the ones that typically, like you can see in this shot during a laparoscopy, they produce mass effect on the colon and the bladder. Symptoms associated with fibroids are those really grouped into the dysmenorrhea or heavy menstrual bleeding category, and then the bulk symptoms. So dysmenorrhea is defined by American College of Obstetrics and Gynecology as painful heavy bleeding greater than 7 days. Frequently requires changing of pads or tampons. Associated with passing of clots, again, a lot of cramping. And to the extent that a lot of these women that come to see me are really afraid or concerned about going out in public or going to work because of the risk of bleeding. Differential diagnosis you can see here. The bulk symptoms, again, are usually due to mass effect from the size of these fibroids that can get quite large. They can push on the bladder, causing urinary frequency. They can cause constipation and feelings of pelvic fullness and bloating. Treatment options, you can see listed here. I won't go through them just in the interest of time, but there are medical therapies that are kind of anti-estrogen approach. And then there are surgical options ranging from myomectomy to high frequency ultrasound therapies, myomectomies, hysterectomies of all types associated with either a vaginal or abdominal approach or laparoscopically assisted, and so on. And then there's also uterine artery embolization. Most of these patients that I see we will already have an ultrasound on for the initial diagnosis, but MRI really is best for working these patients up because it can give you a better sense of the size and the anatomy, as well as determine whether or not these are the degree of vascularity. A lot of these fibroids, if they grow too fast, they'll actually outgrow their own blood supply. So if they're starting to degenerate already, then perhaps uterine artery embolization may not provide a lot of value. This is an outpatient procedure. This has evolved significantly since we started doing these, and this procedure actually developed as a pre-procedural, a pre-hysterectomy procedure prior to hysterectomy. This is way back in the 80s, and actually what they found was as they waited for these women to recover from the procedure, their menstrual period was getting significantly shortened, and so rather than subjecting them to a hysterectomy, this evolved into a primary treatment. Associated with significantly less morbidity versus hysterectomy, as you could imagine. What I tell patients is that for every week that you would be out of work with a hysterectomy, this is a day. So if it's 4 to 6 weeks, typically for a hysterectomy, this is 4 to 6 days from a uterine artery embolization. 0% transfusion, never seen a transfusion related to uterine artery embolization, and it's quite significant in patients getting a hysterectomy. About 90% clinically effective in terms of taking patients that have maybe a 7 or a 9 day menstrual period, and making it much more shorter, more manageable, and decreasing urinary symptoms as well. How do we do this? Well, you can do it from a radial or femoral approach. I would say that most people still do it from a femoral approach, but there's some proponents of a radial approach. Involves either a 4 French or a 5 French base catheter, and then I would say probably 90% of the time I use a microcatheter coaxially through the base catheter and into uterine artery. You want to get into the transverse or the horizontal portion of the uterine artery, past a little branch that kind of dives down towards the cervix and vagina. This is always done with particulate embolization. We don't use coils for this, and it ranges usually from 500 to 700 micron particles, and then following that with 700 to 900 micron particles, taking it to stasis or near complete stasis. Some people use intraarterial lidocaine afterwards, and some people for pain control use a superior hypogastric nerve block pre-procedurally to manage the post-procedural pain. Just a couple select images here. Again, uterine fibers are very rich in blood supply, so they get very hypervascular. These are pre and post embolization images. Again, this is kind of the typical kind of claw type appearance of a hypervascular tumor, whether it's in the uterus or in the liver or in the kidney for that matter. And you can see that there's no flow post embolization. Additional images again showing the middle panel showing the significant mass effect that these hypervascular tumors can have on the urinary bladder. You can see the bladder compressed here towards the bottom of the screen. And then post embolization, again, no significant flow into the uterus. Potential complications associated with uterine artery embolization are fortunately not really common. Most of these people will have pain and cramping afterwards. It's usually worse within the first few hours of the procedure. I tell patients this is just like if you go in to get your gallbladder taken out or you get your cervical spine fused, there's going to be a recovery period, even though you only get a tiny little incision that's about 2 millimeters. It's still sometimes hard to convince them that they're going to have ischemic type pain, which can be pretty significant after a procedure like this. You'll get intermittent cramping, or they will get intermittent cramping over the next couple of days. About 10 to 15% of patients will get what we call a post-embolization syndrome, which is basically kind of death of a big solid tumor that produces this kind of systemic reaction and can result in flu-like symptoms, myalgias, muscle aches, things like that. Women will get spotting in about 10% of the time, and premature menopause is fortunately very uncommon, about 1 to 2%, frequently thought to be due to anastomoses between the uterine artery and the ovarian artery. These are pre and post MR images showing the central necrosis following embolization compared to the preoperative MRI showing a significant vascular tumor. What about geniculate artery embolization and osteoarthritis? So this is a huge patient population affected by degenerative joint disease, particularly in the knees, very common with advancing age. You can see the symptoms listed here. This can be pretty debilitating, as a lot of us know. Treatment includes injection therapy, Synvisc, non-steroidals, heavy-duty pain medicine, and then ultimately total knee arthroplasty. Genicular artery embolization has come into investigation. I would stress the point that this is still investigational. This is not really a ready for prime time procedure yet. But the idea behind this is that there is hyperemic synovium as a result of advanced degenerative change. Far and away, the more common indication for genicular artery embolization is recurrent hemarthrosis following total knee arthroplasty. But there's been some early experience, particularly in Japan, and this is some published data from way back in 2014 and 2017, looking at 72 patients. Almost 90% of these patients had significant reduction in their pain out to 6 months, and some even out to 2 years. Most of these patients that were on either opioids or non-steroidal therapy were able to come off of those medicines, and there were no major complications. This is a little bit more recent study. A few years later, looked at a retrospective review, and then what they did is they compared patients that had mild to moderate osteoarthritis